Hi everyone, very good evening to each one of you. Myself, Dr. Vaibhav Jain, and today we will be learning about the dermatology rapid revision. Right? We will be learning about all the important things. I would be going a little bit faster over here. Right? We have discussed all the things in great details, so I will be going a little bit faster. What is going to be the scheme of class? We are going to start it off with the basics of dermatology, skin appendages, papulosquamous disorders, your infections, different kind of infections like bacterial, viral, fungal, parasitic infections. We will discuss about the STDs, your genital ulcers, right? Then we will discuss about the vesico-bullous disorders, like we have got vesicles, we have got bulla, right? We will discuss about the pigmentary disorder, where we are going to focus specifically on hypo and hyperpigmentation disorder, and ultimately in miscellaneous topics we are going to learn about the genodermatosis, right, and certain cancers and certain questions which has been asked previously in your examination. We are going to discuss about that, है ना? So without any further delay, let's get started. Please let me know if I'm clearly audible and visible. No issues with the audio visuals. Good evening, Pradesh Shah, Raj. Good evening. Let me know if you can hear me and see me well. No issues with the audio video. All right. So without any further delay, let's get started, guys. We will be discussing about the basics. What are the basics we have got? We have got the anatomy of the skin, right? Anatomy of the skin. Skin is the largest organ of the body, beta. Hai na? What is the largest organ of the body? This is going to be skin, right? For the next 3.5 to 4 hours, we will be focusing specifically on all the important high yield questions. Hai na? What are important questions? I've just tried to incorporate it over here. This is going to be sufficient for your FMG, for your NEET PG, and INI-SET examination also, right? I've tried to keep all the questions here, right? So most of the important information will be here itself. Just be with me till the end of the session. Just try to be interactive and we will go through this, right? So what is going to be the weight of the skin? That is going to be 4 to 5 kg beta. What is going to be the weight of the skin? This is going to be 4 to 5 kg, right? Eyelid will be the thinnest part and thickest part will be the palm and soles. Palm and soles will be having the thickest part. What is the area? It would be covering 1.72 meters square, right? That is going to be the area the skin will be covering, right? Then we will discuss about the skin, different layers of skin. Before that, you should understand skin is also known as what, beta? Skin का दूसरा नाम क्या होता है? Dermis, right? Something about dermis is known as epidermis. Something about the dermis will be epidermis. Something below the dermis will be hypodermis, beta. Hypodermis or subcutaneous, right? Subcutaneous. This is also known as subcutaneous hypodermis, right? And between epidermis and dermis there will be a junction. This is known as dermoepidermal junction, also known as basement membrane zone. Right? Then we have got epidermis. This epidermis is further divided into 5 special layers. What is the mnemonic we have remembered always? This is going to be come, let's, grab some burger, right? So this is the mnemonic for layers of epidermis. So we have got layer को क्या बोलते हैं बेटा? Layer को बोलते हैं stratum. We call it stratum. So we have got stratum corneum, we have got stratum lucidium, we have got stratum granulosum, we have got stratum spinosum, we have got stratum basal. These are the 5 layers, important layers that we are having, right? Remember beta, the spinosum and basal together are known as what? Which layer? They are known as Malpighian layer. They are together known as Malpighian layer, and this Malpighian layer is responsible for the synthesis of what? Exam question, vitamin D synthesis. Vitamin D synthesis is going to take place in which layer? This is going to be, your answer is going to be what, beta? Answer is going to be Malpighian layer. Malpighian layer is what? Spinosum and basal together are known as what? Malpighian layer. Both of them are together known as Malpighian layer. ठीक है? ये stratum corneum हो गया. Then we have got lucidium. Then we have got granulosum. Can you appreciate these granules, right? Then we have got spinosum. ये spine जैसी structures दिख रही है. This is spinosum. And lastly we have got what? These are the basal. These are the basal that we are having, right? So this is going to be the epidermis. याद रखना बेटा, this basal sometimes they will also write you in certain questions, you will be finding what, instead of basal they will be writing you germinativum. It is also considered as germinativum. Why we call it germinativum? Because all the cells are arising from this particular one, right? This is also known as germinativum, right? Remember, this superficial layer stratum corneum is going to be what? It is going to be devoid of nucleus. Can you appreciate? There will be no nucleus. There will be no nucleus over here. क्या इसके अंदर nucleus है? नहीं है. If there is no nucleus, this is the layer which is going to be devoid of nucleus, right? This lucidium is not going to be present everywhere. It is going to be present in the palm and soles, okay? All right, so now we will discuss about the cells of epidermis. How many cells do we have in the epidermis? Okay, we have got how many layers, beta, in the skin? The outermost layer is going to be epidermis. Then you have this dermoepidermal junction. This particular one is dermoepidermal junction, also known as basement membrane zone. Then you have got what? Dermis. And then you have got what? Subcutaneous tissues, right? And then you have got what? Muscles. Then you have got what? Then we have got what? Muscles. You know, at this point of time you should be specifically focusing, explorer, you should be specifically focusing on what? On the points which you have already marked, है ना? Exam आ गए, now you should be specifically focusing on what you have prepared, right? That is what is going to get you through, है ना? इधर उधर content देखने से nothing is going to happen, है ना? Whatever you have studied throughout your journey, right? In the 5 months, 6 months, just focus on that particular thing, okay, bachcho? Okay, so we have got what? We have got stratum corneum, which is devoid of nucleus, right? This is going to be the thing. Then we have got cells in the epidermis. How many cells? These cells are known as keratinocytes and non-keratinocytes. बेटा दो तरीके के cells होंगे, keratinocytes होंगे, non-keratinocytes होंगे. Keratinocytes are going to be present in all the layers. Keratinocytes are the most abundant cells. They are going to be present in all the layers, है ना? ये ऐसे keratinocytes will be present in all the layers. These are the most abundant cells that we are having, है ना? I'm just doing a rapid revision. I'll try to mark most important things, right? बहुत ज़्यादा डिटेल में नहीं पढ़ेंगे. We are going to do it superficially, है ना? हम लोग ऊपर से पढ़ेंगे, because I have explained you all those things earlier, right? अगर कहीं पर भी इशू है, if you are finding any difficulties, do let me know, है ना? I'll explain it, right? So we have got keratinocytes. दो तरीके के cells होंगे बेटा एपिडर्मिस में. We have got keratinocytes, we have got non-keratinocytes. So keratinocytes are going to be 95% and they are the most abundant cells and they are present in all the layers. These are the important things, right? What is the function of keratinocytes? Protection. It is responsible for the protection. It is responsible for the strength, and vitamin D synthesis is also going to be helpful. This is going to be keratinocytes. Okay, important question they will be asking you, from where you get this keratinocytes? कहाँ से आता है keratinocytes? Keratinocytes you will be getting from the ectoderm, beta. Ectoderm, right? Ectoderm is the site from where you will be getting the keratinocyte. This is what is important. Second cell that we have got, this is your first one. These are keratinocytes, right? First one cell is keratinocyte. Second cell that we have got is going to be your melanocytes, right? This melanocytes are going to secrete what, beta? ये जो cell दिख रहा है dendritic cell that you can appreciate, this is known as melanocyte, है ना? इसको melanocyte बोलते हैं. और इसमें से जो चीज़ें बाहर निकलती है उनको बोलते हैं melanosomes. These are the melanosomes we are having, and from this melanosomes they are going to release what? Pigments. These are your keratinocytes, है ना? तो ये melanosomes क्या करेगा बेटा? ये pigments छोड़ेगा. कौन से pigment होते हैं melanocytes से? कौन सा कलर आएगा बेटा? Melanocyte is going to release melanosomes, and this melanosome is going to release what? Melanin. Remember, the sequence is important, right? Melanocytes are the cells which are going to secrete melanosomes, and this melanosome is going to secrete melanin, and this melanin is responsible for two important functions. One is the color, second is the UV protection. This is your previous year question. Okay, they have asked you which of the following cell is responsible for the UV protection. Remember beta, which cell is going to be responsible for the UV protection? This is going to be your melanocyte, है ना? तो melanin का function क्या होता है? आपको UV से protect करना. You are applying sunscreens to protect yourself from the UV, right? And that is the function of the melanin, है ना? तो melanin जिनमें ज़्यादा है उनमें basically this is going to have what, these are at a low risk of UV damage, है ना, UV की वजह से उनमें कम डैमेज होगा. This melanin is coming from the precursor, that is the tyrosine. Tyrosine is also going to make what, याद करो फिजियो, राइट, ओके, टायरोसिन फिजियो फार्मा में पड़ा होगा. इट इज ऑल्सो गोइंग टू मेक T3 T4. इट इज ऑल्सो गोइंग टू मेक एपिनेफ्रिन, नोरेपिनेफ्रिन एंड डोपामिन, राइट. दीज आर द प्रीकर्सर, दीज आर द प्रीकर्सर ऑफ व्हाट, मेलेनिन. मेलेनिन से क्या बनेगा, T3 T4, एपिनेफ्रिन, नोरेपिनेफ्रिन, डोपामिन. इट इज ऑल्सो गोइंग टू मेक मेलेनिन, राइट. व्हाट काइंड ऑफ मेलेनिन डू वी हैव, कितने तरीके का मेलेनिन होता है बेटा, दो तरीके का, यू मेलेनिन and pheomelanin. Eumelanin, remember, is going to give you black color, whereas pheomelanin is going to give you which color beta, it is going to be responsible for the white color, है ना. So white or yellow color is going to be, this is because of pheomelanin, है ना, थोड़ा light color will be there, right, and black and brown is due to eumelanin, right. So this is the function of melanin, right. This melanocytes are going to be derived from where, these are derived from the न्यूरल क्रेस्ट सेल बेटा. न्यूरल क्रेस्ट सेल एनाटॉमी एम्ब्रियोलॉजी में पढ़ा होगा. न्यूरल क्रेस्ट सेल्स, दे आर गोइंग टू रिलीज व्हाट, दे आर गोइंग टू रिलीज these cells, है ना. they are going to come, they are going to form which cells, melanocytes. Now one melanocyte is going to give color to how many keratinocytes, this is your again previous year exam question. One melanocyte is going to give you color to the 36 melanocytes, है ना, sorry 36 keratinocytes. these are the keratinocytes. ये एक मेलेनोसाइट कितने लोगों को कलर देगा, 36 केरेटिन सेल्स विल बी गिवन कलर बिकॉज ऑफ दिस सिंगल मेलेनोसाइट, है ना. एक मेलेनोसाइट से 36 केरेटिनोसाइट को कलर मिलेगा. दिस इज द बेसिक थिंग वी आर हैविंग, राइट. सो दिस इज अबाउट द melanocyte that we are having. Third one we have got is the Langerhans cells beta. Third cells that we have got is the Langerhans cells. They are the macrophages of the skin, they are the macrophages of the skin, and they are the antigen presenting cells of the skin beta. Antigen presenting cells of the skin. Antigen presenting cells of the liver is known as what beta, they are maximally present in stratum spinosum. सबसे ज्यादा कहाँ होते हैं ये, they are going to be maximally present in stratum spinosum. Langerhans cells से कौन सा क्वेश्चन आता है, they are going to ask you about this particular structure. What is this particular structure that you are having in front of you? Can you appreciate this tennis racket like appearance we are having? And here these are the granules are known as which granules? These granules are known as Birbag granules. So we have got Birbag granules with tennis racket appearance in the cases of Langerhans cells. Langerhans cells are going to have what? Tennis racket appearance with which granules? With the Birbag granules beta. कौन से granules होंगे? Birbag granules होंगे. And they are going to be derived from what? They are going to be derived from the bone marrow बेटा. Bone marrow से आएंगे. These are going to be the Langerhans cells. ये क्या है? ये सारे macrophages है. Macrophages कहाँ से आते हैं? Bone marrow से आते हैं ना. So they are going to be mesodermal in origin. They are going to be coming from the bone marrow. Coming from the bone marrow. Right? Then we have got what? What are the markers? इनके markers के ऊपर question आता है. What are the markers? This is your previous year question. Most important marker CD207, also known as what बेटा? इसका दूसरा नाम क्या है? Langerin. This is also known as Langerin. And another marker we are having CD1A. CD100 is S100 is also going to be there, but that is going to be non-specific one. ठीक है? Then we have got which cells? Then we have got Merkel cells. Merkel cells are the fourth cells, है ना. चार तरीके के ही cells होंगे एपिडर्मिस के अंदर बेटा. चार तरीके के cells होंगे. The fourth one that we have got is your Merkel cell. It is a type 1 slow adapting touch receptor, and they are going to be present in the epidermis. They are the touch receptor that we are having. They are going to be present in the epidermis, and they are derived from where? They are derived from the ectoderm. They are going to be ectodermal in origin. इनका origin कैसा होगा बेटा? Ectodermal in origin. So what are the things we have studied till now? Let me just try to recap it for you. So we have got three layers in the skin. We have got dermis. Above dermis will be epidermis. Below dermis will be hypodermis. And then we have got a junction between epidermis and dermis. This is known as dermo-epidermal junction. Okay. Epidermis में कितनी layer होगी बेटा? You will be having, come let's grab some burger. These are going to be corneum, lucidium, granulosum, spinosum and basal. These are the 5 layers we have got, right? And how many cells do we have here? We have got 4 cells. कितने cells होंगे बेटा? 4 cells, है ना. ये जो सारे दिख रहे हैं, these are known as which cells? These are the keratinocytes. ये सारे क्या है बेटा? these are your keratinocytes. This one that you can appreciate, this is your dendritic cell that we are having in front of us. This is going to be melanocyte. This is going to be your melanocyte. We have got keratinocyte, we have got melanocyte, we have got Merkel cell. Can you appreciate a nerve is going through this, right? So this is going to be slow adapting touch receptor beta. ये touch receptor हो गया. और चौथा cell जो होता है, these are known as which cells? They are going to be Langerhans cells. Langerhans cells. बेटा Langerhans cells भी पढ़ते हो आप. Langerhans cells कहाँ पढ़ते हो? Where you study about Langerhans cells? These are the giant cells that you find in the TB, है ना. ये Langerhans cells है. These are your antigen presenting cells. ये एंटीजन प्रेजेंटिंग सेल्स है. और ये कहाँ प्रेजेंट होंगे Langerhans सेल्स? दे आर गोइंग टू बी मैक्सिमली प्रेजेंट इन योर स्ट्रेटम स्पाइनोसम. स्ट्रेटम स्पाइनोसम में होंगे Langerhans सेल्स. ओके बेटा. सो दीज आर द 4 सेल्स एंड 5 लेयर्स दैट वी हैव डिस्कस्ड टिल नाउ, है ना. अभी तक यही पढ़ा. अब इनमें से इंपॉर्टेंट क्वेश्चन, लेट मी जस्ट मार्क ऑल द क्वेश्चंस. ओके, तो तुम लोग हेल्प करो. फर्स्ट थिंग वी हैव गॉट केरेटिनोसाइट्स. ओरिजिन इज गोइंग टू बी एक्टोडर्मल, है ना. मेलेनोसाइट्स का ओरिजिन क्या था बेटा? मेलेनोसाइट वाज ओरिजिनेटिंग फ्रॉम विच सेल्स? यस, दे वर ओरिजिनेटिंग फ्रॉम द न्यूरल क्रेस्ट सेल्स बेटा. न्यूरल क्रेस्ट cells. First question, right? Langerhans cells are mesodermal in origin. You can also call it they are coming from the bone marrow. Bone marrow, right? And lastly we have got Merkel cell. ये तो ectodermal होते हैं. So Merkel cell, keratinocyte, ectodermal in origin. These two are important ones that you need to remember. What about the location of all these things? Location of all these things. Remember, keratinocytes are 95% present in all the layers. सभी layers में होंगे. Melanocytes we have seen present in the stratum basal. Another cell in the stratum basal is Merkel cell, है ना. You can appreciate ये Merkel cells, ये आपके keratinocytes और ये आपके Merkel cell दोनों कहाँ हैं? Stratum basal के अंदर है. These are going to be present in the stratum basal layer only, right? Then we have got what? Then we have got keratinocyte. They are present in all the layer. And Langerhans याद रखने, this is going to be present in the stratum spinosum. Stratum spinosum. What they are going to secrete? Remember, keratinocyte is going to secrete what? Keratin. And keratin can be a marker for carcinoma, है ना. हम लोग चेक कराते हैं like cytokeratin 14, right? These are the marker for carcinoma, right? Function क्या होता है keratin का? Vitamin D synthesis and protection of the skin. Keratin is going to be abundantly present in your skin, है ना. आपके hair cells में keratin होगा, skin में keratin होगा, everywhere you will be having this keratin. Second one we have got is melanocyte. This melanocyte, what is the marker for this melanocyte is important question. They are going to be what beta? They are going to be, markers are going to be what? Melane, HMB 45 and S100, right? This S100 can be positive in the Langerhans also, but this is a non-specific one. So these are the markers that you need to remember. Melane, HMB 45 and S100. This is important stuff, right? What about this function of melanocytes? This is also, they have asked this question. So they are going to secrete what beta? Melanocytes are going to secrete melanin. And melanin का क्या function होता है? UV protection. They provide the color, but apart from color, you can remember simply it is going to provide protection from the UV rays. UV rays से protect करेगा, right? Then we have got about the Langerhans cells beta. Langerhans cells are going to secrete what? They are going to secrete some granules. These are going to be your Birbag granules, है ना. कैसा appearance होता है बेटा? Birbag granules और tennis racket appearance. Tennis racket appearance, right? आप और जगह भी पढ़ते हो, study about Langerhans cells, histiocytosis or histiocytosis X will be having what? This tennis racket appearance. These are going to be the macrophages, right? They are maximally present in stratum spinosum. And the marker is going to be what beta? इनका marker होता है CD1A or CD207. This CD207 is also known as Langerin. इसका दूसरा नाम क्या है? Langerin. This is also known as Langerin, right? They are going to be the macrophages of the skin. Lastly, we have got what? Merkel cell. These are going to be ectodermal in origin. Stratum basal से निकलेंगे. Neurotransmitter they are going to secrete because they are the touch receptor. And marker is going to be CD20. CD20 is going to be the marker, right? Function क्या होता है? Function, so they are going to be your crude touch receptor. They are responsible for the crude touch, and they are going to be slow adapting receptor. They are going to be slow adapting touch receptor that we are having, right? So हम लोगों ने पढ़ लिया basics. We have got how many layers in the skin? We have got epidermis, we have got dermis, we have got hypodermis. In the skin we are going to basically discuss about what skin और skin के appendages है ना. Appendages क्या क्या होता है बेटा? Appendages will be having your hairs, your nails and your glands, right? यही सब पढ़ना है skin के बारे में. So let's try to understand about the layers, है ना. तो कौन सी layers होगी? What are the layers we are having? We have got 5 layers. These are going to be your corneum, lucidium, granulosum, spinosum and basal, right? These are the 5 layers that we are having: stratum, corneum, lucidium, granulosum, spinosum, basal, है ना. इसी को अगर मैं इधर दिखाना चाहूँ, first of all remember which layer do not have what? Which layer do not have nucleus? So nucleus will be absent in which layer beta? Stratum, corneum. इसका histopathological images they are going to give you, and they are going to ask you what? Look here, can you appreciate any blue color structure over here? That means nucleus is absent here, and if the nucleus is absent here, this is the which layer beta? This is going to be stratum corneum, है ना. याद रखना stratum corneum के अंदर क्या नहीं होता? Nucleus नहीं होता. Stratum corneum is devoid of nucleus. Then we have got lucidium. This is going to be clear cell layer that we are having. इसमें क्या होता है? Clear cell layer. Then we have got granulosum. These are going to be the granules that you can appreciate. Then we have got what? Spinosum. These are the spine like structures. ये आपस में जुड़े हुए होंगे. These are going to have some spine like structures. And then we have got stratum basal. These are the stratum basal that we are having, which is going to have 2 important cells. Melanocytes will be there, and another cell is going to be Merkel cell, है ना. Then you have got what? Which membrane? You have got basement membrane. This membrane is known as what? Then you have got the basement membrane. अब क्या आ जाता है यहाँ पर? Basement membrane will be there, and then you have what? Then you have dermis. Then you have what? Then you have got dermis here, right? तो ऊपर ही ऊपर होगा बेटा epidermis. Epidermis. This is going to be the 5 layers of epidermis that we are having. Okay. Then you have this basement membrane zone, and then you have got what? Dermis. Then you have got what? Dermis, है ना. यहाँ पर इसकी anatomy से, okay, यहाँ पर इसके एनाटमी से वी नीड टू अंडरस्टैंड वन थिंग. ओके, आई विल शेयर द पीडीएफ, राइट. इसके एनाटमी से यू नीड टू अंडरस्टैंड वन थिंग. व्हाट इज दैट वन थिंग? वी हैव गॉट 2 इंपॉर्टेंट थिंग्स हियर, राइट. सो आई एम जस्ट टेकिंग दिस पर्टिकुलर पार्ट आउट, है ना. ये वाला हिस्सा जो है मैं इसको बाहर निकाल रहा हूँ, राइट. द पार्ट ऑफ एपिडर्मिस विच इज एंटरिंग इनटू डर्मिस, दिस पार्ट इज नोन एज व्हाट बेटा? दिस इज नोन एज रेटेरिजेस. Okay, the part of epidermis which is entering into dermis is known as reteriges, and the part of dermis which is entering into epidermis. So here you will be having dermis. This is the part of dermis which is trying to enter into epidermis. This is known as dermal papilla. So we have got 2 things. This line that we can appreciate, this is known as basement membrane zone beta. इस line का क्या नाम है? This line is known as basement membrane zone, and the part of epidermis which is invaginating into dermis is known as reteriges. This is known as reteriges, and the part of dermis which is trying to enter into epidermis, this is known as dermal papilla. This is known as dermal papilla, right. You can appreciate this dermal papilla over here. These are the dermal papillas, okay. और dermal papilla में कौन से cells मिलेंगे बेटा? In dermal papilla, you will be finding Meissner's corpuscles. Meissner's corpuscle is a feature of dermal papilla, है ना. और here you will be finding in reteriges, you will be finding which cells? In reteriges, you will be finding which cells? You will be having Merkel cell. Merkel cells are going to be present in the reteriges. Meissner's corpuscle are going to be present in the dermal papilla. This is a question they are asking, right. We are not going to make this question wrong. This is going to be the thing, right. All other things are going to be same. If there is loosening or if there is desquamation of these cells, this is known as what? This is known as scaling. Scaling, scale formation, scaling is happening. What is scaling? Scaling means there will be desquamation of stratum corneum. ये scaling हो रहा है, यहाँ से stratum corneum बाहर जा रहा है. This is known as what? This is known as scaling. This is known as scaling बेटा, है ना. तो इसके anatomy important we have discussed. What is the anatomy? Another thing that you need to remember, two keratinocytes are binded together with the help of one thing. This one thing is known as what बेटा? ये दो keratinocytes आपस में कैसे जुड़ेंगे? With the help of desmosomes. With the help of desmosomes. This is known as two keratinocytes are going to bind together with the help of desmosomes बेटा, है ना? Desmosomes से जुड़ेंगे. And then these keratinocytes are going to bind to the background, to the basement membrane zone with the help of hemidesmosomes. Hemidesmosomes, right? This is going to be the basic thing that we are having, right? ये समझ में आ गया? चलो अब आगे एक एक करके we will discuss about all the layers. What are the features of all these layers? Let's try to understand this, right? So we have got the first layer. This is going to be stratum corneum. Stratum corneum is going to be devoid of nucleus. We already know this, right? It is going to be absent in which baby? In the preterm baby or very low birth weight with babies, right? If there is a preterm baby, less than 37 weeks baby, what is going to be the layer which is going to be absent? This is going to be stratum corneum will be absent. Stratum corneum will be absent beta, right? Here you will be finding what? Maximum amount of keratin will be present where? In the stratum corneum. Maximum keratin cells are going to be present in the stratum corneum. Stratum lucidium is going to be a clear cell layer beta. ये clear cell layer है, it is going to be the clear cell layer that we are having. And what are the granules you will be finding? Here you will be finding the refractile granules of alidin. Refractile granules of alidin will be present over here. This is going to be lucidium. Then we have got a stratum granulosum. Granulosum में दो तरीके के important granules will be there. You will be having keratohyaline granules. You will be having what? Membrane coating granules will be there. So two important types of granules will be there. Keratohyaline granules will be there and membrane coating granules will be there. ये keratohyaline granules क्या कराएंगे? They are going to make what? Filaggrin. Filaggrin is a what? Filaggrin is filamentous aggregating protein. It is going to keep the things together. And if there is mutation of this particular thing, you will be having a disease. This disease is known as ichthyosis vulgaris beta. Ichthyosis vulgaris, where you will be having what? Fish-like scaling will be there in the person, right? Fish-like scaling will be there, and scaling is going to be what? Desquamation of stratum corneum will be there, right? You can appreciate this fish-like scaling. This is known as ichthyosis vulgaris. This is going to be mutation in which granules? These are due to keratohyaline granules, right? Second granule we are having, these are known as odd-length bodies, these are known as lamellar bodies, these are known as membrane coating granules, and in the exam they have also written what? Centrosomes. These are also known as centrosomes, है ना? अगर इनका mutation हो गया, अगर इनका कमी हो गया, what is the use of these things? They are going to generate what? They are going to synthesize the lipid. And if there is less of a lipid, what is going to happen? You will be having dryness. You will be having dryness, and this type of dryness is known as what? This type of dryness that you are having, this is known as eczema. Eczema is nothing but the inflammation or dermatitis. This is known as what? Eczema, है ना? So this patient will be having what? This patient will be having winter eczema beta. Winter eczema, also known as astiotic eczema. Astiotic eczema. Treatment क्या करोगे? इसको itching हो रहा है उसकी वजह से. These lesions are coming. What is the treatment would you like to use here? You will give emollients to this particular patient, है ना? इस पेशेंट को लगाने के लिए लोशन दो, राइट? मॉइस्चराइजर दो, राइट? दिस इज व्हाट इज गोइंग टू हेल्प, राइट, दिस पेशेंट. और यू कैन यूज lactocalamin solution also, calamine lotions, right? You can give antihistaminics to the patient so that he won't be itching, right? So this is going to be what? This is going to be keratohyaline granules. These are going to be your membrane coating granules. Then we have got another layer. This is going to be stratum spinosum beta. अगली लेयर कौन सी है? स्पाइनोसम इज गोइंग टू बी देयर. स्पाइनोसम इज ऑल्सो नोन एज प्रिकल सेल लेयर. स्पाइन का मतलब क्या हो गया? कांटा, है ना? अकेंथ का मतलब क्या हो गया? कांटा. दिस इज गोइंग टू बी स्पाइन. दिस इज गोइंग टू बी नोन एज स्पाइन, right? So we have got prickle cell layer. This is the thickest layer that we are having. This is going to be the thickest one that we are having, and here you will be getting the maximum amount of desmosomes will be present, है ना? Maximum amount of desmosomes are going to be there, right? Maximum Langerhans cells are present in stratum spinosum. Maximum number of Langerhans cells are also going to be present where? Here in the stratum spinosum. अकेंथ का मतलब क्या होता है बेटा? अकेंथ का मतलब होता है स्पाइन लाइक सेल्स. अकेंथ मीन्स spine like cells. And if you have acanthosis, acanthosis का मतलब क्या हो जाएगा, there will be thickening, there will be thickening, there will be thickening of which layer, thickening of stratum spinosum. stratum spinosum के thickening को क्या बोलते हैं बेटा, this is known as stratum spinosum thickening is known as acanthosis nigricans. acanthosis nigricans, अगर ये black color का दिख रहा है, if you have this thickening of stratum spinosum and it is appearing black, this is known as acanthosis nigricans. कहाँ कौन से disease में दिखता है acanthosis nigricans? Yes, in which disease you will find this acanthosis nigricans? This acanthosis nigricans is a feature of which disease? You will be finding this in the diabetes. You will be finding this particular thing in the cases of diabetes बेटा, है ना. कहाँ मिलेगा ये, डायबिटीज में मिलेगा. इट इज ऑल्सो अ मार्कर फॉर इंटरनल मैलिग्नेंसी. और क्या बताएगा, इंटरनल मैलिग्नेंसी के बारे में भी बताएगा. सो दिस इज गोइंग टू बी व्हाट, दिस इज गोइंग टू बी योर acanthosis nigricans. The next layer we have got is stratum basal. stratum basal also known as germinativum. germinativum क्यों बोला, this is the lowermost layer which is going to make all the layer, lowermost layer which is going to be responsible for the formation of all other layers, है ना. सबकी सारी layers इसी से बनेगी, right. What is the epidermal turnover time? What is the epidermal turnover time? It is going to be your 52 to 75 days beta. 52 to 75 days, also known as 8 weeks, है ना. In certain questions you will be finding 8 weeks, or certain question you will be finding 56 days, right. Whatever values you are getting somewhat near, you will be marking the answer, है ना. So it can be 52 to 75 days you can mark. You can also mark in certain question you will be finding 8 weeks. Okay, in certain question you will be finding 56 days. All the answers are correct, right. This is known as epidermal turnover time, right. In psoriasis this thing is going to decrease till what, psoriasis में कितना रह जाएगा, this is going to be your 4 to 8 days, है ना. 4 से 8 दिन रह जाएगा in the cases of psoriasis, in the cases of psoriasis, right. The next thing we have got is certain disorders, है ना. We are done with the basics, anatomy of the skin, right. We have got anatomy of the skin, right. 6 days, somewhere between 4 to 8 days you have to remember, because in certain question you will be finding what the answer will be 4, है ना. In certain question there will be answer will be 8, right, and certain question answer will be 6. So you can remember 4 to 8 is going to be a better choice that you can remember, है ना. ऐसे ही यहाँ पर कुछ क्वेश्चंस में उन्होंने 8 वीक्स दे दिया, कुछ में 56 डेज दिया, कुछ में यहाँ से उन्होंने कोई रेंज दे दी. सो यू शुड बी रिमेंबरिंग अ रेंज, है ना. इन चीज़ों का कोई एग्जैक्ट वैल्यू नहीं होता है, यू नीड टू रिमेंबर अ रेंज इन बिटवीन, राइट. सो वी हैव गॉट five layers. What are those 5 layers? These are going to be corneum, lucidium, granulosum, spinosum and basal. These are the 5 layers that we are having, है ना. 4 cells we have discussed, 5 layers we have discussed, right. These are the 5 layers of epidermis. Now we will discuss about the disorders of epidermis. What are the disorders that can happen? What is hyperkeratosis? If there is thickening of stratum corneum, if there is thickening of stratum corneum, इसको बोलते हैं hyperkeratosis. What is acanthosis? Just now we have seen acanth means spine, acanth means spine, right. So if there is thickening of stratum spinosum, this is known as acanthosis. If it is giving you black color, this is known as nigricans. This is going to be your acanthosis nigricans. Acantholysis मतलब क्या हुआ, I've told you 2 keratinocytes are binded together with the help of desmosomes, है ना. ये 2 keratinocytes है, ये 1 keratinocyte, ये दूसरा keratinocyte, they are binded together with the help of what, desmosomes. If you have loss of desmosomes, what is going to happen? These cells are going to fall apart, है ना. ये दोनों सेल कहाँ चले जाएंगे, दूर दूर चले जाएंगे. इसी को क्या बोलते हो, acanthosis, acantholysis. acantholysis मतलब because of there is antibody or something. What is happening here, what is happening, these 2 cells are separated now. This is known as acantholytic cells. These are known as spine like cells, or these are known as acantholytic cells बेटा, ठीक है. ड्यू टू ब्रेक डाउन ऑफ स्ट्रेटम स्पाइनोसम, ड्यू टू डिफेक्ट इन डेस्मोसोम्स, these cells you will be finding in the, these are also known as Zenk cells. These cells you will be finding in the Zenk smear. कहाँ मिलेंगे ये cells? In the Zenk smear. Zinc smear में you are going to break the lesion, you are going to take the sample from the base, and then you are going to put it on the microscope, then you are going to put some stains, and you can see inside the microscope you will find what, these type of single cells, these are known as zinc cells. कौन सा डिजीज में पढ़े थे हम लोगों ने इस टाइप के सेल्स? Remember herpes simplex virus 1, HSV2, in HHV3, varicella में भी zinc cells मिल सकते हैं. These cells are known as zinc cells. Okay, then we have got what, spongiosis. Spongiosis का मतलब क्या होता है? If there is any accumulation of fluid in this epidermal cells, this is going to be what? This is known as spongiosis. This is known as spongiosis. This is generally seen in atopic dermatitis. आगे पढ़ेंगे what is atopic dermatitis. You will be having this spongiosis, and this is your exam question, previous year question. What is paniculitis? Remember, this paniculus is the another name for what? Hypodermis. This is the another name for hypodermis. This is the another name for subcutaneous or paniculus, right? So if there is inflammation of this hypodermis, subcutaneous or paniculus, this particular disease is known as what? इसी को हम लोग क्या बोलते हैं बेटा? इसी को बोलते हैं हम लोग पेनिकुलाइटिस. इसी को बोलते हैं पेनिकुलाइटिस. This is known as पेनिकुलाइटिस. All right. Then we have got certain disorders. What are the disorders we are having? ठीक है. Other disorders we have got. If there is presence of nucleus in the stratum corneum, we call it what? Parakeratosis. Parakeratosis is a feature of nucleus is present where? In the stratum corneum. क्या nucleus होता है stratum corneum में? Look at the histological slide. Look at the first normal slide. क्या इसके अंदर nucleus दिख रहा है? कुछ भी blue दिख रहा है? नहीं दिख रहा है. If there is no blue structure, that means there is no nucleus. And the same thing, can you appreciate anything like nucleus over here? No sir. If you are not able to see, this is which layer? This is going to be stratum corneum. This is going to be stratum corneum, है ना? And stratum corneum is devoid of nucleus normally, but if you are finding a nucleus in the stratum corneum, this is going to be the disease, right? This is going to be which disease? These are going to be your PESA. PESA is the mnemonic. What is PESA? P for psoriasis, you will be finding this nucleus. E for eczema. eczema मतलब क्या होता है? eczema मतलब dermatitis, है ना? एक तरीके का dermatitis will be there. There will be inflammation of the skin will be there. This is going to be eczema, right? Then we have got seborrheic dermatitis. क्या होता है seborrheic dermatitis? कुछ भी नहीं होता सर, dandruff होता है. What is this seborrheic dermatitis? This is nothing but your dandruff, है ना? तो seborrheic dermatitis can be there. You can have squamous cell carcinoma. It is also going to have what? Nucleus, है ना? स्ट्रेटम कॉर्नियम में न्यूक्लियस. एंड एक्टिनिक केरेटोसिस, है ना? एक्टिनिक केरेटोसिस में भी क्या हो सकता है सर? यू कैन हैव न्यूक्लियस इन द स्ट्रेटम कॉर्नियम, राइट? देन वी हैव गॉट व्हाट? देन वी हैव गॉट डिस्केरेटोसिस. सो पैसा याद रखना है. पैसा इज गोइंग टू बी द निमोनिक फॉर पैराकेरेटोसिस. पी फॉर सोरियासिस, E for eczema, S for seborrheic dermatitis, S for squamous cell carcinoma, and A for actinic keratosis, है ना? So they can ask you a question. All of the following are going to be not showing what parakeratosis except. So this is going to be the one which is going to show you what parakeratosis, beta, है ना? Then we have got the second one. This is going to be diskeratosis. Diskeratosis का मतलब क्या होता है? Dis मतलब abnormal keratinization. You will be finding in the benign diseases like Halle or diarrhea disease. You will be finding this thing in the Bowen's disease. You will be finding this thing in the squamous cell carcinoma. Malignant disease like squamous cell carcinoma. Okay, so this is going to be the thing. Acantholysis is going to be what? Separation of keratinocytes. So this is your zinc cell that we are having. Can you appreciate these cells are simple single cells that you can appreciate? These cells are known as what? These cells are known as zinc cells, and this particular thing is known as zinc smear. This particular thing is known as what? Zinc smear. So acantholysis means what is going to happen? You are going to have these two keratinocytes. They should be binded together, but they are not having the bond, and now you can identify these cells that you can appreciate. These cells are not together. These cells are known as acantholytic cells. कौन से cells बोलेंगे इनको? Acantholytic cells बोलेंगे. Okay, then we have got certain big disorders that we are having. The first one in the list is going to be your pemphigus vulgaris. Vulgaris में याद रखना, vulgaris will be having desmoglein 3. Desmoglein 3 is going to be the thing we are having in the pemphigus vulgaris. Pemphigus foliaceus, F4 first. Desmoglein 1 is going to be responsible for the foliaceous बेटा, दोनों में एक एक आ रहा है, याद रखना है, दोनों में desmoglein one is going to be there. Then we have got what, paraneoplastic pemphigus which is also going to be because of desmoplekin and plecoglobin. यहाँ देखो सब में PP आ रहा है, paraneoplastic pemphigus, desmoplekin, plecoglobin, PP याद रखना है. And diarrhea and hale is going to have association with the calcium ATPase beta. Calcium ATPase is going to be responsible. These are the 4 important diseases that you need to remember. Vulgaris में क्या होगा? Vulgaris is going to have 3. F for first, F for first, है ना? आंसर मार्क कर देना है देखते ही, first for first. This is a question they are asking you, है ना? Second thing, PP is going to be desmoplekin, plecoglobin, and diarrhea है not so important, calcium ATPase. ये दोनों याद रखने, ये दोनों नहीं भूलने, इनके ऊपर क्वेश्चन आता है, right? Then we have got certain microabscesses. We have got 2 types of microabscesses. We have got neutrophilic microabscess, lymphocytic microabscess, है ना? तो this papillary tip microabscess कहाँ मिलेगा? This is going to be found in the dermatitis herpetiformis, है ना? Dermatitis herpetiformis में मिलेगा papillary tip microabscess. I am going to ask you the same thing when we are going to discuss about this dermatitis herpetiformis. ठीक है? दूसरा होगा Munro microabscess. This Munro microabscess and this Kogo's pustule, both of them are going to be seen where? They are going to be seen in the psoriasis बेटा. दोनों कहाँ मिलेंगे? psoriasis के अंदर मिलेंगे. Munro's microabscess and Kogo's pustule, right? Potrier's microabscess is going to be seen in the mycosis fungoides बेटा. Mycosis fungoides is not a fungal infection, it is a cutaneous T cell lymphoma. It is a type of skin cancer, है ना? Potrier microabscess you will be finding in a skin cancer. ये 4 ही microabscess आपने याद रखने. This is going to be cutaneous T cell lymphoma, and remember this is going to show you epidermotropism. That means this thing is going to travel towards the skin, है ना? तो ये चीजें मिलेंगी microabscess. ये बेसिक अपन ने मोटा मोटा इसमें से क्या याद रखना है? पैराकेरेटोसिस you need to remember about this. Microabscesses are important. I'll show you the images also, है ना? ये मुनरो microabscess कहाँ दिखेगा, कोगोज पस्टुल कहाँ दिखेगा, हम लोग देखेंगे इसका इमेजेस भी. Then we have got the basement membrane zone. तो अभी तक हम लोगों ने क्या पढ़ा? एपिडर्मिस, डर्मिस और हाइपोडर्मिस. These are the 3 layers. इन दोनों के बीच में डर्मो एपिडर्मल जंक्शन होता है और बेसमेंट मेम्ब्रेन जोन होता है, right? This is the zone we are going to discuss right now. Epidermis हम लोगों ने खत्म कर लिया. 5 layers we are having in the epidermis. These are going to be, come let's grab some burger. This is going to be corneum, lucidium, granulosum, spinosum, basal. 4 cells we have seen: keratinocyte, Langerhans cells, melanocytes and Merkel cells. These are the 4 cells of epidermis. ये epidermis की कहानी खत्म है. We have also seen about the different disorders, है ना? Basic part is completed. Now we will discuss about the basement membrane zone. देखो एक first chapter है, वो थोड़ा बड़ा है. It is going to cover like some more time. Then उसके बाद में if you get to understand this particular thing, बाकी चीज़ें आसान हो जाएगी अपने लिए, है ना? बाकी चीज़ें simple है, आसान है, doable है, right? So basement membrane zone is going to be there. बेसमेंट मेम्ब्रेन जोन का फंक्शन क्या होता है बेटा? ये 2 केराटिनोसाइट्स को जोड़ने का काम तो किसका हो गया? दिस इज द वर्क ऑफ डेस्मोसोम्स. 2 केराटिनोसाइट्स आर बाइंडेड टुगेदर विद द हेल्प ऑफ डेस्मोसोम्स. नाउ these desmosomes are going to these keratinocytes are binding to the basement membrane with the help of something. सपोज ये बेसमेंट मेम्ब्रेन है, तो ये जो चीजें हैं these are known as what? These are known as hemidesmosomes. इनका नाम क्या है? These are known as hemidesmosomes. These are known as hemidesmosomes. अब एक चीज सोचो, यहाँ पर ये दोनों तो साथ में है, अगर यहाँ पर ये जगह खाली हो गई, अगर यहाँ हेमिडेस्मोसोम्स में कोई ना कोई प्रॉब्लम हो गया, तो क्या होगा? यहाँ पर एक स्पेस बन जाएगा और उस स्पेस के अंदर क्या आ जाएगा बेटा? पानी आ जाएगा और उसको बोलेंगे हम लोग कौन सी डिजीज? वी कॉल इट व्हाट? बुल्लस पैम्फिगोइड. Which disease is going to occur over here? The disease name is Bullous पैम्फिगोइड बेटा. एपिडर्मिस में क्या होता है? एपिडर्मिस में होता है पैम्फिगस. एपिडर्मिस विल इन्वॉल्व व्हाट? पैम्फिगस. यहाँ पर हम लोगों ने पढ़ा था ये पैम्फिगस इज गोइंग टू बी अ डिसऑर्डर ऑफ एपिडर्मिस. बेसमेंट मेम्ब्रेन जोन का डिसऑर्डर क्या है बेटा? This is going to be what? This is going to be bullous pemphigoid. Bullous pemphigoid is something happening in the basement membrane zone. These are the keratinocytes we are having. They are binded together with another keratinocyte with the help of desmosomes, but they are connected with the basement membrane or with the another layer with the help of what? Hemidesmosomes, beta, hemidesmosomes. And what are the hemidesmosomal proteins? We have got BPAG1, bullous pemphigoid antigen 1, bullous pemphigoid antigen 2. This is how you can remember BPAG1, BPAG2, or BP230 or BP180, collagen 7, integrin, prolactin. These are what? These are your hemidesmosomal proteins. And if you have got any disease around it, this is going to be what? This is going to be bullous pemphigoid, beta. Bullous pemphigoid. What are the disorders you can have? Disorders you can have is going to be what? Bullous pemphigoid. This is going to be the weakest layer, is going to be salt split layer that you can appreciate over here. This is going to be your lamina lucida, also known as salt split layer. This is going to be the weakest one. Disorder you can have, this is going to have what? BPAG1, BPAG2 की वजह से कौन सा disorder होगा? This is going to be bullous pemphigoid. Bullous pemphigoid is a disease of what? Epidermis or basement membrane zone, beta. It is a disease of basement membrane zone. Okay, you can also have linear IgA disease where you will be having antibody against BPAG2. BPAG2 के लिए antibody बन जाएगा IgA type of antibody, right? We have got epidermolysis, epidermolysis bullosa simplex and dystrophicanes, right? So simplex is going to be K5 and K14, keratin 5, keratin 14, and whereas this is going to be what? Collagen 7, mutation of collagen 7. So dystrophicanes में collagen 7 is going to be responsible, collagen 7 is going to be responsible, and this K5 and K14 mutation will lead to epidermodysplasia, bullosa. Dystrophicanes we can have bullosa simplex will be there, right? So these are going to be the things we are having. Then we have come to the next layer. This is going to be the last layer that we are having. This is going to be your dermis. Dermis में कितना layer होता है बेटा? Dermis में 2 layer होता है. You can appreciate here. Let me show you the diagram. We have got what? Epidermis. This epidermis will be having corneum, lucidium, granulosum. This is going to be spinosum. Then you have the basal. This is going to be your epidermis. Okay, in the basal you are having this basement membrane zone. This membrane is known as basement membrane zone. और इस basement membrane zone में जो part epidermis का नीचे आता है उसको बोलते हैं रेटे रिजेस. जो part dermis का अंदर जाने की कोशिश करता है, the part which is invaginating into the epidermis, this is known as dermal papilla. This is known as dermal papilla. This is known as rete ridges. Okay, so we have got rete ridges, we have got dermal papilla, we have got this basement membrane zone will be there. यहाँ पर जो zone होगा उसको बोलेंगे basement membrane zone will be there, right? Then we have come to the dermis part. We have got 2 cells in the dermis, 2 layers in the dermis itself, beta. Consequently, the first one is going to be your papillary dermis, another one is going to be your reticular dermis. The upper part is going to be papillary dermis, then you have the maximum, this is going to be reticular dermis, and lastly you have got what? Hypodermis. Below dermis is going to be hypodermis, also known as subcutis. तो चलो ये layers देख लेते हैं क्या होता है इस layer के अंदर. 2 layers will be there, important one. So loose and thin is going to be papillary dermis, which is comprising of 10%. कम होती है, 10% होती है. Whereas 90% is going to be what? Reticular dermis, बेटा. ये नीचे वाला जो part है, this is going to be reticular dermis. यहाँ पर papillary dermis में कौन से cells होंगे? You will be having dendrocytes. You will be having these mast cells which are going to release what? Histamine, serotonin, right? Histamine is going to be released from here. You have got fibroblast, elastic fiber, collagen fiber in the dermis. है ना, ये रेटिकुलर लेयर के अंदर होगा. कैन यू अप्रिशिएट, डू वी हैव ब्लड वेसल्स ओवर हियर? yes, blood vessel is going to be present here, right? This is going to be the blood vessel which is going to bleed in the cases of skin rupture. आपको कट लगता है तो स्किन में से थोड़े ना खून आता है. खून is going to come from where? The blood is going to come from the vessel itself. So what are the most important cells in the dermis? The most important cells in the dermis are going to be what? These are going to be your fibroblast, beta. The most important cells in the dermis is going to be your fibroblast, beta, fibroblast, right? Histamine is going to release from the mast cell. The function of histamine is to do what? Vasodilatation, bronchoconstriction, beta. This is going to be connective tissue. Most common collagen you will be having is going to be what? type 1. Bone is also going to have type 1. Second most is going to be type 3. Second most common is going to be type 3. Most common gag कौन सा होगा यहाँ पर? This is going to be a hyaluronic acid beta. And is it going to be good for skin? Yes, definitely. We have discussed multiple times. This hyaluronic acid is going to be good for the skin. It will retain the moisture. It will increase the blood flow. It will decrease the wrinkles. It will decrease the inflammation. So instead of sunscreen, you can apply this hyaluronic acid, right? Retain the moisture, increase blood flow, wrinkles, decrease inflammation. Then we have got what? Subcutaneous layer beta. Subcutaneous layer is going to be the third layer that we are having, important one. This is also known as hypodermis. Important question. This is also known as panniculus, and inflammation of panniculus is also known as panniculitis. You can have what? Panniculitis. What are the function of this layer? You will be having fats. So this is responsible for the thermoregulation. इसका function क्या होता है? Temperature regulation. Temperature regulation, right? You can have inflammation of this panniculitis. Two types of panniculitis we can have. We can have septal panniculitis. We can have lobular panniculitis. Septal panniculitis you will be finding in the erythema nodosum. Erythema nodosum. Lobular panniculitis you will be finding in the cases of trauma. है ना? With this we are done with the chapter number 1, which is the biggest one that we were having. Right? This is the important. Right, basics हमको समझ में आया. We have got to understand. We have got 3 layers. We have got 5 layers in the epidermis. Then we have got 2 layers in the dermis. Then we have got hypodermis, and between dermis and epidermis there will be a basement membrane zone, also known as dermo-epidermal junction. Dermo-epidermal junction. Right. Now we will discuss about the types of skin lesion. Right. So we have got 2 types of skin lesion. We have got primary skin lesions. Primary lesions. We have got secondary lesions. Simple याद रखो, primary lesions are due to disease itself. Due to disease itself, beta. Secondary lesions are going to be the lesions which are due to inadequate treatment. Which are due to inadequate treatment of primary lesion, or which are due to trauma. है ना? ये क्यों होगा? ट्रॉमा की वजह से. आपको कोई लीजन हुआ, आपने उसको ट्रॉमा कर दिया, आपने उसको रब कर दिया. What is going to happen? It will convert into secondary lesion. It will convert into secondary lesion, right? Due to inadequate treatment, due to trauma also, right? The next thing, what are the primary lesions we are having? What are the secondary lesions we are having? Look at these lesions. Primary lesions are going to be your macule, your papule, your nodule, tumor, plaque, veil, vesicle, bulla, pustule. These are the primary lesions, common primary lesions that we are having. Secondary lesions are going to be your scales, crust, fissure. You have got ulcer, you have got scar, you have got atrophy. All these things are going to be your secondary lesions. Right? These things are going to be your secondary lesions. So we have got what? Primary skin lesions. These are going to be your flat lesions. अगर flat lesion है ना? I'm not writing here. It is already written. Okay. आपने बस देखना है. अगर flat lesion है 1 सेंटीमीटर से कम का है, हम लोग क्या बोलेंगे इसको बेटा? हम लोग इसको बोलेंगे हम लोग macule. We are going to call it what? We are going to call it macule. If it is more than 1 centimeter, flat discoloration, color change, any lesion, flat lesion more than 1 centimeter, known as what? Patching. Patch will be there, right? Third thing, clear fluid filled lesion. If you have a clear fluid filled lesion less than 1 centimeter, you call it what? Vesicle. In the cases of herpes, we have got what? Vesicles. Okay. If it is more than 1 centimeter beta, we call it what? Bulla. We have got what? Bulla formation. है ना? Bullous pemphigoid में clear fluid filled lesion more than 1 centimeter, known as bulla. Solid lesion है, raised lesion है, circumscribed lesion है. We are going to call it what? Less than 1 centimeter is going to be papule. 1 से ज़्यादा है तो plaque है, और डेप्थ अगर जा रहा है, डीप जा रहा है अगर कोई भी लीजन, तो दिस इज नॉन एज नोड्यूल. जैसे हम लोग पढ़ते हैं नोडुलोसिस्टिक एक्ने. दीज आर गोइंग टू बी द सॉलिड लीजन्स. पस फिल्ड लीजन अगर कहीं पर भी है, छोटा पस फिल्ड लीजन वी कॉल इट पस्ट्यूल. अगर बड़ा पस फिल्ड लीजन वी कॉल इट व्हाट? एब्सेस. लाइक वी हैव डिस्कस्ड अबाउट पैराटॉन्सिलर एब्सेस, है ना? इन द केसेस ऑफ वेयर डू यू सी पैराटॉन्सिलर एब्सेस बेटा? पैराटॉन्सिलर एब्सेस कहाँ पढ़ा था? We have got wheal. Wheal is going to be what beta? Itchy lesion, erythematous lesion, edematous lesion. Itchy होगा, erythema होगा, redness होगा, and edema होगा. There will be edema is also going to be a feature. Petechia are going to be less than 2 mm. 2 to 1 centimeter is going to be what? Purpura, and then you have got what? More than 1 centimeter known as ecchymosis. है ना? तो small red dots that you can appreciate is going to be what? Petechia. This is going to be what? This is going to be your petechiae, right? This is going to be what? Purpura, and this is going to be what? Ecchymosis, right? So you have got petechiae, you have got purpura, you have got ecchymosis based on the size. These are what kind of lesions? They are all primary skin lesions. They are all प्राइमरी स्किन लीशंस, है ना? तो हम लोग क्या पढ़ रहे हैं? प्राइमरी स्किन लीशंस पढ़ रहे हैं. देन वी हैव गॉट सिस्ट. व्हाट इज अ सिस्ट? एनी सेल्स विच आर कवर्ड बाय द एपिथेलियल सेल्स, है ना? कोई भी छोटी सी सिस्ट मतलब उसके चारों तरफ कौन से सेल्स होंगे बेटा? एपिथेलियल सेल्स होंगे. दैट इज नोन एज व्हाट? सिस्ट. सिस्टिक फॉर्म विल बी देयर, राइट? सेकेंडरी लीशंस क्या होते हैं बेटा? Secondary lesions are the lesions which are formed after inadequate treatment of a disease, after trauma or injury, है ना? आपने वापस से रब कर दिया, स्क्रैच कर दिया, you will be having what? Secondary lesions, right? So secondary lesions, first secondary lesion we have got is going to be your scales, which is nothing but the desquamation of stratum corneum. आपका desquamation of stratum corneum is known as what? Scaling. Then we have got what? Crusting. Crusting is nothing but the dried up exudate. आपके जो एक्सुडेट निकल रहे हैं, लाइक इन द केसेस ऑफ स्ट्रेप्टोकोकस पायोजीन्स बेटा, है ना? लेट्स ट्राई टू इंटीग्रेट द सब्जेक्ट. पायोजीन्स में क्या निकलता है? यू विल बी हैविंग पस फिल्ड लाइक लीजन, एक्सुडेट विल बी कमिंग आउट एंड इट इज गोइंग टू ड्राई अप. When it is going to dry up, dried up exudate is known as what? Crusting, and it is going to give you honey color appearance in the cases of what? Pyogenes. It is going to give you honey color appearance. That is why that is known as honey colored crust. तो crust का मतलब समझ में आया? Okay, what is erosion? Erosion is going to be beta loss of epidermis. Loss of epidermis is known as what? Erosions. What is excoriation? Excoriation is linear loss of epidermis. अगर कोई लाइन linear loss है, कांटे से हुआ, पेन से हुआ, right? This is going to be linear loss of epidermis is known as what beta? This is known as excoriation. What is lichenification? अगर कहीं पर भी itchy lesion है, itchy lesion है, थिकनिंग हो रखा है, उसके ऊपर मोटा हो रखा है, कलर चेंज विल बी देयर. ओके, इफ देयर इज अ थिक itchy lesion with a color change, these three things are going to get favor in of lichenification. What is scar? Scar is a permanent fibrotic change that we have got. And ulcer is going to be what? Loss of epidermis plus dermis is known as what? Ulcer. That is known as ulcer. Loss of epidermis plus dermis is known as what? Ulcer. Okay. So let me just try to recap all these things. So let me see if you can answer this particular one. Let's begin with the first one that we are having in the list. This is going to be what? Flat lesion. This is going to be what? Okay. This is going to be what? This is going to be macule that we are having. Flat lesion less than 1 centimeter. This is known as macule. If it is big, more than 1 centimeter flat lesion, this is known as what beta? This is known as patch. This is known as patch, है ना? दूसरा lesion or third lesion you can appreciate, we have discussed about, is going to be your vesicle. What is vesicle? Vesicle is a clear fluid filled lesion, है ना? Clear fluid filled lesion less than 1 centimeter is known as what? Vesicle. Less than 1 centimeter is known as vesicle. और अगर 1 centimeter से बड़ा है, if you have got more than 1 centimeter clear fluid filled lesion, this is known as what? This is known as bulla. This is known as bulla. Okay, this is known as bulla. If you have got solid lesions, these are known as papule. Less than 1 centimeter are known as papules. More than 1 centimeter are known as plaques. And if they are going into depth, अगर ये डेप्थ में जा रहे हैं तो इनको बोलते हैं हम लोग नोड्यूल्स, है ना? ये नीचे तक जा रहे हैं, दैट इज व्हाट इज नोन एज नोड्यूल्स. देन वी हैव गॉट पस फील्ड लीशन. दिस इज गोइंग टू बी व्हाट? दिस इज गोइंग टू बी पस्ट्यूल. अगर छोटा पस फील्ड लीशन है पस्ट्यूल होगा, और अगर बड़ा पस फील्ड लीशन है दैट इज नोन एज एब्सेस. उसको क्या बोल देंगे? एब्सेस बोल देंगे, राइट. दिस इज गोइंग टू बी व्हील. व्हील में क्या होता है, लाइक आफ्टर मॉस्किटो बाइट यू कैन हैव व्हील. व्हील विल बी हैविंग व्हाट, edematous lesion, erythema can be there, and itching can be there, right. So here you will be having this wheel formation. Scales are going to be what, scales are going to be stratum corneum desquamation, right. So you will be having compacted desquamated layers of stratum corneum is known as what, this is known as scales, right. Then we have got crusting. Crusting, dried up serum or dried up exudate is known as what, crusting. Fissures, or fissure is going to be what, this is going to be a crack or split in the legs. You can have this type of fissuring. Excoriation is going to be linear erosion. Excoriation is going to be linear erosion. Erosion का मतलब क्या होता है, loss of epidermis. Loss of epidermis, if it is happening on linear pattern, this is known as excoriation. बेटा इसी को excoriation बोलते हैं, right. Then we have got what, lichenification. There will be three features of lichenification. Thickening will be there, okay, thickening will be there, color change will be there, itching will be there, color change will be there. This is going to be what, this is going to be lichenification. And scar is a permanent fibrotic change that we can have. This is going to be the scar formation, right. So these are the primary and secondary skin lesions that we are having, है ना. ये primary और secondary skin lesions हो गए. Then we will discuss about some other lesions. These are known as annular lesions and discoid lesions, right. This annular lesions, can you appreciate, this lesion will be having active margin and central clearing. So what is a lesion with active margin and central clearing? These lesions are, you will be finding in the cases of what, tinea. These are the lesions of tinea corporis, active margin, central clearing, right. You can find such sometimes this kind of lesions in the cases of leprosy also. बीबी टाइप ऑफ लेप्रेसी, मैंने बताया था बीबी की, बीबी क्या करवाएगी, बीबी घूमने के लिए बोलेगी. जियोग्राफिकल लीजन्स और बर्तन, right. Remember the inverted saucer plate, inverted saucer like appearance will be there. Inverted saucer shape appearance in the BB type of leprosy, और BB घूमने के लिए बोलेगी. You will be having geographical lesions, right. In Arctic area also you will be finding such type of lesions, right. Discoid lesions or nummular lesions or coin shaped lesions, these are the lesions you will be finding in which cases. Remember, first thing, all the center and periphery, everything is going to be what here, everything is active here, है ना. इसमें क्या हो रहा था, ऊपर वाले में central clearing was there, here complete lesion is active, right. Whole lesion is active. This type of lesion are known as discoid lesion, and discoid lesions are a feature of discoid lupus erythematosus. बेटा DLE में मिलेगा या discoid eczema में मिलेगा ऐसा lesion. This is going to be the thing. Then I have tried to summarize all the different kind of scaling at a single places, right. Single place scaling मतलब क्या होता है बेटा, स्केलिंग मतलब पिटाइरियासिस. पिटाइरियासिस का मतलब भी स्केलिंग होता है. एंड दिस पिटाइरियासिस और द स्केलिंग यू विल बी फाइंडिंग इन विच केसेस, द स्केलिंग इज गोइंग टू बी सीन विद व्हाट, ये जो स्केलिंग आपको दिख रहा है इसका मतलब होता है लॉस ऑफ स्ट्रेटम कॉर्नियम, और desquamation of stratum corneum is known as what, scaling. Desquamation of stratum corneum is known as what, this is known as scaling beta, this is known as scaling, right. So we have got ichthyosis vulgaris. Ichthyosis vulgaris, we will be having fish like scaling. In the beginning we have seen about this fish like scaling. Where do you see this fish like scaling? Ichthyosis vulgaris is due to deficiency of which granules, okay. Second, we have got pityriasis rosacea, where you will be having colorate of scales or cigarette paper like scaling. पिटाइरियासिस का मतलब भी क्या होता है बेटा, पिटाइरियासिस का मतलब होता है स्केलिंग. पिटाइरियासिस वर्सिकॉलर, पिटाइरियासिस वर्सिकॉलर, वर्सी मींस डिफरेंट कलर. You will be finding rice powder like fine scaling will be there, or briny scales will be there. In the cases of psoriasis, you will be finding what, silver white scaling will be there. In the cases of psoriasis, silver white scaling will be there. This is how you will be having easy of the questions, right. आपके क्वेश्चन आसान हो जाएंगे अगर आपको ये चीजें याद है. Pityriasis rosacea is going to be red color thing. versicolor is going to be hyperpigmented thing will be there, right? You will be having macules or patches on the back, right? Second thing, versicolor will be having what? You will be having two important thing, STA, and it is going to be on the KOH mount, remember. Okay, so in the KOH mount it is going to show you a spaghetti and meatball appearance, whereas in the STA it is going to show you what? It is going to show you on STA, it is going to show you what? फ्राइड एग अपीयरेंस बेटा, फ्राइड एग अपीयरेंस है ना। और ये फ्राइड एग अपीयरेंस कहाँ कहाँ और पढ़ा था बेटा? पैथोलॉजी में पढ़ा था कहीं फ्राइड एग अपीयरेंस ऑन द ओलिगोडेंड्रोग्लायोमा, है ना, IDH1 IDH2, है ना, ओलिगोडेंड्रोग्लायोमा। और कहाँ पढ़ा था फ्राइड एग अपीयरेंस? रिमेंबर इन माइकोलॉजी, remember in bacteriology I've told you about mycoplasma, last bacteria. So this mycoplasma will be having what? Again fried egg appearance, right? So this is what is about the scaling that we have got, right? This is the scaling that we have got. Then we have got the Langer's line. These lines are parallel to what? Parallel to collagen fibers, and they are perpendicular to muscle fibers. These are the lines of tensions. इनका दूसरा नाम होता है लाइन ऑफ टेंशन. कौन यूज में लेगा? दीज लाइन्स यू विल बी यूटिलाइज्ड बाय द सर्जरी पीपल before making any incision. If you go make an incision along this line, this is going to give you what? Better healing, है ना. Across this line incision is going to give you bad healing, or you can say across the line incision will lead to what? Hypertrophic scar formation. So it is used for what purpose? Incision during the surgery for better healing. This is going to be your Langer's line. कौन सी line बोलते हैं बेटा इनको? Langer's line. Okay, another line we are having is the Blaschko's line. This Blaschko's lines are responsible for the identification of what? Embryonal migration. ये important है, ये line ही important है. This is what they have asked, right? So these are the lines which are going to be helpful in identification of keratinocytes, है ना. keratinocytes का migration को identify करने के लिए ये lines है. And these are the what are the examples of this particular line? What are the diseases which are happening around this line? This is going to be your incontinentia pigmenti, hypomelanosis of Ito, and epidermal nevi. Epidermal nevi, incontinentia pigmenti, hypomelanosis of Ito. These are the three diseases, important one for Blaschko's line, है ना. ये कैसे डिफ्रेंशिएट करोगे? रिमेंबर बेटा, इट इज गोइंग टू बी सर्कुलर ऑन द हेड, है ना. ये यहाँ पर क्या है? सर्कुलर है हेड के ऊपर. यू विल बी फाइंडिंग दिस एस शेप ग्रिप विल बी देयर, है ना. वेरएस ये ऊपर वाली जो लाइन है ये कैसी होंगी? सीधी होंगी. यहाँ क्या सर्कुलर दिख रहा है? क्या कुछ नहीं दिख रहा. सो Langer's lines do not have this circular thing, whereas this Blaschko's lines will be having what? Circular thing, and S shape will be there on the trunk, right? This is going to be what? Blaschko's lines. This is going to be your Langer's line. Third line we have got is the dermatomes beta. Third line we have got is the dermatomes. These are the area of skin that connects with a specific nerve, root, right, in the spine, and control the sensory nerve root. Sensory nerve root को control करेंगे. They are going to control what? Sensory nerve root, right? So this is going to be the nerve root that we are having, है ना. ये इसकी वजह से क्या हमें पता चलता है? If someone is having radiculopathy, है ना, suppose किसी के neck में stiffness है, right? If there is some stiffness, there will be loss of curvature of the neck, है ना. Stiffness spasm की वजह से क्या होगा? How you will assess that someone is having cervical or something? You will look for the X-ray. You will find there will be loss of lordosis, right? Loss of curvature will be there, and then this patient will be having what? Radiculopathy. This current, this pain will be radiating. This pain will be radiating along what? This pain will be radiating along the dermatomes, है ना. हम लोग myotomes तो पढ़ते हैं. Myotomes is responsible for the movement. This dermatomes are responsible for the sensation, है ना. And you can also have some diseases like we have got herpes zoster beta. Herpes का मतलब क्या पढ़ाया था मैंने? Herpes means grouped vesicles. Now you already know what is a vesicle. Vesicle is a clear fluid filled lesion less than 1 centimeter. Grouped vesicle. Zoster means what? Along a nerve segment. Zoster means along a specific nerve segment beta. So when you have this grouped vesicle along a particular nerve segment, right? For example, this thoracic segment will be having multiple small grouped vesicle will be there. This is going to be what? This is known as herpes zoster, also known as shingles, है ना. It is a manifestation of what? Varicella की वजह से बाद में क्या होगा? Shingles हो जाएगा, right? You will be having HHV 3, I've told you HHV3 है ना, तो ये shingles हो जाएगा. This is going to be the thing. What is the drug of choice for this herpes zoster? आपका क्वेश्चन आता है ट्रीटमेंट के लिए. You are going to use what 800 milligram of acyclovir 5 times a day into a week, 7 days, right? The drug of choice remains the acyclovir. Acyclovir is the drug of choice for this particular one, and you would like to use this 800 milligram 5 times a day for 1 week, है ना. This is going to be herpes zoster. Then we have got some techniques. What are the techniques we are having for diagnosis of the skin lesions? Okay. Okay, Vijay, all of you are waiting for the same thing. I would be continuing for 3 more hours. I think, है ना, 3 घंटे और चलेगा. You can do one thing. If you want to study something else, you can rewatch it on a 1.5 or 2x, है ना. So this is going to be what? Diascopy. This is going to be what? Diascopy. Diascopy we are going to use for diagnosis of the skin lesions, right? We have got some skin lesions. उसके diagnosis के लिए we are going to use this diascopy. If redness is due to blood vessel, बेटा, अगर redness किसकी वजह से है? Blood vessel की वजह से, erythema की वजह से, बेटा. So what is going to happen? There will be extravasation into the skin, right? You will be having what kind of lesions? What kind of lesions will be showing you this diascopy test? If there is erythema, it is going to blanch with the pressure, yes or no? Okay. If there is erythema, it is going to blanch with the pressure. Blanch मतलब क्या होता है? Blanch मतलब होता है disappear. Right, so when you are going to apply a pressure, diascopy में क्या होगा? There will be a glass slide that you are applying on the pressure, applying on the wound, right? Whatever lesion you are having, जब आप उसके ऊपर रखोगे तो क्या होगा? एरिथमा होगा तो ये डिसअपियर हो जाएगा, इट विल डिसअपियर. अगर एरिथमा नहीं है और हिमरेज है, सो दिस इज गोइंग टू बी नॉन ब्लांचेबल. दिस इज गोइंग टू बी नॉन ब्लांचेबल. नॉन ब्लांचेबल है ना. ब्लांचेबल का मतलब होता है डिसअपियर करना, राइट. This is also going to help you identify about certain granulomatous diseases, है ना. कौन सी granulomatous diseases को identify करने के काम में आएगा? जैसे lupus हो गया, lupus vulgaris. We have skin, most common skin TB. जब आप diascopy करते हो, you will be finding what kind of nodules? You will be finding apple jelly nodules on the diascopy. This is also going to get understood with the help of this diascopy. Apart from diascopy, we have got what? We have got this wood lamp examination, right? This wood lamp is a device which is used to identify the fungal, bacterial or some other type of infections on the skin or scalp, right? So in erythrasma, what is the color that you would be getting? You will be getting what? Coral red fluorescence, beta. Coral red fluorescence will be there, right? And this erythrasma is due to Corynebacterium minutissimum. This is due to Corynebacterium minutissimum, right? This Corynebacterium minutissimum is going to be there. Then we have got what? Pityriasis, which is going to have what? Yellow to orange color of wood lamp examination. Then we have got what? This Snollany is going to give you what? Dull blue color. Tuberous sclerosis, you will be finding what? White color, and this macule is known as, very important, ash leaf macule. This macule is that you will be finding in tuberous sclerosis. This is known as what, beta? This is known as ash leaf macule. In the vitiligo, you will be finding blue to white color. Blue to white color will be there. This tinea Snollany is going to cause what? Carrion. This is this is going to cause what, beta? Favus. Favus is going to be there. Carrion किससे होगा? Carrion होगा. Painful boggy swelling will be there. That is going to be the carrion. This is due to tinea mentagrophyte or verrucosum. आगे पढ़ेंगे, ठीक है. Then for the treatment, we have got what? Cryotherapy and phototherapy, beta. Cryotherapy is we are going to use what? Liquid nitrogen, 196 degrees Celsius. Okay, they are going to be responsible for killing of the keloid warts. But remember, beta, you will be going for multiple sessions, है ना. एक बार में नहीं होगा. You need to go for multiple sessions. Second one we have got is the phototherapy. Phototherapy, you are going to use what? PUA. Soraline plus UVA, and Soraline is going to be what? Photosensitizer here. This Soraline is going to be what? Photosensitizer, right? And UVA radiation you are going to give. It is used for psoriasis. It is used for what? Vitiligo, both the cases, right? So we are done with this particular thing. Now the next thing we will be starting it off is with the skin appendages. How many skin appendages we have got? So we have got nails, we have got hairs, we have got glands on the skin. Whatever is on the skin के अलावा और जो भी है skin के ऊपर, they are considered as skin appendages. So we have got nails, we have got hairs, we have got glands. Remember, we have got two types of glands. We have got sebaceous glands, we have got sweat gland. बेटा sweat gland होगी और sebaceous glands होंगे. तो जो sebaceous glands होती हैं, इनमें से क्या निकलेगा बेटा? इनमें से निकलेगा sebum. And what is the function of this sebum? It is going to provide lubrication, है ना, nourishment, lubrication to the cells. कहाँ से निकलेगा ये देखो, ये sebaceous gland कहाँ खुलेगी? This is a sebaceous gland which is going to produce what? Sebum. And this sebum is going to come out where? Along with the hair follicle. Along with the hair follicle you will be having what beta? You will be having sebum release will be there, right? Then we will discuss about the first. Let's begin with the nails. Just give me 5 minutes. 5 minutes break beta. All right. So now we will discuss about the nail changes beta na. So first change we are going to discuss is about the changes in the nails. So what are the different type of nail changes that we are having? Let's learn about them, right? So first thing in the nails, right, you need to understand the basics. This is going to grow at a speed of 3 mm per month, right? 3 mm per hour is going to be the speed of what? Try to answer. 3 mm per hour is the speed of what? Right? So this is going to be what? This is going to be known as cuticle. This part is known as cuticle. This white area that you can appreciate over here, this is going to be your nothing but your lunule, right? Lunula, right? Then we have got this free edge of the nail that we are going to have. This is going to be the body. This particular lateral part is known as lateral nail fold. This part is going to be what? Here, this part is going to be your proximal nail fold. This is going to be proximal nail fold. This is going to be lateral nail fold over here. This is going to be lateral nail fold, right? We can have infections over there, and the infection of lateral nail fold is going to be what? कौन सा infection होता है यहाँ पर? We'll discuss. That is going to be your paronychia, right? So this is going to be normal scale, normal nails that we are having. We can have pitting over there. This is known as pitted. Onycholysis means breakdown of the nails. You can have excessive deposition of hyperkeratinization subungual below the ungual. This is known as subungual hyperkeratosis, right? We can have ridging of the nails, we can have thickening of the nails, we can have crumbling of the nails, we can have certain nail changes color. So let's begin with the first thing that we are having. This is going to be about the first thing. Let's just start it off with the first thing. We have got pitting. So this is going to be the pitting of the nails. This pitting you will be finding two important questions from the pitting. They will be asking you, right? What kind of pitting you will be finding in alopecia areata? Alopecia areata में कौन सी pitting होती बेटा? Alopecia areata is going to be what? There was a small girl like a few days back, 3-4 days back, there was a small girl in the hospital and she came with the hair loss from this particular part. यहाँ से पूरे बाल गए, यहाँ से पूरे बाल गए, right? So she is having hair loss, complete hair loss from a particular region. Does this particular patient needs to worry? Yes, they need to worry, but is it going to come back? The hairs are going to come back or not? So this is going to be loss of hairs beta, and this is going to take place from a particular area, right? It is going to be a autoimmune disorder, autoimmune condition, and remember this is going to be non-cicatricial type of alopecia है ना. तो ये इसमें क्या होगा? नॉन स्कारिंग टाइप ऑफ एलोपेशिया है. तो क्या इस पेशेंट को फिर से हेयर ग्रोथ हो जाएगा? हो जाएगा. हियर यू विल बी फाइंडिंग पिटिंग. व्हाट काइंड ऑफ पिटिंग? याद रखना एलोपेशिया एरियाटा यू नीड टू रिमेंबर अबाउट द हेयर्स है ना. सो इट विल बी हैविंग सुपरफिशियल हेयर्स. कहाँ होते हैं? ऊपर होते हैं. सुपरफिशियल एंड रेगुलर हेयर लॉस विल बी देयर. सो रेगुलर पिटिंग विल बी देयर. So when they talk about alopecia areata, this is going to have what? Superficial and regular pitting. Whereas in the psoriasis, you will be having a deep systemic infection. So it will be having deep and irregular infection, irregular pitting, right? So you can simply remember psoriasis will be having deep and irregular pitting, whereas alopecia areata will be having pitting, which is going to be superficial as well as regular pitting, right? Then we have got this nail condition that you will be finding in the hypoxic conditions. This is going to be the clubbing that you can see in the hypoxic conditions, right? This is your spoon shaped nails that you will be finding, also known as koilonychia, which is suggestive of what? Iron deficiency anemia beta, iron deficiency anemia. In Plummer-Vinson syndrome, what was the triad? We have already discussed. This was the triad: iron deficiency anemia, dysphagia will be there, and esophageal webs will be there. This is going to be spoon shaped nail, which is going to be characteristic thing that you will be finding over there. These are the Mees lines. These are Mees lines you will be finding in the arsenic poisoning. Which poisoning you will be finding? Mees line beta. This is going to be seen in the arsenic poisoning. Arsenic poisoning will be having what? Mees lines. These Mees lines are going to be your horizontal lines that you can appreciate. These horizontal lines that you can appreciate, this is known as Mees lines, right? When a proximal nail fold, this is your proximal nail fold, is dividing the nails into two halves, this is known as what? This is known as pterygium beta. This is known as pterygium. It is a very, very important finding for what? This pterygium is a very important finding you will be finding with the lichen planus. Lichen planus, right? So pterygium is a characteristic feature of lichen planus, where a nail fold, proximal nail fold is going to divide your nails into two halves. यहाँ से दो half में divide कर दिया. This is known as what? This is known as pterygium beta. Pterygium, right? Then we have got what? Remember, acute infections are generally bacterial infections and chronic are going to be fungal. Can you appreciate here there is an infection of lateral nail fold? This is known as paronychia beta. This is known as paronychia. Paronychia, and the treatment will be you give amoxi to this patient. If it is big, you can make an incision also and do the bandage, right? Yeah, you can give amoxi. 625 is going to be good one, right? 625 mg amoxiclav, right? Then we have got what? Half nail sign. We have got Lindsay's nail. This is going to be your half nail signs or Lindsay's nail that we can appreciate. Half nail are red, half nail is going to be white. This is known as half nail sign or Lindsay's nail. This is what you will be finding in the cases of chronic renal failure. In the cases of chronic renal failure, you will be having this half nail sign, right? Whereas this Terry's nails, this is going to be somewhat 80-20 ratio, na? 80-20. This Terry's nail you will be finding where? This is something you will be finding in the pemphigus, also in the cases of hepatic failure beta. Hepatic failure वाले patients में भी कौन से nails मिलेंगे? Terry's nails मिलेंगे. कौन से nail मिलेंगे? Terry's nails will be there in the hepatic failure. Apart from that, you can also appreciate the ground glass opacities over there. You will be having this ground glass opacities. This ground glass opacities are also going to be positive in the cases of this particular Terry's nail, है ना? तो half nail sign, Terry's nail we are going to have. Then we have got this oil drop sign, very, very characteristic, and your previous year question also. This oil drop sign that you can appreciate is a very characteristic feature of psoriasis beta. This is your oil drop sign that we are having. It is characteristic feature of psoriasis. This is your thimble nail, also known as pitted nails that we can have. These are your thimble nails or pitted nails that we are having. Both of them are a feature of what? If they ask you what is the most common type of nail finding, your answer will be what? Thimble nails, also known as pitted nails. What kind of pitting you will be seeing over here? कौन सा pitting मिलता है बेटा psoriasis में? You will be having psoriasis is a deep disease or superficial? Deep disease. So you will be having what? Deep irregular disease, irregular pitting will be there. This is the most common presentation. Then you can have this most characteristic presentation is going to be what? Most characteristic presentation of psoriasis is going to be this salmon patch, or also known as oil drop sign. This salmon patch, also known as oil drop sign. Then we have got this Bullous lines beta. This is going to be your Bullous lines. These are going to be your depressed and growing lines. These are going to be your depressed and growing lines. Here you have got what? Muher's lines. These are the lines which are non-depressed and non-growing lines. They are responsible for the hypoalbuminemia indication, right? This patient will also have what? Edema on the body, right? And if this edema is going to be generalized, like on the abdomen, we call it what? Ascites. If it is generalized, we call it what? Anasarca. Anasarca, generalized edema, right? So this is due to decrease in the levels of albumin also, right? We can have what? We can have chronic illnesses. This is going to be the seen in the cases of chronic illnesses, Bullous lines and Muher line. Okay, and lastly we have got what? Onychogryphosis. This is going to be what? Ram's horn nail. This is going to be the Ram's horn nail, also known as this distorted nail that you can appreciate. This is going to be your onychogryphosis, right? This is going to be onychogryphosis. So this is pretty much about all the nail pathologies, various nail pathologies that have come across in your dermatology, right? We have seen the basics and we have seen the various specific nail pathologies that has been asked in your previous examinations. Next thing we have got is about the hair follicle beta. Hair follicle, we have got the growth of hair follicle is going to be 1 centimeter per month, right? 1 centimeter per month. Loss of hair is known as what beta? This is known as alopecia, nothing but your alopecia. How many stages do we have? We have got anagen, we have got catagen, we have got telogen, we have got exogen. Anagen is going to take years. It is going to be long growing phase where you will be having growth of the hairs. Catagen is going to be residing for like weeks, and it is also known as involution forms, and destruction can be happening over here. And then lastly you have got telogen, which is residing for the months, which is very important, and it will be having what resting phase of the hairs will be there, right? So we have got these three hairs stages. Fourth one is going to be exogen, which is going to be shedding of the hairs, and shedding of the hairs is going to come under exogen beta. तो एलोपेशिया होता क्या है, कितने टाइप का एलोपेशिया होता है, दैट इज इंपॉर्टेंट. सो वी हैव गॉट टू टाइप्स ऑफ एलोपेशिया ओवर हियर. One is going to be scarring type of alopecia, another one is non-scarring type of alopecia. Scarring is also known as cicatricial type of alopecia. Cicatricial. Cicatricial means once there is hair loss, there will be no growth of hairs from that particular area. है ना, एक बार हेयर लॉस हो गया मतलब हो गया, खत्म कहानी, राइट. व्हाट अबाउट दिस नॉन स्कारिंग? नॉन स्कारिंग मीन्स द पर्टिकुलर पर्सन विल बी हैविंग हेयर ग्रोथ अगेन. यहाँ पर पेशेंट को फिर से बाल आ जाएंगे, राइट. दिस इज ऑल्सो नोन एज नॉन स्कारिंग, ऑल्सो नोन एज नॉन cicatricial. Non-cicatricial type of alopecia. So we have got tinea capitis, non-inflammatory type of tinea like gray patch. We are having black dot. These are going to be non-inflammatory type of tinea. Inflammatory is going to be what? These are going to be carrion and favus. They will have complete hair loss. Once hair loss, always hair loss, right? Then we have got hormonal. Hormonal, we have got what? Hypothyroidism. Remember, hypo is going to be one of the most important cause for hair loss. If a pregnant female or a female is coming to you, chubby female, she will have complaints that I don't want to go out, I don't feel like walking, I don't feel like eating, and I'm always cold intolerant, I don't want to go out, I don't want to do anything. Panda like person with a hair loss. This is going to be what? This is going to be this can be a feature of what? Hypothyroidism. You need to check for the TSH. Right. Androgenic alopecia, this is a male and female pattern baldness that we are having in the family. This is due to dihydrotestosterone. It is going to be androgen dependent also, right? That is going to be androgenic alopecia in the males, in the females. We can have anagen effluvium, which is going to be seen in the cancer therapies. Alopecia areata, autoimmune disease, it is also going to be non-scarring. Trichotillomania. Trichotillomania means hair pulling and eating. It is a maniac condition. Eating is not necessary, hair pulling is necessary, right? Then we have got what? Then we have got secondary syphilis. This is going to be having what? Moth eaten alopecia. Moth eaten alopecia मतलब कैसा दिखेगा head? Head is going to look like your moth has eaten your hairs, right? Then we have got what? SLE, systemic lupus erythematosus. Telogen effluvium, post some disease, you will be having this type of alopecia. And deficiency of zinc and iron are important. Zinc and iron can also lead to what? Hair loss beta. Hair loss can be there, right? Then we have got scarring type of alopecia where you will be having what? Scleroderma. Okay, hardening of the skin, scleroderma will be there. Tinea capitis can be there. We can have folliculitis declavans. We can have DLE, discoid lupus erythematosus. We can have what? Lupus vulgaris, which is the most common type of TB. We can have Lichen planopilaris. We can also have what? Pseudoplaid of Brock. This is going to be what? This is the appearance that you will be finding in the pseudoplaid of Brock. Pseudopalade of Brock. What kind of appearance you will be having? It is looking like a snow print on. It is looking like a footprint on snow. This is going to have what? Snow will be having what? Footprint like appearance. This is known as pseudopalade of Brock. This is your previous year question that you will be finding. This is going to be what? Fibrosis of skin. Fibrosis of skin means what? Fibrosis of skin you will be finding in the scleroderma beta. Skin tightening will be there in the scleroderma, and coupe de sabre is going to be what? It is going to be seen in the morphia. This box like structure they have asked, this box shape appearance will be there. In the question they have written box shape appearance. This is your previous year NEET PG question. Okay, this is going to be coupe de sabre, right? Anagen effluvium and telogen effluvium कैसे differentiate करोगे? It's pretty simple. Anagen effluvium is going to be, just wait for a few minutes and you will get to know automatically, right? This is going to be the, this is your linear scleroderma beta. linear scleroderma, where you will be having this line will be there, and sclero means hardening, derma means there will be skin involvement will be there, right? What are the patterned hair loss? We have got patterned hair loss is going to be what? Androgenic alopecia. We have got male pattern baldness, we have got female pattern baldness beta. Male pattern baldness is considered understood with the help of Norwood and Hamilton grading system. इसके अंदर 7 grades we have got, है ना? तो यहाँ से गया, फिर यहाँ से गया, फिर यहाँ से गया, तो ऐसे करके we have done what? How many stages we have got? We have got 7 stages in Norwood Hamilton grading system. Okay, here the patient will be having loss of hair from the frontal part of or the vertex, है ना? यहाँ से जाएगा या यहाँ से जाना start होगा. This is going to happen in the family. Male pattern baldness. Female pattern baldness or female hair loss is going to be what Ludwig and Olsen we can have. Here you will be having loss of hair from the frontal or vertex portion of the skull, or you will be having loss of hair from the part from where the females are going to part their hairs, है ना? तो यहाँ से female में यहाँ से hair loss होना start होगा. Females will be having hair loss from this particular area, right? So this is going to be the thing. क्यों होता है ये hair loss? Because testosterone in males, this testosterone is going to convert into dihydrotestosterone with the help of an enzyme. What is the name of this enzyme? 5-alpha reductase, and this dihydrotestosterone is responsible for this particular hair loss, है ना? So we can give what? Finasteride to this patient because they are going to block this 5-alpha reductase. We can give dutasteride to this patient also. This is also going to be done, right? Minoxidil we can use in both the patient, 5% for the males and 2% for the females, you can remember, right? If this is not effective, what we can do? We can go for PRP. PRP is platelet rich plasma, right? We can go for transplant also. This is the last mainstay of treatment that we have got. This is going to be hair transplant we can do, है ना? Patch भी लगा सकते हो, but for patch you need to go for regular shaving of head, right? And transplant is going to be something that you can also do. This is your male and female pattern baldness, also known as androgenic alopecia. Second one we are going to discuss is going to be your nothing but your alopecia areata. मैंने बताया एक बच्ची आई थी हॉस्पिटल में, right? She will be having this same type of lesions was there, right? And this is going to be what? This is autoimmune disorder. We have already understood. Here you will be having easily pluckable hair. आप खींचोगे वो बाहर आ जाएगा. This is going to be easily pluckable hair. But there will be a special phenomena. Remember, white hairs are spared, है ना? ये जो white hairs, ये grey hairs होते हैं, ये spared हो जाते हैं. They are not going to get affected. We don't know the exact cause for that particular thing, but still these hairs are going to get spared, right? Pitting, you will be having superficial regular pitting, and you will be finding what kind of sign? You will be finding this exclamation mark sign you will be having, right? And around that sign you will be having this perifollicular hemorrhage. This is going to be what? This is going to be giving you appearance of swarm of bee. This is appearance is known as what? Swarm of bee appearance. This appearance is known as what? Swarm of bee, madhumakhi ka jhund, right? This is going to be the swarm of bee appearance that we are going to have. Treatment क्या करने हैं? This is autoimmune condition. You give injection of steroid. These are going to be your triamcinolone use में ले सकते हो. You can give steroids. You can give azathioprine to the patient, right? They will be okay, right? This is just autoimmune condition, right? So alopecia areata, patient will be having patchy hair loss will be there, and from a particular area all the hairs will be gone, right? Whereas alopecia totalis means what is going to happen? You will be having total hair loss from the head, right? Alopecia universalis means complete body will be not having the hairs, है ना? पूरी body में से hair चले जाएंगे. This is known as alopecia universalis, right? Then we have got androgenic alopecia. From the female is going to have alopecia from here. Males will be having starting will be from this particular part, and ultimately they will join like that. This is going to be androgenic alopecia. Okay, we can have diffuse alopecia areata also, right? We can have oophiasis pattern. Oophiasis, you can make a oo like that, okay? So you will be having a band like hair will be there, and then you will be having loss of hair from the lower part. You can have traction alopecia, those people who are keeping the pony high, right? High ponytails, those people who are using buckles or something are always causing what like that. So what is going to happen? They will be having traction alopecia beta. Traction alopecia, you know? What is this? Enargin effluvium, okay? So enargin effluvium is something that is going to have loss of hairs after chemotherapy beta. After chemotherapy, if patient is having hair loss, this is known as enargin effluvium. This is known as enargin effluvium will be there. Enargin effluvium will be there, right? Telogen effluvium will be what? Telogen effluvium will be after some disease. Okay, history of some disease you will be finding. Few months back patient had COVID, patient had typhoid, patient had dengue, and now she is having what? Now she is having hair loss, है ना. 3 महीने पहले पेशेंट को डेंगू हुआ था, अभी पेशेंट को क्या हो रहा है? पेशेंट को बहुत ज़्यादा हेयर लॉस हो रहा है. व्हाट इज़ योर डायग्नोसिस? दिस इज टेलोजन एफ्लूवियम. इस पेशेंट को क्या करना है? इस पेशेंट को कुछ भी नहीं करना, कुछ भी फालतू नकली चीज़ें कुछ भी नहीं बताने इसको. यू जस्ट गिव द रीअश्योरेंस टू द पेशेंट दैट योर हेयर्स विल कम बैक एंड दिस पेशेंट विल बी हैविंग कमिंग बैक ऑफ द हेयर. Right, this is what is known as telogen effluvium. Then we have got what? Trichotillomania. Tricho means hair, tilo means pulling, and mania means it is a psychiatric condition where the patient will be pulling the hair for the gratification, है ना. इसको शांति मिलती है बाल खींचने से. So this is going to be what? This is going to be trichotillomania. Some people are eating it also, that is going to be trichophagia or trichobajor, right? That is going to be the hair eating disorder that we are having, right? So we are having this hair pulling disorder. It is a psychiatric condition beta. You will be having perifollicular hemorrhages also here. Treatment क्या करोगे? This is a psychiatric condition, treat it psychiatrically, right? This patient will be treated by the cognitive behavioral therapy, or this patient should be given what? SSRI. SSRI are the drugs which you would like to use over here. And then we have got what? Traction alopecia beta. Traction alopecia में क्या होगा? You are going to have a very good traction over here. Look, can you appreciate this? Is the female, she is doing what? She is causing a great force over there, leading to what? Leading to hair loss in this particular area because of the constant pull. Constant pull is going to cause what? Loss of hairs due to constant pulling. Example, tight ponytails, and you can also have hair bands. Some people are applying what? Hair bands like that every time. So they are going to have what? They are also going to have what? This particular thing. This is going to be traction alopecia beta. Traction alopecia, right? So these are the basic type of alopecias that you should be remembering. Then we will discuss about the glands beta, है ना. अब क्या पढ़ेंगे? Glands पढ़ेंगे. तीन ही चीज़ें पढ़नी होती है. Now we will discuss about the different kind of glands that we are having. कौन सी glands होती है? We have got eccrine gland, we have got apocrine gland. Eccrine होती है, apocrine होती है. These eccrine glands are going to be present. E for E, you can remember, they are going to be present where? They are going to be present everywhere. Okay, you will be having what? Cholinergic control. You can remember C से C याद रख लो. Okay, eccrine में E से everywhere, C से you can remember cholinergic control. They are under cholinergic control. Cholinergic means parasympathetic nervous system. They are responsible for what functions? Thermoregulation beta. Thermoregulation. Okay, we have got a disease because of that. If you are having inflammation of this eccrine sweat glands, eccrine glands, you will be having what? Sweat glands का function क्या होता है? Sweat produce करना. अगर आपको यहाँ पर inflammation हो जाए eccrine glands में, you will be having what बेटा? You will be having malaria. This malaria is also known as prickly heat. Prickly heat है ना. तो गर्मी में ये क्या कराती है? गर्मी में ये एक्टिवेट हो जाएगी पैरासिम्पैथेटिक नर्वस सिस्टम के एक्टिवेशन से, एंड दिस इज गोइंग टू डू व्हाट? दिस इज गोइंग टू रिलीज व्हाट? स्वेट. और स्वेट की वजह से क्या होगा? पर्सपिरेशन होगा. स्वेट की वजह से क्या होगा? आपका टेम्परेचर कूल होगा, राइट. बट अगर इनका ब्लॉकेज हो गया, सो यू विल बी हैविंग अ डिजीज दैट इज नॉन एज मलेरिया, है ना. मलेरिया एक अलग चीज है. मलेरिया इज व्हाट? मलेरिया और prickly heat also known as गमोरिया, है ना. दैट यू हैव inflammation of eccrine sweat glands, है ना. And the most common, that is going to be red color. This is known as what? Malaria rubra. Malaria rubra beta, है ना. Second thing we have got is apocrine glands. This apocrine glands, apo मतलब होता है किसी ना किसी के साथ में बेटा है. Apo means किसी ना किसी के साथ में. So these are the glands which are going to open along with something. Apo means along with something. Along with what? Along with the hair follicle. So these are the apocrine glands. You can appreciate the sebaceous glands are going to produce what? Sebum. ये हम लोगों ने पहले ही पढ़ लिया था. Sebaceous gland is going to produce sebum. These are your eccrine sweat glands which are going to do what? Which are going to produce the sweat. And these are your apocrine gland. These apocrine glands are going to produce what? These apocrine glands are going to release something along with the vessel, है ना. तो इसकी वजह से क्या आता है बेटा? इसकी वजह से odor आता है. Odor that you are having, this is going to open along with something. So where do you have this thing? In the armpit, you will be having in the axilla, you will be having in the groin, you will be having odor because of this particular sweat plus bacteria is going to make some odor, right? This is the thing we are having. So it is going to open along with the hair follicle. You will be having this particular thing under which control? This is going to be under adrenergic control. We have got this particular thing in the axilla and perineum. You will be having the disease. What is the disease you will be having? If you have inflammation of this particular apocrine gland, we will be having a disease that is known as phosphodysis disease. And previous question hai, what is the disease we are having? This is going to have what? Phosphodysis disease, right? It will be present in the axilla, it will be present in the perineum. Beta, axilla or perineum mein you can have which disease? This is going to be your phosphodysis disease, right? So axilla around the nipples, you can have what? This particular thing, axilla around the nipples, you will be having multiple itchy skin colored papules will be there, pruritic papules, they will be having itching. This is known as what? Phosphodysis disease. Okay, you will be having this type of papules will be there. This is going to be what? Phosphodysis disease. Okay, you can also have another disease which is also known as hidradenitis suppurativa, also known as inverse acne. Beta, this is also known as inverse acne. This is also a disease which you will be finding either in the groin region, right? This is going to be present in the same region, right? That is going to be the hidradenitis suppurativa. Then we have got some modification of this apocrine glands. These are known as what? Modified apocrine glands, है ना? तो जैसे हमारी मेमोरी ग्लैंड होती है, we have got memory gland. These are going to be what kind of gland? ये क्या है बेटा? ये modified apocrine gland. Apo means along with the hair follicle. So modified apocrine का पहला example है बेटा. This is going to be mammary gland, and mammary gland is going to do what? Simple, milk production. And which hormone is responsible for milk production? Pro. This is going to be prolactin. Ejection के लिए कौन सा हार्मोन काम में आता है? This is going to be for milk ejection बेटा. Ejection किसकी वजह से होता है? That is going to be your oxytocin, right? Second gland we have got is the moles gland in the eye, which is going to cause what? So which is going to have a disease that is going to be sty formation that you can have, right? And you can also have hydrocystoma. We have got ceruminous gland in the ear. These are also what type of glands? They are also apocrine gland, modified apocrine gland. They are going to be present in the ear and responsible for the production of what? Wax in the ear, right? Wax in the ear is going to be what? कुछ नहीं होता wax. Wax क्या होता है? It is a product coming from the modified apocrine gland. Apo means along with something. They are going to open along with something. Okay, they are going to open along with the something, है ना? Then we have got what? Then we have got sebaceous gland बेटा. Sweat gland हम लोगों ने देख लिया. We have got two types of sweat glands. We have got ecrine gland, we have got apocrine gland, है ना? Apocrine देख लिया, ecrine देख लिया. Now we have got what? Now we have got sebaceous gland, है ना? Apo मतलब it is going to open along with the hair follicle. तो sweat कहाँ कहाँ होगा hair follicle के साथ में? In the axilla, in the groin region, right? Sweat glands, normal sweat glands, ecrine sweat glands are present throughout your body. E for everywhere. E for everywhere will be there, right? So they will be present everywhere. Ecrine are going to be present everywhere, beta. ये सब जगह होगी, right? Then we have got what? Then we have got sebaceous gland, beta. Sebaceous gland are going to produce what? Sebum, and sebum is responsible for what purpose? ये sebum कहाँ से निकलेगा? ये sebaceous gland है. ये sebum यहाँ से निकलेगा along with the hair follicle again, right? So it is going to open along with the hair follicle again. It is going to be absent in your palm and soles. ये कहाँ absent होगा? आपके palm और soles में absent होगा. And breast are going to be the example of this particular one. Breast के ऊपर क्या होता है बेटा? आपके Montgomery tubercles that we are having. Montgomery tubercles, they are the example of what? Sebaceous gland बेटा. Sebaceous gland, है ना? Mammary gland itself is example of what? Modified apocrine gland. Mammary gland itself is example of modified apocrine gland, whereas this Montgomery tubercles on the breast are going to be example of sebaceous gland. Sebaceous gland. अगर ये sebaceous gland कहीं पर और present है, for example like we are having in the eyes. In the eyes we call it what? Zeiss gland or Mobian gland. Okay. In prepuce we call it Tyson's gland. इनका function क्या होता है? To produce the sebum, right? And if you find ectopic sebaceous gland, this is known as which disease? This is known as psoriasis spot, right? Psoriasis sports. So you can appreciate this small sebaceous gland that we are having over here. This is going to be what? This is going to be Fordyce's sport, है ना. ऐसा एक disease हमने ऊपर पढ़ा था, that is your Fox Fordyce's disease, where you will be having multiple bumpy papules will be there, which is going to be what? Which is going to be Fordyce's disease, है ना. वो sweat gland का था, ये sebaceous gland का है, ये self resolving है, इसमें कुछ नहीं करना, right. अगर इनका इन्फ्लामेशन हो जाए बेटा, इफ देर इज इन्फ्लामेशन ऑफ दिस sebaceous gland, व्हाट इज गोइंग टू हैपन, यहाँ से सीबम बाहर आ रहा है नॉर्मली, है ना. आप फेस वॉश कर रहे हो, ये सब चीज़ें ठीक चल रही है, एवरीथिंग इज फाइन, नो इश्यूज, है ना. यहाँ से क्या बाहर आ रहा है बेटा, सीबम बाहर आ रहा है. बट व्हाट इज गोइंग टू हैपन, व्हाट इज गोइंग टू हैपन बेटा ओवर हियर, यहाँ से क्या होगा, यहाँ से जो भी चीज़ें बाहर आएगी, वट एवर थिंग इज गोइंग टू कम आउट फ्रॉम हियर इज गोइंग टू गेट ब्लॉक्ड, है ना. यहाँ से जो भी चीज़ें बाहर आ रही है, अगर वो ब्लॉक हो गई बेटा, अगर वो बंद हो गई, अगर वो ब्लॉक हो गया, तो क्या यहाँ पर ब्लॉकेज हो जाएगा. ब्लॉकेज की वजह से क्या यहाँ पर एक्ने हो जाएगा. यस, दिस इज द रीजन फॉर व्हाट, acne. If there is inflammation of this pilosebaceous unit, this is particular thing is known as what, pilosebaceous unit. And if there is inflammation of this pilosebaceous unit, what is the disease that is going to happen, that is known as what beta, that is known as acne. Acne formation can be there. Now what is the most common bacteria which can cause acne, the most common bacteria is going to be Propionibacterium acne, है ना. एग्जाम में उन्होंने क्या किया है, Propionibacterium की जगह दूसरा नाम दे दिया. What is another name for this particular one is going to be Cutibacterium. Cutibacterium याद रखना है, ठीक है. So we can get the most characteristic lesions. These are going to be your comedones. We have got black color comedones, we have got white color comedones, we have got black heads, we have got white heads, right. Then we have got mild to moderate disease में we have got retinoids, we have got adapalene, we have got tretinoin like drugs, right. We can give adapalene, tretinoin to the patient, right. These are the retinoids. Okay, in moderate acne we are going to give topical retinoids plus antibiotics, topical antibiotics. What is the topical antibiotic you can add on, this is going to be clindamycin, right. Here moderate to less severe cases you can give topical retinoids plus oral antibiotics. Now you can change the antibiotics to oral one, and ultimately if nothing is working, you can give oral retinoids to this patient like isotretinoin. In the last exam they have asked about the dose of the isotretinoin. This is going to be 0.5 to 1 mg per kg per day. This is going to be the dose. But remember, this tretinoin or isotretinoin is what kind of drugs, this is the teratogenic drug beta. ये teratogenic drug है ना. So you need to be very very cautious because it is a derivative of vitamin A, and this vitamin A derivatives can cause what, they can cause dryness on the skin, right. It is a fat soluble vitamins that can store in the body, it can store in the ito cells, and it can cause what, teratogenicity, right. अगर देखो एंड्रोजेंस का लेवल बढ़ गया, if someone is taking androgens if there is increase in the levels of androgen in the cases of puberty, है ना. प्यूबर्टी के टाइम पे क्या होता है बेटा, एंड्रोजन बढ़ जाएंगे, और अगर एंड्रोजन बढ़ जाएंगे तो क्या सीबम प्रोडक्शन बढ़ जाएगा. yes, sebum production will also increase because of androgen increase, and if there is increase in the sebum production, more blockage will be there, and if there will be more blockage, beta, what is going to happen, no sound beta, can you hear me. If there will be more blockage from my end, it's okay beta, na. If there will be more blockage, what is going to happen, you will be having more acne formation, बहुत सारा acne formation हो जाएगा. That is why it is happening, है ना. Normally if someone is getting puberty, तो puberty के टाइम पे क्या होता है, patient को acne बढ़ जाते हैं ना, acne production बढ़ जाता है. This is going to be because of the increase in the sebum production, right. What is the treatment, you can give salicylic acid in the beginning phase, in the first phase, like normal face wash that you are having, they are going to have what, the salicylic acid, right. Drug induced acne क्या होता है, if someone is taking steroids, है ना. How you will get to know that person is taking steroids, what is the thing you will be having, monomorphic comedones, है ना. same morphology के lesions होंगे on the back, you can appreciate. This is a acne which is because of the drugs, है ना. तो drug induced acne you can identify, अगर कोई steroid भी ले रहा है, they will be having what kind of acne, You will be having monomorphic lesions will be there, and this will be having what? Absence of comedones beta है ना, comedones नहीं होंगी. You will be having multiple lesions on the back, and this will not have the comedones. ठीक है. What is rosacea? Rosacea is going to be due to chronic inflammation of sebaceous gland, right? With the dilatation of all the vessels, you will be having on the face, you will be having this particular type of appearance. This is known as what? This is known as rosacea. ये कैसा लग रहा है? This is known as rosacea. You can appreciate the dilatation of the vessels over here. You can appreciate the dilatation of small vessels. I have already told you, if any vessel is going to get dilated, you will be having what? You will be having what? You will be having redness. You will be having erythema. You will be having visibility of that erythema, right? So this is the rosacea, which is going to have what? Chronic inflammation of sebaceous glands with dilatation of the vessels, right? What are the triggers? It can be due to alcohol. It can be due to spicy food. Your sunlight exposure can also lead to this particular thing in certain patients. Lesions will be having papules, pustules, but remember, comedones are going to be absent because this is not a pilosebaceous unit which is going to get infected over here. This is comedones will not be there. Sites will be facial convexities. You will be having this particular thing on this particular part. Treatment will be, you will be avoiding the triggers. Every time you have alcohol, you will be having this blushing, like redness will be there. You avoid the alcohol. You avoid antibiotics. You take antibiotics. You take what? Vasoconstrictor drugs. Levocetirizine is also going to be very, very helpful here. The next entity we have got is rhinophyma beta. Rhinophyma is going to be potato nose. It is the hypertrophy of which gland? It is the hypertrophy of the sebaceous gland and fibrosis of the sebaceous gland that we will be having, right? This is known as rhinophyma. We have discussed about the rhinoscleroma. We have discussed about the rhinoscleroma. We have also discussed about the rhinosporidiosis. Rhinosporidiosis. है ना. Rhinoscleroma is sclerosis से याद रखना. This is going to be nothing but your woody nose beta. Woody nose, which is due to a bacteria Klebsiella, है ना. Klebsiella is the bacteria which is going to be there, and rhinosporidiosis is due to Rhinosporidium seaberry, which is a protista, है ना, where you will be having mass coming from the nose. You will be doing what? Functional endoscopic sinus surgery, right? फेस करोगे यहाँ पर, right? This is going to be the thing. Rhinophyma is potato nose or potato nose like tumor, right? ये तीनों चीजें याद होनी चाहिए. Rhinophyma, rhinoscleroma, rhinosporidiosis, all of them are going to be different, है ना. Rhinoscleroma में आपको biopsy पे क्या मिलेगा? You will be finding which cells? Mucoid cells and Russell bodies will be there. Mucoid cells and Russell bodies will be there. Okay, beta. Next thing we are going to discuss is about another chapter. This is going to be your Papulosquamous disorders. The another chapter we have got is Papulosquamous disorder. Papulosquamous disorder मतलब यहाँ पर हम लोग in Papulosquamous disorder we are going to learn about the papules, we are going to learn about the plaques, we are going to learn about the squamous, means you will be having scaling, right? So we will discuss about the Papulosquamous disorder. Okay, the first one we have got is psoriasis. Psoriasis is going to be a autoimmune kind of disorder beta. It is a T cell mediated disorder where you will be having psoriasis, you will be having lichen planus and pityriasis rosacea. ये तीन disorder हमको इसमें पढ़ने. Three things we are going to see over here in this particular chapter. Three things we are going to discuss. First disease is psoriasis. Second is going to be lichen planus. Third one is going to be rosacea, pityriasis rosacea, है ना. तो पेपुलो का मतलब तो हो गया प्लाग या प्लैक, पेप्यूल्स विल बी देयर. स्क्वामस का मतलब हो गया स्केलिंग विल बी देयर. So remember here also we are going to find what? Scaling. What is the most common site for this psoriasis beta? Psoriasis is going to be, most common site is going to be extensor surface, है ना. ये मोस्ट कॉमन साइट क्या होता है इसका? बाहर वाली सरफेस पे होगा, एक्सटेंसर सरफेस पे होगा. Most common type of psoriasis is going to be psoriasis vulgaris beta. Psoriasis vulgaris is the most common type of psoriasis. What are the things you will be finding? This is going to be your polish is the mnemonic. P for pitting will be there. O for oil drop sign will be there. L for OL together. This is going to be what? Oil drop sign. Okay. This is going to be onycholysis will be there. I for irregular pitting will be there, and as such is going to be in the favor of subungual hyperkeratosis. क्या क्या मिलेगा psoriasis में? First thing you will be having is going to be beta pitting. Pitting is going to be there. What kind of pitting is this? This is going to be regular, irregular, deep or superficial. Okay, so this is going to be deep pitting. Regular hoga, irregular hoga, this is a irregular disease, you will be having irregular pitting, right? So you will be having deep irregular pitting will be there. What else you will be having? You will be having a loss of this nail. This is known as onycholysis. This is known as onycholysis will be there. You will be having this patch like structure. This patch is known as which patch? This patch is known as Salmon patch. Yes, and turnover time is going to change to 4 to 8 days beta, hai na? 4 to 8 days. Worn off ring will be there. This is going to be the worn off ring. When you try to remove this worn off ring, okay, so you will be having a membrane around it. This membrane is known as what? Berkeley's membrane. Around it there will be a membrane over it. This is known as Berkeley's membrane. And when you try to remove this Berkeley's membrane, what is going to happen? You will be having pinpoint bleeding will be there. When you try to remove this membrane, you will be having appearance of pinpoint bleeding, and this particular test is known as what? This test is known as Grattas test, and this sign is known as pinpoint bleeding sign is known as what? Auspitz sign. Very, very important, your previous year exam question. Okay, so what is going to be there? You will be having this worn off ring halo around this particular thing. Around the lesion, you will be having this type of halo. They have asked this question about the Salmon patch, right? They have asked a question about the Salmon patch. They have asked a question on the Berkeley's membrane. When you try to peel off this Berkeley's membrane, when you try to remove this Berkeley's membrane, what is going to happen? There will be appearance of this pinpoint bleeding, and this pinpoint bleeding appearance is known as which sign? This is known as Auspitz sign, and this test is known as which test? This test is known as Grattas test. Very, very important. All these things are important questions that has been asked. They have asked a question from dermatology about subungual hyperkeratosis. They have asked a image based question on this particular Salmon patch. They have asked a question on this Grattas test, Auspitz signs, right? They have asked questions on pitting also, right? All these things are very, very important and important keywords. Then we have discussed about this histopathological slides. If you can understand this histopathological slides, very, very good, right? So what is going to happen? We will be having epidermis, we will be having dermo-epidermal junction, and then you will be having dermis, right? This part of epidermis which is trying to invaginate into dermis is known as what beta? इस part को क्या बोलते हैं हम लोग? The part of epidermis which is trying to invaginate into dermis, this is known as rete. This is known as rete. Whereas the part of dermis which is trying to go into epidermis, this is known as dermal papilla beta. This is known as dermal papilla. So we have got rete, we have got dermal papilla, right? So this is going to be the first thing. Can you appreciate? You will be having what? Elongated rete will be there. Elongated rete ridges will be there, or there will be very deep rete ridges will be there. First thing. Second thing you can appreciate over here, this is going to be what? This is going to be the pustules that you can appreciate. This is going to be known as what? Kogos pustule. This, spongiform pustules of Kogos. These are your Kogos pustules, right? This is the accumulation of abscess over here. This is known as which abscess? This is known as Munro's microabscess. Okay, you will be having appearance of this nucleus in the stratum corneum. You can appreciate the nucleus in the stratum corneum. This is known as parakeratosis. All these things are going to be the features, है ना? ये सारे किसके features है बेटा? Psoriasis के. Psoriasis will be having what? Parakeratosis, मतलब presence of nucleus will be there. और क्या मिलेगा psoriasis identify करने के लिए? You will be having Kogos pustule. You will be having Kogos pustule. You will be having Munro microabscess. You will be having what? Munro's microabscess, Kogos pustules. Okay, you will be having elongated rete ridges will be there. And you will be having what? Hyperkeratosis. You will be having increased in the deposition of keratin. Right, these are the things. This is how we are going to make the diagnosis of this particular thing. Anything out of them you will be finding in the question, you will be marking it as what? This is a question from the psoriasis, right? And then we have got what? Then we have got different types of psoriasis. We have got scalp psoriasis, where you will be having the silver white scaling on the scalp. We have got this pustular psoriasis. If you are having scales along with the pus, this is known as pustular psoriasis. And in fact, the drug of choice for this pustular psoriasis is going to be what, beta? This is going to be acetretin, which is going to work for 3 years, है ना. इसका साइड इफेक्ट कब तक रहेगा? It is going to be teratogenic for 3 years. Acetretin, right? Then we have got this gutter-like structures that you can appreciate. This is going to be what? Guttate psoriasis. After a upper respiratory tract infection, if patient is having this type of psoriasis, this is known as guttate psoriasis. Treatment is going to be what, beta? You need to give what? Antibiotic to the patient. Then we have got psoriasis on a flexural surface. This is going to be what? This is going to be your inverse psoriasis. Drug of choice for inverse psoriasis is what? Methotrexate. Methotrexate is the drug of choice here. Then we have got what? Erythrodermic psoriasis, red color psoriasis or erythrodermic psoriasis. Drug of choice is going to be what, beta? Again, methotrexate. Erythema का मतलब ही क्या होता है? Red. So you will be having redness on the skin, and psoriasis will be there. The drug of choice will be what? Methotrexate, beta. Methotrexate. And lastly, we have got what? Impetigo herpetiformis. Impetigo herpetiformis is a psoriasis in pregnancy. What is the thing that you can use over here? You can give steroids, you can give cyclosporin. Can you give methotrexate? No, it is going to be teratogenic. It is going to kill the fetus here, right? तो methotrexate यहाँ पर नहीं देना, right? It is going to be anti-cancer drug which is going to kill the any cell which is going to be dividing rapidly, right? And fetus is something which is going to divide rapidly, so that can be dead. In fact, in the cases of in certain cases you are definitely using what? You are using this drugs, है ना. कई जगह तो आप इसको काम में ही लेते हो, मोल वगैरह डिलीट करने के लिए you are using this thing, right? So we have discussed about this thing by so far. Now, what is the pathogenesis of this particular one, right? Pathogenesis is going to have what? Chronic inflammation due to T cells will be there. Epidermis में क्या मिलेगा बेटा? Psoriasis में you will be having hyperkeratosis. That is why you are having what? You are having on the nails. You will be having what? You will be having accumulation of what? This particular keratin deposition will be there. Epidermal transit time will be decreased to 4 to 8 days. That is going to be 4 to 8 days will be their epidermal transit time. Associated with certain genes, what are the things we are having? HLA CW6 and HLA B27. B27 has got lots of other associations also, but this CW6 is going to be here for the psoriasis, right? We can have psoriatic arthritis, and this psoriatic arthritis is going to show you penicillin cup deformity and Sosa's digit. Very, very important radiological and orthopedics finding that penicillin cup deformity you will be having, and you will also have this Sosa's digit, right? In dermis you will be having inflammation, and you will be having activation of T helper 1 and T helper 17 cells, right? Other system association is going to be what? You will be having this particular disease associated with the atherosclerosis. This is associated with the atherosclerosis and certain metabolic syndromes also. Treatment क्या करोगे? In the beginning phase you will like to use what? Scaling is there, so you want to remove the scaling. You can give what? Moisturizers, you can use steroids, you can use coal tar in this particular patient in the beginning. You can also give phototherapy to this particular patient. Phototherapy, narrow banded UVA phototherapy. You can give Soralin UVA phototherapy. Soralin is working as a photosensitizer, right? You can also use methotrexate, which is a DHFR reductase inhibitor, right? You can give it for plaque psoriasis, pustular psoriasis, and erythrodermic psoriasis. Can anyone tell me where else do we use this methotrexate? Methotrexate और कौन सी डिजीज में आप लोग यूज में लेते हो commonly in the orthopedics, right? We can use cyclosporin as steroids if it is causing this particular thing in the pregnancy. This is going to be, we can also use calcineurin inhibitors, right? Acetretin is the drug of choice for pustular psoriasis. If less than 10% body surface area is covered, how we will assess? If 10% or less than 10% body area is covered, we can give the steroids to the patient, we can give tazarotene, we can give emollients or like lotions we can give to the patient, emollients. अगर 10% से ज़्यादा बॉडी सरफेस एरिया कवर्ड है, वी कैन गिव व्हाट पुआ, वी कैन गिव सिस्टमिक drugs to the patient, we can use systemic drugs to the patient. Interleukin 17 inhibitor, this is going to be secukinumab, we can use secukinumab. PD4 inhibitors like apremilast and TNF alpha blocker like acute girl, adalimumab, certolizumab, ustekinumab, right? These are the drugs you can use, etanercept and golimumab. These are the acute girl. This is going to be what? TNF alpha blockers, right? So we can use any of them. This is about the psoriasis. Definite one question they will be asking you about psoriasis, important one, right? Second thing we are going to discuss about the lichen planus beta. Lichen planus is going to be a very chronic immune disease. This disease is also known as what? 6P disease. इस disease का दूसरा नाम क्या है? 6P disease. Why we call it 6P? Because you will be having 6 P's. What are those 6 P's that we are having? You will be having plain, you will be having purple, polygonal, pruritic, papules will be there, and these are going to be associated with the pterygium. So sometimes we call it 6P or 5P disease also. Very good. In rheumatoid arthritis we can use what? methotrexate, है ना? methotrexate rheumatoid arthritis में देना है, उसके साथ में फॉलिक एसिड भी देना है. लेकिन जिस दिन आप methotrexate देते हो, the day you are giving methotrexate, we are avoiding what? folic acid, है ना? It's not necessary, but yes, in certain literatures we are doing that, so we do that. Like for example, we need to give it weekly. तो मंडे को अगर यू आर गोइंग टू गिव दिस methotrexate टू द पेशेंट, तो मंडे को आप क्या करोगे? फॉलिक एसिड नहीं दोगे साथ में. रेस्ट 6 days you can give folic acid to the patient, right? So these are going to be your plain purple polygonal pruritic papules beta. These papules you can appreciate over here. Can you appreciate? These are the lesions we are having. They are going to be plain topped, है ना? ये जो lesions हैं, these are the plain topped lesions. They are polygonal. They are going to be pruritic. They are going to be purple, and you can also appreciate here you will be having what? pterygium. You can have the pterygium where the lateral where the proximal nail fold is going to divide the nail into 2 halves. दो भाग में विभाजित करेगा, दो भाग में डिवाइड करेगा. It is going to divide it, this particular thing, into 2 halves. This is going to be pterygium. Okay, along with that you will also have this type of white reticular lacy pattern on the mouth, on the mucosa involvement will be there. This is going to be very characteristic of what? Wickham stria. This is known as what? Wickham stria. This is known as what beta? Wickham stria, right? What are the triggers? Remember these 2 triggers you have to remember. They have got association. Hepatitis C, which is the most chronic type of hepatitis that we are having, which can cause hepatocellular carcinoma also, which can cause cirrhosis also in the patient, right? And second thing we have got is dental amalgam. Dental amalgam can also cause this particular thing, right? Dental amalgam and hepatitis C. Then on the histopathological examination, you will be finding what? You will be finding seaweed bodies, Max Joseph cleft space, hypergranulosis, and remember here the red ridges are going to be what? These red ridges are going to be sawtooth in appearance, right? So you will be having this sawtooth red ridges. कैसी red ridges होगी बेटा यहाँ पर? Sawtooth red ridges will be there, right? You will be having Max Joseph cleft space. You will be having what? Seaweed bodies. You will be having seaweed bodies. You will be having Max Joseph cleft space. This space is known as Max Joseph cleft space. You will be having seaweed bodies. You will be having hypergranulosis, है ना? वहाँ क्या था? Hyperkeratosis. ऊपर क्या पढ़ा था? Hyperkeratosis. यहाँ कौन सी लेयर बढ़ जाएगी? Hypergranulosis, है ना? Granulosis will be there. We can also have one disease on the hairs. You can have Lichen planopilaris, which is a scarring type of alopecia. हम लोगों ने पढ़ा था वहाँ पर Lichen planopilaris, which is a scarring type of alopecia beta, right? It is going to show you one phenomena. That phenomena is known as isomorphic phenomena. क्या बोलते हैं उस phenomena को? isomorphic phenomena. Iso means same, morphic means morphology. So whenever you have a lesion, the same morphology lesion will be beginning over here, right? So what is going to happen? For example, if I am going to have some trauma over here and I am a psoriasis patient, what is going to happen? At the site of the trauma, I will also have the psoriasis. So this is known as isomorphic phenomena. It is seen with the psoriasis, it is seen with the lichen planus, it is seen with the vulgaris, it is seen with the vitiligo, not vulgaris. It is also seen with the vitiligo beta, vitiligo. Right, so this is going to be seen with the vitiligo, lichen planus and psoriasis, whereas the pseudo cobnerization or false cobnerization that you will be finding this thing in the molluscum contagiosum. Molluscum means soft, contagiosum means highly infectious nodules will be there, pearly white umbilicated nodules will be there on the skin, which is due to immunodeficiency state, and these lesions are going to spread by touching, right? So what is going to happen? You are going to touch your lesion, and now you are touching it over here. What is going to happen? This molluscum contagiosum will come over here, right? And this thing is going to another person also. So we have got two types of phenomena. One is known as isomorphic phenomena. This isomorphic phenomena is characteristic of what? This is characteristic of what? These lesions, psoriasis, lichen planus and vitiligo. They will be showing what? Isomorphic phenomena. Whereas this pseudo cobnerization, false isocobner phenomena, false isomorphic phenomena, this isomorphic is also known as Kobner phenomena. So false Kobner phenomena is seen with molluscum contagiosum बेटा, है ना? False Kobner कहाँ मिलेगा? Molluscum contagiosum में मिलेगा. और warty lesions, कोई भी wart वाला infection हो, virus वाला infection हो, वहाँ मिलेगा. Then we have got a special term. This is known as lichen nitidus. This lichen nitidus beta, this lichen nitidus will be having what? Also known as mini lichen, where you will be having tiny skin colored bumps will be there, skin colored bumps over the extensor surface. कौन सी surface पे होगा बेटा ये? Extensor surface पे, elbow में tiny colored skin colored bumping will be there. On histopathological identification, this is very important. You will be finding this sign. You will be finding this sign. This sign is known as what? Ball in claw appearance. This sign is known as ball in claw appearance. Okay, ball in claw appearance. This sign is known as ball in claw appearance. Ball in claw appearance will be there, right? Treatment will be, it is going to be self-resolving thing. You can apply topical steroids over here. Topical steroids आप यहाँ पर दे सकते हो, but generally it is going to be a self-resolving thing. Lastly, this infection, this disorder that we are having is going to be your pityriasis versicolor. Pityriasis rosacea. Versicolor we have already seen, right? Versicolor is going to be another one. This is your pityriasis rosacea, where you will be having this red color patch beta, na? Red color ka patch hoga on the back, on the trunk, and this patch will be radiating all the way like in a Christmas tree pattern, na? What is going to be the pattern beta here? This is going to be a Christmas tree pattern. So you will be having the first patch. This first patch is also known as mother patch. This first patch is also known as herald patch. And generally this thing is going to be asymptomatic. It is going to be acute disease. Most common trigger is going to be HHV7. HHV7, important, human herpes virus 7, which is also known as 6-7, is going to cause what? Xanthum subitum, and also cause roseola infantum, right? You will be having this red color plaque present on the trunk. First patch is known as mother patch, also known as herald patch, and then you will be having this Christmas tree appearance will be there. When you are going to see the scales of this particular person, you are going to see the scales, you will be finding collarate of scale, collar like scaling will be there, collar like scaling. You will be having cigarette paper like scaling, collar like scaling, cigarette paper like scaling. You will be having a sign, this is known as hanging curtain sign will be positive. Which sign will be there? Hanging curtain sign will be positive. Generally it is a self-resolving condition. You apply emollients, you apply steroids, and it will be fine, right? So this is pretty much about the pityriasis rosacea. Pityriasis rosacea, right? So we have learned about three important things in Papulosquamous disorder. This is going to be psoriasis, this is going to be lichen planus, and this is going to be what? This is going to be rosacea, right? Next thing we are going to discuss is about the infections. So we have got bacterial infections. What are the bacterial infections we have got? कौन से bacterial infection होते हैं? These are going to be your pyodermas, we can have skin infections. So we can get skin infections on the basis of location only, right? So location के हिसाब से एक बार देख लेते हैं. So superficially we have got what impetigo, it can be bullous impetigo, it can be non-bullous impetigo. Bullous impetigo will be having bulla formation, that is going to be due to staph most commonly. Second is non-bullous impetigo, that is due to what? That is due to स्ट्रेप्टो बेटा, स्ट्रेप्टो की वजह से होगा ना. नॉन बुलस इम्पेटिगो, हनी कलर्ड क्रस्टिंग. सो वी हैव डिस्कस अबाउट द इम्पेटिगो. देन वी विल डिस्कस अबाउट सर्टेन टाइप्स ऑफ एक्थाइमा. वी हैव गॉट मल्टीपल टाइप्स ऑफ एक्थाइमा बेटा. Then we will discuss about the erysipelas. Then we will discuss about the cellulitis. Remember, this cellulitis will go deep into the subcutaneous tissue. ये cellulitis यहाँ तक आ जाएगा, नीचे तक subcutaneous tissue, right? Then we can have deep fascias, you can have muscles, so you can have necrotizing fasciitis, and this necrotizing fasciitis can be due to staph also, है ना. ये staph की वजह से भी हो सकता है. And you can also have this infection, like deep infections. This is due to Clostridium also can cause this, right? You can have osteomyelitis. The king for osteomyelitis is what? This is nothing but your Staph aureus, right? It can go to the bones, right? Staph aureus is the king, right? So we have got this bacterial, viral, fungal, parasitic skin infections. We are having epidermis tak. You can have dermis, you can have subcutaneous, you can have deep fascia, muscle, you can have bones, and you can have this artery vessels and nerves, right? You can have this necrotizing fasciitis till this particular part. So let's try to understand what is folliculitis, what is bacterial infections, like what is folliculitis, what is furuncle, what is carbuncle, है ना. तीनों चीजें देख लेते हैं. folliculitis, furuncle and carbuncle. You can appreciate there will be loss of single follicle is involved. If there is inflammation of a single hair follicle, it can be papular, it can be pustular, है ना. इसको बोलते हैं folliculitis. It can happen generally around the face also. Papular, it can be pustular. Pus भी हो सकता है, it can be normally papular also. This is known as what? Folliculitis. Here remember, single hair follicle is involved. Single hair follicle is involved. This is known as folliculitis, right? Second thing is going to be your furuncle. Furuncle में क्या होगा? Folliculitis तो हो गई, साथ में there will be involvement of a follicle. Along with that, you will be having parafollicular area will be involved. You can appreciate this is going to be what? Single follicle is involved. Along with that, parafollicular area is going to get involved. This is going to be what? This is known as furuncle. ये ऐसा दिखेगा. Parafollicular area is going to get involved, right? And then you have got what? Then you have got carbuncle, and this carbuncle, multiple follicles are going to get involved, like in generally happening in the nape of the neck, and those patients who are diabetes mellitus associated disease, right? Associated with diabetes mellitus. So this is going to be what, beta? This is going to be carbuncle, right? Due to carbuncle you can have, right? Then we have got what? Then we have got another infection. This is known as erythrasma. So basic समझ में आया, what is folliculitis, what is furuncle, what is carbuncle, right? Then we have got another infection, beta. Another infection is going to be what? Erythrasma. Another infection we have got is erythrasma. Erythrasma is due to Corynebacterium minutissimum. Corynebacterium diphtheria is going to cause what? Diphtheria. Corynebacterium minutissimum we have discussed in micro also. This is going to cause what? Erythrasma. And this erythrasma is due to what? It is due to this color that you are appearing, that color that is coming, that is going to give you on wood lamp examination, it is going to give you coral red fluorescence. And why this coral red fluorescence? It is due to corpoporphyrin 3. Corpoporphyrin 3 is going to be responsible for this coral red fluorescence, right? This is the wood lamp exam that we have been talking about, right? Here you will be having this reddish brown color pigmentation that you can appreciate. This is going to be erythrasma. What is ecthyma? We can have ecthyma pyogenicum, we can have ecthyma gangrenosum, right? We can have ecthyma contagiosum. Pyogenicum is going to be with the pyogenes, beta, streptococcus pyogenes, right? Gangrenosum is due to Pseudomonas, which is a nasty bacteria we have got, right? And parapox virus is going to cause what? Ecthyma contagiosum. Ecthyma contagiosum, right? We have got impetigo. Impetigo can be two types of impetigo. We can have bullous impetigo. Bulla will be there. There is a fluid filled cavity, clear viscous, clear fluid filled cavity, that is known as bulla, more than 1 centimeter. So we can have this type of infection. This is bullous impetigo. We can have non-bullous impetigo, where you will be having this dried up exudate, right? This dried up exudate is known as what? Honey colored crusting. You will be having what? Honey colored crusting. This is known as dried up exudate, right? These are your superficial bacterial infection. Remember, this is going to be caused, non-bullous is due to streptococcus followed by staph, whereas here you will be having what? Staph followed by strepto. So this is going to be the opposite thing. Here you will be having epidermolytic toxin leading to what? Bulla formation, and treatment will be mupirocin. For cellulitis versus erysipelas, remember both of them appear similar from outside, but this cellulitis is going to be deeper thing. It is going to invade till your subcutaneous, right? Whereas this erysipelas is going to be what? Superficial infection. It is going to be superficial skin infection with a demarcated margin. Here the margins are not going to be demarcated, right? This is going to deeply invade the lesion till hypodermis. This is a superficial lesion. Okay, it is generally happening because of group A beta hemolytic streptococci, right? This is cellulitis. Most common cause is going to be what? Staph aureus. Staph is the most common cause for this cellulitis, and the treatment is going to be what? Amoxicillin, right? This is what we are using in this particular case, right? Here you will be having group A beta hemolytic streptococci. In this particular case, it is going to be superficial, and treatment will be what? Again, you can use the same group of drugs also, right? Then we have got what? SSSS. What is staphylococcal skin scalded syndrome? It is due to staph aureus. Staph means grape-like clusters. Aureus means golden yellow color. Okay, gold will be AU, right? So you will be having ETA, ETB toxin making antibodies against what? Desmoglein, making this damage against desmoglein. And this desmoglein is responsible for the connection of two keratinocyte. अगर यहाँ पर एंटीबॉडी बन गया, कुछ भी आ गया, टॉक्सिन आ गया, क्या होगा? टूट जाएगा. अगर ये टूट जाएगा तो क्या बॉडी में स्किन स्काल्डिंग होना स्टार्ट हो जाएगी? यस, दैट इज व्हाई वी आर हैविंग स्टेफाइलोकोकल स्किन स्काल्डेड सिंड्रोम. We can also have Steven-Johnson syndrome. We can also have toxic epidermolysis necrosis, TEN and SJS. Right? They are going to affect what? Skin and mucosa also. SJS, we call it if it is covering less than 10% of body surface area. If it is covering more than 30% of the body surface area, this is considered as what? 10. Overlap is between 10 to 29 is going to be overlap syndrome. Remember, in anthrax also you will be having cutaneous anthrax. Those people who are carrying the dead animal, they will be having black color malignant pustule. Malignant means it is not cancerous. It is going to be known as what? Hyde-Porter's disease, where you will be having this black color scar will be there, right? Another patient you will be having is scrub typhus patient, where you will be having black color scar will be there. Along with that, you will at the site you will be having, along with that you will be having erythema, fever, lymphadenopathy, all this malaise, all these things will be there, right? It is going to be a Laus-borne disease, tick-borne disease, mite-borne disease. So your answer will be Laus, flea, tick, mite. Remember, we remembered the mite. So it is going to be a mite-borne disease. You will be having Orencia sushugamushi, right? And the larva is known as shigerosis, right? And the drug of choice is going to be what? Doxycycline for all of these particular cases. For the pyoderma skin infection, the treatment will be, you can apply what? Fusidic acid over here, or you can also apply mupirocin ointment, right? This is the basic thing we are having. Then we will discuss about the fungal infection. The first fungal infection, very important, is going to be what, beta? This is going to be your pityriasis versicolor. Pityriasis means scaling and versicolor mean different color. Versicolor matlab different color. So you will be having different color matlab hypo and hyperpigmentation will be there. Hypo and hyperpigmentation will be there. And this is due to which acid? This is due to azelaic acid beta. कौन सा एसिड की वजह से होगा? एजेलिक एसिड की वजह से होगा. इंक्रीज इन मेलानोसोम्स विल बी देयर लीडिंग टू व्हाट? हाइपरपिगमेंटेशन. Azelaic acid is going to cause what? Hypopigmentation. Color discoloration will be there. Azelaic acid. Causative agent is going to be the previous question, Malassezia furfur and Malassezia globosa. Furfur and globosa are the causative agent we have got. And fine brany scales, you will be finding fine brany scales. On microscopy, you are going to find this type of appearance on a, you can call it like KOH mound you will be making, you will be finding spaghetti and meatball appearance, also known as banana and grapes appearance. Very, very important entity. Spaghetti, meatball, banana and grapes appearance. Right? Onward lamp examination, yellow orange color will be there. Treatment is going to be what? Selenium sulfide. When you are going to put the same thing on SDA beta, when you are going to put the same thing on Sebro dextrose agar, what is going to happen? It is going to give you fried egg colonies. Fried egg colonies. But remember, you need to put what? Olive oil. Then you will be getting what? Fried egg colonies will be there. Next one we have got is the pedra, which is a superficial hair nodule infection that we are having, right? We can have black pedra, this is due to horte. We can have white pedra, this is due to bijli. So white pedra is due to bijli, black pedra is due to horte. Pedra horte is going to cause what? Black pedra, and bijli is going to cause what? This is going to cause what? White pedra. Bijli is going to be light, light is going to be white. Treatment will be azoles. The ultimate treatment is going to be what? Shave the head. So this is something you will be finding in those Baba. You know Baba, those people who are having long hairs, है ना? तो उन लोगों में क्या होता है? This pedra infection is going to be common. Then we have got dermatophytes, which are going to be superficial skin infections that we have got, right? These are good. The skin infection which are going to be what? They are going to be erythematous, means they will be red, they will be pruritic, and they will be having annular plaque. Annular plaque will be there, right? So they will be having active margins and they will be having central clearing. These are going to be your dermatophyte infections. So first one we have got is trichophytone. This is going to be involving all three structures: hairs, nails and skin, right? Epidermophytone is not going to infect what? Hairs. E के बाद में H आता है, it is not going to infect hairs, right? It is going to infect nails and skin. H M के बाद में N आता है, it is not going to infect the nails, it is going to infect the hairs and skin. So they are skipping their पड़ोसीज, है ना? इनके पड़ोसियों को छोड़ रहे हैं, बाकी सबको इन्फेक्ट कर रहे हैं, right? So we have got two types of tinea capitis beta. We have got tinea capitis, which is scarring type, which is non-scarring type. Scarring type of alopecia is seen with the painful boggy swelling. If you find in any question, you will be marking your answer as Kirion. It is due to tinea mentagrophyte. It is due to tinea verrucosum beta. Tinea verrucosum, tinea mentagrophyte. Whereas if you are finding dense crusting, you are finding scutula, favus, and this is an endemic thing. This is an endemic thing which is you will be finding in the Kashmiri people. This thing you will be finding in the Kashmiri people. This is due to tinea snoleni. Tinea snoleni is going to be there, right? Tinea snoleni is going to be there. Whereas you will be having this black dot and gray patch. These are going to be what? These are due to tinea volutium, and these are going to be endothrix and ectotrix kind of infections. They are non-scarring type of alopecia. मतलब अगर ऐसा कुछ होता है, you will be completely fine after that. You will be having all the hairs regain will be there, right? Then we have got what? Tinea cruris, tinea pedis. Remember the drug of choice for these tinea capitis is going to be what? This is going to be griseofulvin. Next thing we have got is tinea cruris and tinea pedis. Can you appreciate? This is a lesion which is going to have what? Central clearing, right? So this is an annular lesion with a active margin beta, active margin. Tinea cruris is going to be there. This is also known as dhobi itch. It is something that you will be finding in the groin area. Why? Because of lots of moisture, lots of water. Fungus just loves the moisture, it loves the water. Wherever you give water to the fungus, it will be there, right? In rainy seasons, you will be having lots and lots of fungal infections, right? Tinea corporis means it is going to be tinea on the body. Tinea pedis means it is a tinea. Tinea means superficial fungal infection on the pedis, means on the foot. In the athlete, it is also seen because they are wearing socks for all the time and they are running, because of that sweating will be there. So this is going to cause what? Athlete foot. Central scarring is a feature of TB, whereas central clearing is a feature of tinea. Lupus vulgaris is the most common type of skin TB, right? Central crusting is a feature of leishmania beta. Leishmania, है ना? Central crusting is a feature of leishmania. Which leishmania? Leishmania tropica, also known as oriental sore, Baghdad boil, है ना? Delhi boil, Aleppo boil we have discussed, right? Tinea capitis, drug of choice is griseofulvin. Tinea incognito is going to be because of steroid use. 10% QH mount पे you will be finding those refractile hyphae. Drug of choice is going to be what? Terbinafine or cycloperoxamorolafine, amorolafine. These are going to be the nail liquor that we are having that you can apply on the tinea pedis also. Then we have got what? Candida infection. This candida is going to be what? Candida albicans. We can have oral candidiasis, we can have vaginal candidiasis, we can have esophageal candidiasis, candida intertrigo. Okay, so we have got multiple types of candidiasis. This oral candidiasis is going to have what? Pseudomembrane. This is going to have pseudomembrane, also known as oral thrush. Oral thrush. Esophageal candidiasis will be having what? What is the drug that you would like to use? Is going to be what? Fluconazole. Esophageal candidiasis is only going to happen in which patient? Which are neutropenic patient, immunocompromised patient. Intertrigo is going to happening on the intertriginous areas where you will be having plaques, you will be having what? Satellite lesions will be there. Melanopastitis will be having radial fissuring of the skin will be there around the prepuce. This is generally seen in the diabetes mellitus patient. And vaginal candidiasis is going to have what? Beta, you will be having pruritus. Thick white cuddy discharge will be coming along with the pruritus, and on SDA you will be finding creamy pasty color colonies. Okay, KOH mount is going to show you budding yeast cells with pseudo hyphae, and one phenomena that you can appreciate is known as Raynaud-Broad phenomena, also known as germ tube formation. Right, you can also use which agar? Chrome agar for the identification of multiple species. Different species identification, you can use what? You can use the chrome agar. This is going to be the chrome agar. The treatment is going to be what? Fluconazole, you can use clotrimazole, you can use nystatin C. Right, then we have got what? Then we have got chromoblastomycosis. Then we have got what? Chromoblastomycosis beta. Sorry, sporotrichosis first. Let's talk about the sporotrichosis. Sporotrichosis is due to Sporothrix-Schenke. Sporothrix-Schenke, this is also known as Rose-Gardner's disease. This is also known as Valentine disease. Valentine disease, Rose-Gardner disease. Here you will be having this nodulo-ulcerative lesion. And this lesion will be having what? Lymphocutaneous spread will be there. What kind of spread will be there? Lymphocutaneous spread will be there. On histopathological, you will find the asteroid body. What are these asteroid bodies? These are the yeast cells surrounded by pink eosinophilic material. This is just a yeast cell which is surrounded by pink eosinophilic material. This is known as what? This is known as asteroid body. This is known as asteroid body. Central basophilic yeast with pink eosinophilic material. This is going to be what? Asteroid body. Right, treatment will be antifungal you would like to use, and you can also give what? Itraconazole to the patient. You can give itraconazole to the patient. Then we have got mycetoma. Mycetoma is a disease you will be finding in the farmers. Right, normally you will be having a discharging sinus will be there. We can get two types of mycetoma, eumycetoma and actinomycetoma. Actinomycetoma is going to be what beta? It is going to be a bacterial one. E के बाद में B आता है. After E there will be B, and after E there will be F. So it is going to be a fungal one. It is going to be a fungal one. It is due to actinomadurai. It is due to nocardia. Okay, and here you will be having black color granules. Here you will be having white or two yellow color granules will be there. Treatment, here you will be giving antibiotics. This is going to be antifungal, but still they are not working. You need to go for amputation definitely. Okay, we need to do what? Amputation. What is the regimen that we are following? That is known as Welsh regimen, which is going to take care of both the things by giving amikacin plus cotrimoxazole, which is a combination of trimethoprim plus sulfamethoxazole given in 1:5 concentration will convert into 1:20 concentration in blood. Right, this is going to be what? Cotrimoxazole, combination of trimethoprim plus sulfamethoxazole. Right, then we have got some parasitic infections. Two important parasitic infections are going to be there. One is going to be scabies beta. Scabies is going to be happening in the circle of Abra. This is the circle of Abra where you will be having most of the infections. Right, this is also known as Prince itch disease. This is also known as 7-year itch disease. Right, it is going to happen in the family. You will be having, this is known as circle of Abra, is the most common site. Okay, you can have the Sarcoptes scabies, which is a mite which is responsible for this particular disease. And most characteristic lesion that you will be finding are known as burrows, which are going to be present on the stratum corneum beta. Stratum corneum will be having the burrows, right? You can have crusted scabies. This is the Norwegian scabies. This is due to taking of the steroid. This thing can happen, right? This is a worst prognosis beta, and the treatment will be, you can give ivermectin here. Ivermectin you will also use in the onchocerca volvulus in the strongyloid stercoralis, right? There are very few indication of this ivermectin. Two important one I'm telling you: strongyloid stercoralis and onchocerca volvulus, right? Then we have got this burrows. These are the burrows in the stratum corneum, and this particular patient will be having itching. Not just this patient will be having itching. This is known as Prince itch disease. This disease will also spread in the family. All the family will be having the itches. What itching will be there? What we need to do? We need to apply 5% of permethrin to the patient. Below the neck, you will be applying the permethrin in the circle of Hebra. Right, in the circle of Hebra, you will be applying this permethrin, and then you need to put all the clothes into hot water, not just you, all the family. This is how this disease will be gone, right? This is the disease because of dirty environment that can happen, right? You can also use what ivermectin over here also. This ivermectin is going to do what, paralyze this particular thing and kill, right? So this is the combination you can use. In pediculosis, you will be having this pediculosis in children, and you will be having this pruritic pediculosis on the head, right? These are the head louse that we are having. This is going to cause what? Pediculosis on the head, right? Head louse is going to be pediculosis capitis. Then we have got pediculosis corporis, which is a body louse. Corporis matlab body. This is also known as vagabond disease. Those people who are living outside, dirty people, they will be having this particular thing. And if you have this pediculosis on the like pubis, this is known as crab louse, and the most characteristic lesion that you will be having is known as macula seriola. Macula seriola. Right, this is the most characteristic lesion that we are having. How you are going to treat this situation? You are going to give again the same drug. What is the same drug? 1% permethrin, right? This is what you are going to give along with the ivermectin over here, right? But the next thing we are having is the viral infections, and ugly infections are going to be your viral infections. What are the viral infections we are having? These are going to be your molluscum contagiosum. We have got molluscum contagiosum, which is a soft pearly white umbilicated nodule. This is a soft pearly white umbilicated nodule. There will be a dip on the center. There will be a dip on the center, right? It is coming under the pox virus. It is a DNA virus. Yes, it is a DNA virus. DNA viruses are happy viruses, we have discussed, right? Inclusion bodies you will be finding are going to be your Henderson-Peterson bodies. These are going to be your intracytoplasmic eosinophilic bodies. Intracytoplasmic eosinophilic bodies that you will be finding, and it is going to be associated with pseudo cobnerization beta. Cobnerization नहीं मिलेगा, pseudo cobnerization मिलेगा. Treatment will be, it can be self-resolving if your immunity is coming back. If it is not, you can use what? TCA, you can use what? Podophylotoxin, you can use imiquimod, you can use cryotherapy also. Then we have got HPV, human papilloma virus beta. It is also papilloma virus is also a DNA virus, right? So it is going to cause what? Warts. What is the mnemonic that we have remembered every time? This is going to be DSP, come eat a burger. Come eat a burger, right? Come eat a burger. This is going to be, first is going to cause deep warts, second is going to cause what? Superficial wart, third is plan warts, common warts, epidermodysplasia verruciformis, anogenital warts, butcher's wart. How you are going to treat them? You can use salicylic acid, you can do electric cautery, you can remove them with the cryotherapy. Okay, this epidermodysplasia verruciformis is known as tree men, and this 16 and 18 are going to cause what beta? This is going to cause CA cervix, है ना? इनके लिए we have got vaccination, like we have got Cervarix, we have got Gardasil, right? We have got Cervarix, we have got Gardasil, and we have also got nonavalent Gardasil. Okay, we have got Cervarix, we have got Gardasil and nonavalent Gardasil. The next one is going to be human herpes virus. Next one we have got is HHV. Remember, first one was pox virus. That was your molluscum contagiosum was your pox virus. This is your DNA virus, papilloma virus, HPV. Now we are discussing is human herpes virus, HHV. It is also a DNA virus, beta. You can have what? You can have herpes labialis, you can have grouped vesicle around the lips, cold blister will be there, fever will be there. Treatment will be acyclovir 400 milligram TDS into 7 days. Right? The same treatment will be doubled in the cases of shingles. In the shingles, the treatment will be what? 800 milligram 5 times a day and 7 days. This is going to be in the shingles, right? Shingles, you will be finding acantholytic cells. This is due to HHV3. Herpes means grouped vesicle, zoster means along a nerve segment. So you can appreciate there are multiple grouped vesicle along a nerve segment. This is going to be what? Herpes zoster. HHV3 is going to cause what? Varicella, also known as chicken pox, where you will be having this pleomorphic lesions, multiple morphology lesions on the body, and you will be having a specific dew drop on rose petal appearance will be there. Right? Patient will be having fever can be there in the child. You will be having rashes on the body. Right? Instead of giving acyclovir, you can also use valacyclovir 1 gram 3 times a day into 7 days. Right? You can also have allodynia, that means pain will be there with a non-painful stimuli. Then we have got what? Kaposi sarcoma, which is a vascular hemangioma. You can appreciate this type of tumor will be there. This is due to HHV8, human herpes virus 8. This is a purple plague immunocompromised patients are common. Vascular hemangioma, right? Patient who are already having AIDS or patient who are already having TB or some kind of cancers, they are at a more risk of this particular one. HHV5 is also known as cytomegalovirus, going to show you owl eye inclusion bodies. Treatment will be ganciclovir. For all the family, you give acyclovir. For this particular one, you give ganciclovir. Then we have got at hand, foot, mouth disease. This is going to be Coxsackie AE16 and enterovirus 71, where you will be having this vascular lesions on the palm, soles, and buttock and oral cavity. This type of lesions will be present on palm, sole, oral cavity, and buttock. Then we have got oral hairy leukoplakia, beta. Oral hairy leukoplakia, where you will be having this type of corrugated appearance. Can you appreciate this type of corrugated appearance over there? This is something you will be finding generally in the HIV positive patient with white corrugated plaque. Okay, this is going to be cancerous thing, oral hairy leukoplakia, right? This is going to be cancerous thing. What about this parvo B19? It is also a DNA virus, beta. Parvo B19 is also a DNA virus. It is going to cause what? Erythema infectiosum, right? Slab cheek appearance will be there. Bilateral slab cheek appearance will be there. This is known as erythema infectiosum. Malar rash on the face, reticular rash present on the body, right? Then let's take a small break. Let's take a small break and then we will continue from here onwards, right? All right, guys. So the next thing we are going to discuss about is going to be your mycobacterial infections. So what are the mycobacterial infections that we can have, right? The most common type of skin TB is known as what? This is known as lupus vulgaris. Vulgaris means in derma, vulgaris means the most common. So most common type of TB is known as lupus vulgaris, where you will be having what kind of lesions? You will be having apple jelly nodules. Remember beta, on diascopy we are going to find which nodules? This is going to be apple jelly nodules, right? It is the most common type of skin TB that we are having with the central scarring. Remember, central scarring is a feature of skin TB. Most common site is going to be what? These are going to be your face, these are going to be your extremities, these are going to be your buttocks, beta, na? Buttocks, face and extremities are going to be the most common site, okay? So in children you can have what? This scrofloderma is going to be the thing you can have in the children. This is the second most common cutaneous TB in children that is going to be there, and it will be involving your cervical lymph nodes, right? This is what is going to happen. These are your apple jelly nodules that you can appreciate. These are your apple jelly nodules on diascopy. On diascopy you can find what? Apple jelly nodules over here. This is going to be what? Cutaneous TB, right? Then what about leprosy? Is important. Mycobacterium lepra is the organism. Does it follow Koch postulate or not? Remember beta, it is not going to follow Koch postulate. Is it an anti-inflammatory? Is it going to be inflammatory disease? Yes, it is going to be inflammatory disease. It is going to be granulomatous disease. We can have two types of leprosy. Leprosy is also known as Hansen's disease, right? We can have two types of leprosy. We can have paucibacillary, we can have multibacillary. Pauci will be having what? 1 to 5 lesions. Multi will be having more than 5 lesions, beta. Okay, multi will be having more than 5 lesions, right? Zero nerve involvement will be in the paucibacillary. Multibacillary will be having more than 1 to 2 nerve involvement will be there. It is going to be pauci for 6 months and multi is going to be for the 12 months, right? Multi is going to give the treatment. Protocol is going to be for 6 months here, for 12 month here, right? This is going to be the treatment protocol that we are having. Okay, what is the drug that you will be using? The three combination of the drugs we will be using is going to be rifampicin, clofazimine and dapsone, right? Rifampicin, clofazimine and dapsone are the three drugs that you would like to use over here. The doses will be 600 milligram per month. This is going to be rifampicin. Clofazimine 300 mg per month and 50 mg per day for clofazimine, and dapsone is going to be 100 milligram per day, right? This is going to be daily, right? This is what you will be giving this particular patient when the patient is going to come to the hospital, right? Hansen's disease, also known as this particular disease, Hansen's disease is also known as leprosy. It is the another name for leprosy, same thing, right? Clinical features are going to be, you will be having a hypoanesthetic patch or hypoanesthetic skin lesions, which is going to have less sensations will be there. You will be having certain nerve involvement will be there. Madarosis will be there. Lateral loss of eyelashes. You will be having saddle nose, claw hand. Okay, you can have foot drop, CPN because of CPN, because of ulnar nerve. You will be having foot drop, right? You will be having claw hand because of ulnar and foot drop because of CPN. So this thing can happen. These are the clinical features of Hansen's disease. Once this disease is diagnosed, you need to start the treatment, right? What is the stain that you are going to use? This stain is known as fight for aqueous stain, beta. If you are using 5% H2SO4, this is known as fight for aqueous stain. Fight for aqueous stain, right? Diagnosis you will be doing, you will be using a slit skin smear, and you are going to take the sample either from the eyebrow, from the ear lobule, from somewhere in the body, and you are going to grow this particular thing under the armadillo, 9-banded armadillo. In India we do not have the armadillo, right? So we are going to grow it under newborn suckling mice also. The target thing will be skin and peripheral sensory nerves, right? You will be having loss of A delta and C fibers, hot and cold phenomena will be there, right? Next thing we will be having what? You will be having loss of hot and cold. Next thing is going to be lepra reaction, beta. Remember, lepra reaction is due to treatment. We need to tell our patient if you have any reaction, if you have erythema, neuritis, you will be having pops of painful nodules on the body, just come back to us. Don't stop the treatment, because if you stop the treatment, this thing can get worsened, right, with time, right? So type 1 lepra reaction, we just need to make it 5, right? So you will be having type 4 hypersensitivity reaction. Whereas in the cases of type 2 lepra reaction, this is going to be your type 3 hypersensitivity reaction, right? In type 1, you will be having rhythma as well as your neuritis will be there in the patient. In type 2, you will be having erythema nodosum leprosum, where you will be having cope of painful nodules on the skin, on the body, right? The treatment protocol for both of them, this is because of the treatment. So this is a antigen antibody reaction that is happening in the body, right? It is an immune reaction that is happening in the body. So you try to decrease the immune system of the body by giving what? Steroids to the patient. You give the steroids to the patient. You can also give steroids. Along with that, you can also give one more drug, that is going to be thalidomide, which is a drug of choice for uh, this particular condition. You can use this particular drug, and this drug will be having a side effect. What is the side effect? It can lead to phacomelia, also known as C-limb deformity will be there, right? C-limb deformity will be there. What is this classification that we are having in front of us? This classification is known as Ridley-Joplin classification beta. Okay, it is going to be telling us about the TT, BT, BB, BL, LL. This is the question in your exam, last year question. They have asked what is the classification we are going to use for this particular one, and this is going to be what? Ridley-Joplin classification. We have got TT type of leprosy, we have got BT type of leprosy, we have got BB, BL and LL type of leprosy. We have divided these lesions on the basis of lesions. Like if you have got 1 to 3 lesions, slit skin smear is negative, hypopigmented plaques are there, this is going to be TT type of leprosy. BT will be having 3 to 10 lesions, most common in India. Satellite lesion you will be finding. Okay, this is going to be BT type of leprosy. You have got BB type of leprosy, where you will be having 10 to 30 lesions. Inverted saucer shape appearance will be there. I told you, inverted saucer appearance, right? Here you will be having geographical lesions also. BB क्या बोलेगी? घुमाने के लिए बोलेगी, बर्तन साफ करने बोलेगी. That is what we have discussed, right? BT कौन देता है? Indian people are going to give what? BT, and they are going to give you what? We have sent our satellite also, so you can remember satellite and BT. These two things are most common in India, right? BV is going to tell you to take you out, and she is going to have inverted saucer shape appearance will be there. BL is going to have multiple nerve involvement, but it is going to be asymmetric lesion. And last one, lepromatous leprosy, is going to have what? Symmetrical lesions. Epistaxis can be there. You can have glove and stocking hypoanesthesia will be there. You will be having leonine facies. Let me just let you just try to understand what is this particular type of lesion we are having. So we have got a lesion, and surrounding this lesion you are finding some other lesion. This is going to be known as satellite lesion. And remember, satellite lesions are the common lesion you will be finding with the BT type of leprosy. Whereas these lesions are looking like inverted saucer shape, inverted plate appearance, or you can also call it Swiss cheese appearance. This is going to be the lesion of BB type of leprosy beta, BB. Then we have got this particular one. This is going to have what? This is going to have the organism here, right? This is going to be the leonine facies we are having. We can have lateral ossophylosis will be there. Okay, you will be having what? You will be having this type of leprosy. This is going to have what? Madarosis. This is going to have what? Saddle nose. All these things will be positive. And this particular organism that we are having in front of us is known as 9-banded armadillo beta. इसका नाम क्या है? जिसका नाम है 9-banded armadillo. So we have got this 9-banded armadillo, right? Then what is this indeterminate leprosy versus you can remember Pityriasis alba. So we can have this indeterminate leprosy in the children from the endemic areas. What are the endemic areas? Where this disease is confined to a particular area. So we have got areas like Bihar, UP and Tamil Nadu, where you will be having this particular indeterminate type of leprosy. So solitary hypopigmented itchy macules over the face, you will be having a single or multiple lesions on the face will be there. Hypopigmented lesions will be there, and this is going to have itchy macule, flat lesion will be there. But remember, here scaling is going to be absent, and this is the most important line that you need to identify. This is the most important word that you need to identify over here. This is what going to differentiate between Pityriasis alba and Pityriasis alba and indeterminate leprosy. Pityriasis का मतलब क्या होता है? The meaning of Pityriasis is pretty simple. It means what? Scaling beta. So if you will be having scaling, you will be having alba means white. You will be having white color lesion with scaling. This is going to be in the favor of Pityriasis alba. So this is a child with multiple hypopigmented macules on the face. Another child with multiple hypopigmented macules on the face. Fine scaling is going to be present. This is going to be suggestive of what? Scaling, if it is present, this is suggestive of what? This is suggestive of pityriasis alba. Okay. Then we have got certain types of endogenous eczema. Sorry, this is going to be what? This is a eczema, endogenous type of eczema. This is a pityriasis thing, right? And this is going to be a type of leprosy in the children, which is a indeterminate type of leprosy you will find in the UP Bihar region, right? For diagnosis, you are going to take any like any one out of these three things, right? What is this any one, right? You will be having this any hypoanesthetic lesion will be there, hypopigmented hypoanesthetic lesion. You'll be having what? Nerve involvement. You'll be having slit smear examination positive for M. leprae. अगर इनमें से एक भी पॉजिटिव आता है, you will be taking for diagnosis, right? You will be understanding for the diagnosis. In children for 10 to 14 years, this is a previous year exam question. Remember, the doses are going to be different for children and they are interested in these doses, right? Rifampicin, you are going to give 450 milligrams per month for children. Dapsone, 50 milligrams per day for children. And clofazimine, you are going to give 150 and 50 on the alternate day, right? This is what is going to be the treatment, right? What are the side effects? You can have orange discoloration of urine. This is going to be hepatotoxic. This is going to be your rifampicin. Dapsone is going to cause what? Anemia. It is going to decrease the granulocyte count, right? And this is going to be clofazimine, which can cause ichthyosis or hyperpigmentation on the body, right? Now we have got very simple topic. This is going to be your sexually transmitted diseases. What are the sexually transmitted diseases that we can have? STDs क्या क्या होते हैं? We have got certain different types of STDs. We have got herpes simplex virus, we have got chancroid, we have got syphilis, we have got donovanosis, we have got LGV, lymphogranuloma venereum. Anytime a patient is going to come to you, you need to ask first question whether you are having a painful lesion or a painless lesion, because painful are going to be only two, right? Painful are going to be your herpes simplex virus and chancroid. And along with the painful, you can also remember these are the lesions which are going to be not single but multiple. These are the lesions which are going to be what? Not a single ulcer you will be finding what? Multiple ulcers over there. So you'll be having what? Multiple ulcers in HSV and chancroid. Whereas you will be having single ulcer or single beefy red ulcer, single transient ulcer is going to be seen in the cases, other cases, right? You will be having transient single ulcer in other cases. So sir, how we will differentiate between different kind of ulcer if a patient is coming to us? All right, I'll make you understand how you will differentiate. Okay, so you have got this particular cases. These are the different kind of ulcers we are having, right? So how you will differentiate, identify these ulcers? First of all, you need to understand herpes meaning what? Herpes means you will be having what? This is the ulcer of herpes, because herpes means what? Grouped vesicle. The only part where you will be finding grouped vesicle is going to be what? Herpes. And this is the only infection which is having what? Grouped vesicle. You will be finding grouped vesicle over here. This is going to be your herpes infection. The treatment for this particular one is going to be as cyclovir. 400 milligram TDS for 7 days. This is going to be the treatment protocol for this herpes. Right, here also you are finding multiple grouped vesicle. Are they painful? Yes. You remember just two things. Painful lesions are going to be only two important one. One is going to be herpes. Another one is going to be your chancroid. Chancroid is due to do cry. Hemophilus do cry, and do cry will always say cry. Cry means ye rota rahega, right? This is going to be the painful lesions. These are the two painful lesions we are having, beta, right? This is your another painful lesion. Here you will be having multiple grouped vesicle. Your diagnosis will be what? Herpes. Here also you are having what? Multiple ulcer. Here also you are having what? Multiple ulcer. And this multiple ulcers are the ulcer of chancroid, which is due to what? Do cry. What you need to understand for this particular one, you need to understand this is going to have what? Is here you will be having inverted margins will be there. Inverted edges, inverted margins will be there. And you will be having what? Multiple ulcers. Third thing you need to understand is going to have unilateral lymph node involvement will be there. You will be having what? Unilateral lymph node involvement will be there in this particular one, right? Another one we have got for painless ulcers, we have got two important entity. Painless can be due to syphilis, beta. Painless can be due to syphilis beta, it can be due to donovenosis. It can be due to syphilis, it can be due to donovenosis. So what you need to remember, syphilis is going to be a single ulcer. Donovenosis is going to also be a single ulcer, right? What you need to understand, for this donovenosis, they will be writing a specific term. This is going to be beefy red ulcer beta. If you have seen somewhere written beefy red ulcer, your answer will be what? Donovenosis. Okay, so now let's try to understand. Just think like that, you are sitting in the OPD, patient is coming with some kind of ulcer. If patient will say this type of ulcer, what you will suspect? What you will suspect beta? One more thing you need to understand, this LGV ulcer is going to be transient ulcer. That means till the time this patient is going to reach to the hospital, the patient will not have ulcer, right? Ulcer अपने आप चला जाएगा, ulcer बचेगा ही नहीं, right? So this is going to be having only buboes, and these buboes are going to be painful, and bilateral painful buboes will be there, right? So what you need to do, you need to understand and you need to treat your patient. If you find multiple grouped vesicle, you think about herpes. If you find another multiple ulcer, you will think about what? Chancroid. This is due to Haemophilus ducreyi. If you find single ulcer, which is going to be what? Painful, which is going to be painless and beefy red, which is going to bleed on touch, this is going to be what? This is going to be donovenosis. And lastly, you have got this particular ulcer. This is the ulcer for syphilis beta. Syphilis is going to be painless ulcer with rubbery and shorty lymph nodes. Painless ulcers with shorty and rubbery lymph nodes will be there. This is going to be what? This is going to be syphilis. This is due to Treponema pallidum. This is due to HSV. This is due to ducreyi. This is due to granulomatous, and this is due to chlamydia. Chlamydia, right? This is L1, L2, L3 strains of chlamydia. Now about the STD kits, let's try to understand the STD kits, and then we will remember all the things. So STD kits we are having. So anytime you have a patient coming with some kind of STD and you are not able to identify what is the disease this patient is having, so what we can do, we can give the patient STD kits, है ना? हम लोग क्या कर सकते हैं, पेशेंट को STD kits दे सकते हैं. अब STD kit में क्या करना है, the first time patient is going to come with some kind of urethral discharge बेटा. अगर आपके पास में कोई पेशेंट यूरेथ्रल डिस्चार्ज लेके आ रहा है, यू नीड टू थिंक अबाउट टू इंपॉर्टेंट थिंग. वन इज गोइंग टू बी गोनोकोकाई, दैट इज द मोस्ट इंपॉर्टेंट कॉज फॉर दिस यूरेथ्राइटिस, right? Another one is going to be this non-gonococcal urethritis. There are only two possibilities, important one, right? So if it is a gonococcal urethritis, you will be having this purulent discharge. You take the swab, you take the sample, you go for NIS swabbing, you can look for microscopy, you will find all those things you will be finding in the gonococci, है ना? gonococci में जो भी मिलता है, it is going to be kidney shape, intracellular, diplococci, है ना? जो भी मिल रहा है, everything will be there. This is going to be what? Gonococcal urethritis. But here we are not going to do the diagnosis, right? हम लोग identify कर सकते हैं, but here we are not going to do the diagnosis. We will ask the patient whether you are having symptoms. This is a syndromic management, right? So we are going to give this patient certain drugs which is going to take care of everything. So this is going to be gonococcal urethritis, purulent discharges there, ceftriaxone plus azithromycin we can give to this particular patient. If it is non-gonococcal urethritis, the cause will be either trichomonas, either the cause will be chlamydia. Chlamydia में कौन से strain बेटा? Chlamydia D2K strain, D2K, right? Chlamydia strains A, B, B, A and C is going to cause what? It is going to cause trichoma. D2K are going to cause swimming pool conjunctivitis. It is also going to cause non-gonococcal urethritis, right? And then L1, L2, L3 are going to cause what? They are going to cause what? This type of ulcer. This is known as LGV ulcer, right? LGV, lymphogranuloma venerum. So here you will be having mucoid type of discharge. The drug of choice will be either you can give doxy plus azithromycin. So we have developed the kit, and this kit will be having what beta? This kit will be having azithromycin 1 gram plus cefixime 400 milligram. This is the kit number 1 that we are having. This is the kit number 1 that we are having. This is the kit number 1 that we are having. Azithromycin 1 gram plus cefixime 400 milligram. Okay. If you are having something coming from the vaginal discharge, you need to look for what? You need to look for first thing candida, second thing trichomonas, third thing bacterial vaginosis. These are the three possibilities for vaginal discharge. Candida is going to be thick, wide, curdy discharge that we are going to have, and it is going to have what? Intense itching beta. Here this patient is going to have what? Intense itching will be there. So thick, wide, curdy discharge along with the intense itching is going to be what? Suggestive of candida infection. Whereas this Trichomonas vaginalis is going to what? It is a flagella which is going to have 5 flagella we are going to have, and this is going to be flagellate which is a STD. Remember beta, in Trichomonas you need to treat both the partners. It is a STD which is a trophozoite is going to be there, right? This is going to be Trichomonas vaginalis, pear shaped trophozoites will be there, right? You will not pear shape, you will be having a trophozoite will be there, right? This is going to be Trichomonas, and this Trichomonas is going to be what? It is going to cause colpitis macularis. What is this patient will be having? Strawberry vagina, strawberry cervix is strawberry vagina, right? So you will be giving this particular patient metronidazole, right? This metronidazole 7 days BD subasham, right? You can have greenish or yellowish discharge will be there. Whereas third possibility is a bacteria that is going to cause Gardnerella vaginalis, that is going to cause bacterial vaginosis, right? Here this patient will be having which cells? You will be having these clue cells will be positive. Clue cells are normal epithelial cells will be having what? This bacteria will be there. This is known as clue cells. You can do WIP test, and this WIP test is also coming out to be positive. You can check for M cells criteria. What is coming out to be positive? You will be having fishy odor beta. Fishy odor in the WIP test, this is going to be positive here, and you can give the metronidazole also here. So we can give for both of them, we can give metronidazole. This particular one we can give fluconazole. So what we are going to do, we are going to make kit number 2, and this kit number 2 will be having what? Which it will be having fluconazole, which is going to take care for the candida, whereas it will be having secondidazole. क्योंकि हमको मेट्रो तो 7 से 10 दिन देना है, right? This metro we need to give a BD सुबह शाम देना है. We are doing syndromic management, so we are going to give what? We are going to give secondidazole. Single tablet is going to be good enough. This is going to be single tablet 2 gram that we are having. This is your kit number 2. Okay, this is what is syndromic management that we are having, है ना? ये kit number 2 हो गया आपका, kit number 2, right? Then we have got genital ulcer, that is the kit number 3. अगर genital ulcer है बेटा और नॉन हर्पेटिक है, नॉन हर्पेटिक मतलब नॉट ग्रुप्ड, क्या बताया था? हर्पीस का मतलब ग्रुप. So if it is non-herpetic, it can be it can be 3 possibilities. What can be the possibilities? Either it can be syphilis, either it can be donovenosis, either it can be chancroid, right? So this syphilis and this chancroid and donovenosis, they can be treated with the help of azithromycin. They are going to show you good results with the azithromycin, and syphilis के लिए the drug of choice is going to be penicillin. So kit number 3 will be comprising of what? 2 important things. This is going to have azithromycin as well as your penicillin. This is going to be kit number 3. Another patient is coming with who requires kit number 4. He will tell you, sir, I am allergic to penicillin. मैं penicillin नहीं खा सकता, right? So this patient you need to give what? Azithromycin is okay, but penicillin case place पे you need to give what? Doxycycline to this particular patient. Another patient who is going to have what? Herpetic type of ulcers. Herpetic मतलब definitely herpes है. अगर herpes है तो क्या दोगे बेटा? herpes है तो acyclovir 400 mg TDS for 7 days. This is going to be the standard drug, right? Kit number 5 will be there. Kit number 6 is going to responsible for the PID. PID means pelvic inflammatory diseases that we are going to have, where you will be having lower abdominal pain will be there. Here it can be bacterial, it can be amoebic beta. So you can give cefixime, you can give metronidazole in this particular case, right? Buboes are going to be there. This is going to be causing kit number 7 we are going to give in the cases of buboes, where you will be having what? Lymphadenopathy can be there, right? Here this kit number 6, 7 is going to comprise of doxycycline plus azithromycin. It is used for what? We can have what? Lymphogranuloma venerum, and this is the recent advancement that we are having right now. We are having kit number 8. This is for the anorectal things, right? Here we are going to give what? Cefixime along with the doxycycline we can give in this particular one, right? For the 7 days we can give this cefixime and doxycycline, right? So we have got what? We have got this particular kit number 8. This is the latest one. We give cefixime 800 mg straight. This is 4 times of the normal dose, right? And we can give doxycycline 100 mg 14 capsules. That means for the 7 days, right? BD for the anorectal kind of discharges, right? So these are the STD kits that we are having. That this is the new one we are having, right? Earlier we used to have this 7. Now we are having what? Total 8 STD kits. This is what is something you need to add down into your notes, right? Then we have got the another chapter beta. This is going to be vesico-bullous disorder. कौन सा disorders we have got? Vesico-bullous disorder. So these are the disorder which are going to have what vesicles involved, and these are the disorder which are going to have involvement of bulla also. So you will be having involvement of vesicles, you will be having involvement of bulla, right? This is going to be vesico-bullous disorders, right? So we have got pemphigus group of disorder, pemphigus, and we have got pemphigoid group of disorders. Pemphigus is going to be a superficial disorder beta. Pemphigus is going to be, S से याद रखो, superficial disorder. This is going to be a deep disorder. I taught you how many layers in the skin: epidermis, dermoepidermal junction, and then then you will be having what? Dermis. So we already know we are not going to discuss anything about dermis, but we are going to discuss about this epidermis, and the disorder which is going to happen in the epidermis is going to be what? This is going to be your pemphigus disorder, and the disorder which is happening in the dermoepidermal junction or basement membrane zone is going to be what? Pemphigoid group of disorder, right? This is the first basic funda that you should be understanding. Here you will be having desmoglin, desmocolin involvement. Here you will be having involvement of hemidesmosomes beta. है ना, याद आ रहा है? हेमिडेस्मोसोम्स, दिस इज वन केराटिनोसाइट, अनदर केराटिनोसाइट, दिस इज डेस्मोसोम्स. It is epidermal disorder. These are going to be your hemidesmosomal proteins, and this is going to be hemidesmosomal disorder, which is going to be present on the basement membrane zone or dermoepidermal junction. So here you will be having superficial lesions. क्या होगा अगर दोनों केराटिनोसाइट्स के बीच में से क्या हट गया? डेस्मोसोम्स हट गया. Now what will happen? Two keratinocytes are binded together. Body में क्या हो जाएगा? Rupturing will be there, right? You will be having this type of skin lesions will be there on the body, right? This is going to be what? This is known as pemphigus. Here you will be having antibodies formed against desmoglin beta, है ना? Important thing that you need to remember is going to have what? Flaccid kind of bulla. दो तरीके के बुला होंगे. One is going to be flaccid. Here you will be having tense bulla beta, tense bulla. This is going to be deep lesion. Here you will be having antibodies against this hemidesmosomes, right? You will be having BPHE2, BPHE1 antibodies, and here you will be having tense bulla. Here you will be having flaccid bulla, right? Flaccid bulla इधर होगा, tense bulla इधर होगा, right? So pemphigus की बात कर लेते हैं. Pemphigus will be having what? It is going to be epidermal disorder. Flaccid bulla will be there. We have got pemphigus foliaceus, we have got pemphigus vulgaris. मैंने बताया था foliaceus is going to be first, so it is going to have involvement of desmoglin first. And here you will be having involvement of desmoglin number 3. Desmoglin number 3. What are the layers we have discussed in the epidermis? These are going to be your come, let's grab some burger beta. These are going to be corneum, lucidium, granulosum, spinosum, and basal, right? So this is a disease of stratum granulosum beta. This is the disease of stratum granulosum, whereas this is a disease of stratum spinosum. This is the disease of stratum स्पाइनोसम बेटा, है ना? ये एक स्ट्रेटम स्पाइनोसम का डिसीज है, एक ग्रेनुलोसम का डिसीज है. तो अगर ये ग्रेनुलोसम का डिसीज है, ये ल्यूसीडियम तो सब जगह होता नहीं है, तो कैन आई ऑल्सो कॉल इट सब कॉर्नियल डिसऑर्डर? यही क्वेश्चन तुमसे घुमा के पूछते हैं. दे विल बी आस्किंग यू द सेम थिंग. व्हाट इज विच ऑफ द फॉलोइंग इज गोइंग टू बी सब कॉर्नियल? तो सिंपल याद रखना, सब कॉर्नियल इज गोइंग टू बी व्हाट? It is going to be pemphigus foliaceus, which is going to be suprabasal. Can I call it suprabasal also? Stratum spinosum above the base. So it is also known as suprabasal. It is also known as subcorneal. Subcorneal, suprabasal. Right? Other things remains the same. Remember beta, one more thing. It is going to have what? Mucosal involvement. Vulgaris means most common. It is going to involve what? Oral mucosa. Oral mucosa involvement will be there. Right? Mucosa involvement will be there. This is going to be what? Mucosa involvement will be there, right? So we have got MINAR. What is this MINAR? M for mucosal involvement, I for intradermal, intraepidermal, not dermal, intraepidermal. They will be having Nikolsky positive. They will be having acanthocytes. Acanthocytes मतलब ये normal keratinocytes. They are known as acanthocytes, and they will be having row of tombstone appearance. Okay, let me make you understand what is this row of tombstone appearance, what is this acanthocyte, what are these things which are going to be positive over here. So let's begin with the signs. What are the signs you will be finding? You will be finding the first sign, that is known as what? Nikolsky positive. What is Nikolsky sign? When you apply the tangential pressure, आप जब tangential pressure लगाओगे तो ये क्या होगा? ये move हो जाएगा. This is going to rupture the skin. This is known as Nikolsky positive beta. Very important sign, Nikolsky positive, right? एब्सोहेंसन साइन क्या होता है? ऑल्सो नोन एज बुल्ला स्प्रेड साइन. व्हेन यू आर गोइंग टू अप्लाई परपेंडिकुलर प्रेशर, when you are going to apply perpendicular pressure on the bulla, it is going to get spread. This is known as what? This is known as Absoy-Hansen sign. This is known as bulla spread sign. On the histology, you will be finding this particular type of appearance. This is known as row of tombstone appearance, right? You can appreciate this appearance is also known as row of tombstone appearance. This type of appearance will be there, and this type of appearance you are also finding here. This type of appearance is known as row of tombstone appearance. This is known as row of tombstone appearance. DIF में क्या मिलेगा? You will be finding fishnet pattern. क्यों मिला fishnet pattern? Let me make you understand. Look here. This is going to be the, what is this I am making? Can you appreciate what is this layer that I am making? This is going to be what? Rete ridges. These are going to be rete ridges, and this is going to be what? This is going to be dermal papilla. This is going to be dermal papilla, right? We have nothing to do with the dermal papilla, rete ridges. We have only things to do with the epidermis, and these are the cells of epidermis. These are the keratinocytes that you can appreciate. ये सब क्या है? These are the keratinocytes, and remember these keratinocytes are binded together with the help of what? Desmosomes. They are binded together with the help of desmoglein. So what we are doing, we are putting some antibodies chain, and what is happening? We are finding that there is some antibody production. ये antibodies बन गया इसके against. You are having the formation of antibodies, and this antibody is going to give you which appearance? You will be having what? Fishnet pattern, beta. Fishnet pattern, or you will be having what? This type of appearance. This is going to be appearance of pemphigus. This is going to be the appearance of pemphigus, beta. Pemphigus, है ना? Because you will be having two keratinocytes and antibodies formed against desmoglein, and this is the desmoglein which is responsible for binding of two keratinocytes. So यहाँ पर ये एंटीबॉडी मिल जाएगा आपको. This is going to be epidermis. This is dermoepidermal junction. This junction that you can appreciate over here, this is going to be the dermoepidermal junction, है ना? ये dermoepidermal junction है, और उसके नीचे वाला क्या है बेटा? dermis है, right? So this is how you will be understanding that here you will be having antibody deposition in the epidermis, and this is going to be what? This is going to be pemphigus group of disorder. Treatment क्या करोगे? You can give steroids to the patient. You can give anti-CD20 molecule, right? Anti-CD20 molecule is going to be rituximab, right? Generally seen in patients of like 40 to 60 to 80 years of patient, they are going to be more commonly involved. Another disease that we are having is going to be, or another disease, this is known as bullous pemphigoid. Okay, this is your bullous pemphigoid, same disease. It is going to be flaccid bulla or tense bulla, beta. Remember, it is going to have tense bulla. This is going to have tense bulla. IgG deposition will be there. This IgG deposition will be there, and this IgG deposition is going to be on the BPH2 or BPH1 against, right? And here you will be having the diffuse linear IgG deposition. Why linear IgG deposition? Here you will be having epidermis above. This is your dermoepidermal junction or basement membrane zone, and then you have the dermis. तो यहाँ पर एंटीबॉडी कहाँ जमा होगा बेटा? यहाँ पर एंटीबॉडी जमा होगा इस रीजन में. Why into this region? Because this is a disease which is going to happen on the basement membrane zone. Here you will be having tense bulla बेटा. कैसे बुला होंगे? Tense bulla will be there, and treatment will be steroid. Then we have got linear IgA disease. How to differentiate this linear IgA disease? It is going to have bimodal approach. That means generally happening in less than 5 years and more than 60 years of adults, right? Here you will be having IgA deposition on the basement membrane zone. ये भी basement membrane zone पे deposit होगा, but the antibody will be different. Earlier we have discussed about which antibody? IgG. Everywhere we have discussed about IgG. In bullous pemphigoid, IgG will be there, but in linear IgA, the name itself is suggesting that it will be having what? IgA antibodies will be there, and the treatment will be what? Dapsone and steroid you are going to give, and you are going to find a string of pearl appearance or cluster of jewel appearance will be there. This type of appearance will be there. This is going to be what? Linear IgA disease, beta. Linear IgA, है ना? तो diffuse pattern you will be finding fishnet like pattern. You will see the fishnet pattern. You will mark the answer what? This is going to be pemphigus. This is going to be pemphigus. If you see the linear pattern, you think about two things. One is going to be what? One is going to be bullous pemphigoid, another one is going to be linear IgA disease. If IgA is written in the question, you go for linear IgA. If IgG is written in the question, basement membrane zone, you mark what? Bullous pemphigoid. Lastly, we have got what? Dermatitis herpetiformis. Dermatitis means inflammation of the skin. Herpetiformis means grouped vesicle, right? And this is going to be what? This is going to be rete ridges. This is going to be rete ridges that we are having, and this particular part is known as what? Dermal papilla. And can you appreciate this dermal papilla is having some kind of deposition over there, and this is known as papillary tip microabscess. Remember, in the beginning itself we have seen this papillary tip microabscess, and this is seen in the dermatitis herpetiformis. Dermatitis means inflammation of the skin. Herpetiformis means grouped vesicles. So you can appreciate here this patient is going to have inflammation of the skin, and these grouped vesicles are going to be present where? These grouped vesicles are going to be present on the extensor surface, on the hands, on the knees, right? This is going to be the thing. What is this disease is associated with? It is associated with celiac sprue, where you will be having what? You will be doing what? You will be having positivity of anti-TTG, very important, anti-TTG positive, anti-endomysial antibody, anti-gliadin antibody. These are the three antibodies which are going to be positive: anti-TTG, anti-gliadin, anti-endomysial antibody, right? And the drug of choice in this particular case is going to be dapsone, which is a sulfonamide beta, and treatment of choice is going to be what? This patient should be avoiding what? Bro, barley, rye, oat and wheat. This patient should be avoiding bro. This is going to be what? Dermatitis herpetiformis, right? Generally happening in the patients of 20 to 40 years of age. This is going to be dermatitis herpetiformis, right? What are the HLA associations? Very important. This is going to be HLA B8, HLA DQ2 and DQ8. These are the important things which are going to be asked from this particular point, है ना? तो 4 DIF की इमेजेस मैंने याद करवाई, 4 चीज़ें याद रखनी है. अगर एपिडर्मिस की बात हो रही है, एंटीबॉडी डिपोजिशन एपिडर्मिस में, your answer will be pemphigus. If you are having linear IgA, if you are having linear deposition, this is going to be what? IgG antibody. This is going to be your bullous pemphigoid. If linear deposition with IgA antibody, this is going to be linear IgA disease. Very simple, right? And lastly, we have got some pigmentary disorders beta. We have got hypopigmentation disorder and hyperpigmentation disorder, है ना? तो ये कलर कहाँ से आता है? Basically, what is the precursor for melanocyte or melanin? This is going to be your tyrosine. It is going to make melanosomes. Melanocytes are going to make melanosomes, and they are going to make what? Melanin. We can have eumelanin, we can have pheomelanin. U is going to give you black or brown color, whereas pheo is going to be responsible red or yellow color. So we have got some hyperpigmentation disorder. Hyperpigmentation disorder, let's begin with the first one that we have got. This is something you will be having hyperpigmentation around the face, around the nose. This is going to be known as melasma. If the same thing is happening in the pregnancy, this is what is known as what beta? This is what is known as cloasma. The same thing is happening in the pregnancy, we call it cloasma, right? ये macule है, macule क्यों बोला? Macule is a small lesion, flat lesion को क्या बोलते हैं बेटा? Macule बोलते हैं, right? This can be due to OCP uses, right? Again, the same kind of sign that you will be finding. This sign is known as what? Chick sign, that you will be finding in one disease. Previous year question है. This is what you will be finding in one disease, that is known as chikungunya. चिकनगुनिया से कोई पेशेंट मरता है क्या? नो पेशेंट इज गोइंग टू डाई बिकॉज ऑफ चिकनगुनिया, एंड द ट्रीटमेंट रिमेन्स व्हाट? symptomatic treatment, lots and lots of water you need to give to your patient will be fine, right? So this is going to have chick sign में ऐसा फोटो देंगे, ये दोनों नहीं देंगे. यहाँ पर थोड़ा सा excessive melanin deposition was there. This is going to be your chick sign. Okay, excessive melanin deposition. Second thing we have got is going to be Mongolian sport बेटा. मंगोलियन स्पोर्ट में पेशेंट को क्या बोलना है, कितने दिन में ऑपरेट करना है इस पेशेंट को? Remember, Mongolian sport is something that you will be having ceruloderma. This is going to be some lesions on the trunk you will be finding, right? What to tell to patient? We need not to treat this within 1 year. This is going to be a self-limiting thing. It will go away within a year, right? This is going to be your Mongolian sport. Then we have got nevus of Ota. O से याद रखना है, O for ophthalmic part, right? This is going to be involving the eye. O से ophtha याद रखो, O से eye याद रखो. This is going to be nevus का मतलब होता है discoloration, hypercoloration will be there, right? You will be having hyperpigmentation will be there, and this is going to have what? Unilateral hyperpigmentation. Sclera, 1/3 of sclera will be involved here. Sorry, 2/3 of sclera will be involved here. You will be having involvement of V1, V2 and trigeminal nerves will be there, right? This is going to be nevus of Ota. अगर इसी सेम नीवस में, नीवस मीन्स डिस्कलरेशन, यू विल बी हैविंग हेयर ग्रोथ, बाल आ गए, बी से याद रखो, अगर इसमें बाल आ गए तो दिस इज नॉन एज व्हाट, दिस इज नॉन एज बेकर्स नीवस बेटा. इट इज नॉट कंजेनाइटल वन, इट इज एक्वायर्ड वन, है ना, ये बाद में हो सकते हैं, किसी को भी हो सकता है, दिस थिंग कैन हैपन. दिस इज गोइंग टू बी यूनिलेटरल हाइपरट्राइकोसिस, दिस इज गोइंग टू बी डिपेंडेंट ऑन द एंड्रोजन बेटा, एंड्रोजन डिपेंडेंट है, you can have this particular type of thing. This is going to be nevus of Baker's, right? This is Baker's nevus. Acanthosis is nigrigens is going to be what? Acanthosis, acanth मतलब होता है spine. So spinosum layer का hardening is known as thickening of stratum spinosum is known as what? Acanthosis. और अगर ये black color दे रहा है, that is what is known as nigrigens. This is going to be acanthosis nigrigens. क्या रगड़ने से ठीक हो जाएगा? नहीं होगा, बहुत नीचे. Stratum corneum, lucidium, granulosum, then spinosum. वहां पर thickening हो रहा है. Right, so that is the thickening of stratum spinosum known as acanthosis nigrigens. It is an internal marker for diabetes mellitus. It is an internal malignancy marker also. Right, you have got nevus of Ito. Eat कहाँ कंधे पे उठाते हो, you can remember like that. You will be having nevus of Ito. Subclavicular nerve will be involved. Lateral branch of cutaneous nerve will be involved. Here you will be having discoloration over here. This is going to be nevus of Ito, है ना. तो ये basic nevus we have done with the nevus, cloasma we have done with the melasma, right. Now the next thing we are going to discuss is about the hypopigmentation disorder. What are the hypopigmentation disorder we have got? We have got first one is pyabaldism beta. Pyabaldism, remember it is a autosomal dominant thing, है ना. आजकल तुम्हारे क्या क्वेश्चन पूछते हैं, दे विल बी आस्किंग यू विच वन इज एक्रोफेशियल, विच वन इज वल्गैरिस, विच वन इज यूनिवर्सल. एक फोटो दे देंगे और पूछेंगे कौन से टाइप का विटलिगो है, राइट. सो वी नीड टू अंडरस्टैंड विच टाइप ऑफ विटलिगो, हाउ वी विल आइडेंटिफाई. लेट मी मेक यू अंडरस्टैंड. सो वी हैव गॉट व्हाट, वी हैव गॉट पायाबाल्डिज्म बेटा. इट इज गोइंग टू हैव व्हाट, व्हाइट फोरलॉक्स. ये देखो ये व्हाइट फोरलॉक्स इंदिरा गांधी को भी था. दिस इज द पायाबाल्डिज्म दैट वी विल बी हैविंग. This is going to be autosomal dominant condition, and here you will be having what, problem with the melanocytes. Remember beta, I told you melanocytes are going to make what, melanosomes, and then melanosomes are going to impart color to multiple keratinocytes. One melanocyte is going to give color to how many keratinocytes beta? Yes, that is going to be one melanocyte to 36 keratinocyte. Then we have got different types of vitiligo. Very simple vitiligo. Vitiligo is a autoimmune condition beta. Autoimmune condition, and here you will be having involvement of T helper cells which are going to inhibit what. यहाँ पर देखो कहाँ प्रॉब्लम हो रहा है बेटा, यहाँ पर मिले. They are going to ask you question from here. In pyabaldism you will be having absence of melanocyte migration from the neural crest cells. melanocyte बनते कहाँ पर है, न्यूरल क्रेस्ट सेल्स में, और फिर कहाँ आते हैं आपके उस बॉडी के अंदर से स्किन के अंदर आएंगे. सो हियर यू विल बी हैविंग प्रॉब्लम विद द माइग्रेशन. सेकंड थिंग वी आर हैविंग विटिलिगो विल बी हैविंग प्रॉब्लम विद द इनिबिशन ऑफ मिलेनोसाइट. अगर मिलेनोसाइट्स नहीं है तो क्या मिलेनोसोम बनेगा? नहीं बनेगा. क्या मिलेनोसोम नहीं बनेगा तो क्या मिलेनिन बनेगा? मिलेनोसाइट नहीं है, मिलेनोसोम नहीं बनेगा, मिलेनिन नहीं बनेगा. क्या कलर इम्पार्ट होगा? ब्लैक ब्राउन कुछ भी नहीं, कलर इम्पार्ट नहीं होगा. नाउ इट कैन बी लोकलाइज्ड, इट कैन बी जनरलाइज्ड बेटा, है ना. लोकलाइज में क्या याद रखना है, इट कैन बी फोकल. कोई भी एक पर्टिकुलर जगह पर कोई भी डिसीज हो रही है, दैट इज गोइंग टू बी फोकल, है ना. जैसे एपिलेप्सी में भी पढ़ते हैं कोई ना कोई फोकल एपिलेप्सी, मतलब कोई ना कोई फोकल सीजर, कोई ना कोई स्पेसिफिक फोकस से सारा चीज जनरेट हो रहा है. दिस इज गोइंग टू बी फोकल वन, राइट. सेगमेंटल में क्या होगा, हियर यू विल बी हैविंग थोरेसिक सेगमेंट, कोई ना कोई एक सेगमेंट इन्वॉल्व होगा. देयर विल बी इन्वॉल्वमेंट ऑफ नर्व, है ना, कोई भी एक नर्व का सेगमेंट, कोई भी एक डर्मेटोम इन्वॉल्व होगा. दिस इज गोइंग टू बी सेगमेंटल विटिलिगो. तो फोकल और सेगमेंटल याद रख लेना. दिस इज गोइंग टू बी फोकल, दिस इज गोइंग टू बी सिंगल सेगमेंट विल बी इन्वॉल्व. जनरलाइज्ड में क्या होगा बेटा, जनरलाइज्ड में यू विल बी हैविंग बायलेटरल लीजन्स. कैन यू अप्रिशिएट, यहाँ भी दोनों साइड है, यहाँ भी दोनों साइड लीजन है, और यहाँ तो पूरा ही लीजन में, राइट. सो वी कैन हैव एक्रोफेशियल इन जनरलाइज्ड. एक्रोफेशियल मीन्स यू विल बी हैविंग इन्वॉल्वमेंट ऑफ एक्सट्रीमिटीज विल बी देयर, right. Involvement of extremities will be there and facial involvement will be there. This is acrofacial. Vulgaris is going to have most common involvement. दोनों साइड देखो क्या bilateral है, symmetrical है. Yes, bilaterally symmetrical है, mostly parts में हो रखा है. This is going to be generalized. This is going to be vulgaris. Vitiligo, vulgaris, most common type of vitiligo. Third one, this is vitiligo universalis. Most of the body will be having what? Vitiligo. Don't confuse this particular thing with the एल्बिनिज्म. अभी दिखाता हूँ एल्बिनिज्म क्या होता है. एल्बिनिज्म विल बी हैविंग व्हाट बेटा, एल्बा का मतलब होता है व्हाइट, एल्बा का मतलब होता है व्हाइट, राइट. सो हियर यू विल बी हैविंग प्रॉब्लम विद द इनहिबिशन ऑफ मिलेनोजेनेसिस, यहाँ पर क्या नहीं बन पा रहा, मिलेनिन नहीं बन पा रहा, क्यों नहीं बन पा रहा, टायरोसिनेज की एक्टिविटी प्रॉब्लमेटिक है, राइट। टायरोसिन इज गोइंग टू मेक व्हाट, मिलेनिन, है ना। टायरोसिन से क्या बनता है बेटा, मिलेनिन बनता है। और चाय दूध में क्या, चाय में क्या होता है, यू ड्रिंक ब्लैक कॉफी, टी, दे विल बी हैविंग व्हाट, टायरोसिन, लॉट्स ऑफ टायरोसिन विल बी देयर। इसलिए तो घर वाले बोलते हैं ना, काले हो जाओगे ज्यादा चाय पियोगे तो, सो यू विल बी हैविंग व्हाट, tyrosin. Tyrosin is going to make what, melanin. So this tyrosinase enzyme that we are having is going to be problematic in albinism. तीनों का पैथोलॉजी अलग है बेटा, है ना। मिलेनोसाइट्स यहाँ पर होगा, मिलेनिन यहाँ पर नहीं होगा। क्यों नहीं होगा, क्योंकि टायरोसिन वाला प्रॉब्लम है। तीनों का पैथोलॉजी अलग है। दिस इज पायाबाल्डिज्म, दिस इज विटिलिगो, दिस इज एल्बिनिज्म। ओके, डोंट कंफ्यूज बिटवीन दीज थ्री थिंग्स एंड ट्रीटमेंट. So now let's discuss about the treatment. We give the steroids to the patient, we can give tacrolimus to the patient, we can give phototherapy to the patient, है ना। phototherapy दे सकते हैं, steroid दे सकते हैं, tacrolimus दे सकते हैं in the patients of what, in the patients of vitiligo, right. Then we have got some hypopigmented other disorders that we are having. This is going to be your nevus depigmentosis, where you will be having problem in transfer of melanosomes beta. Problem in transfer of melanosomes, this is your nevus depigmentosis. Okay, melanosomes का transfer में issue आ रहा है. Nevus anemicus is going to be a white patch that you will be finding because of vasoconstriction. Vasoconstriction की वजह से होगा. Melanocyte destruction कब होगा? In the bindi. If you are applying bindi or due to rubber chappal, right? You will be wearing slippers of rubber. You will be having bindi leukoderma. This is bindi will be having butyl phenol. B से B याद रखो. Para-tertiary butyl phenol, and this rubber will be having what, monobenzyl ether of hydroquinone beta. Monobenzyl ether of hydroquinone will be there, rubber, right. Then we have got what, eczema beta. Eczema is going to be the inflammation of the skin. We have already seen dermatitis को क्या बोलते हैं, eczema बोलते हैं, right. We have got multiple types of dermatitis. We have got acute dermatitis, we have got chronic dermatitis. So acute cases में क्या होगा, you will be having what, erythema, you will be having edema, you will be having crusting. यहाँ तक ठीक है. अगर आपने उसको बार बार रब किया, itching किया, what is going to happen, it will convert into secondary lesion, that is going to be your lichenification. Lichenification will be having color change will be there will be itching, there will be erythema, there will be changes in the color, है ना, discoloration will be there, right, hypertrophy हो जाएगा. This is going to be the acute and chronic classification. Then now discuss about the eczema. We can have two types of eczema. Majorly we can have exogenous, we can have endogenous eczema. ये समझना जरूरी है. Exogenous is going to be causing what, contact dermatitis. It is coming out from the outside. Exogenous मतलब बाहर से कुछ ना कुछ हो रहा है, right. This is going to be because of clothes, because of something. This is because of nickel, multiple things. Detergent we are having, lots of things we are having, right. So we can have two types of contact dermatitis. We can have contact dermatitis, remember beta, this is a type 4 hypersensitivity reaction, है ना. So we can have two types of contact dermatitis. We can have due to irritants, due to allergens. So we can have irritants are going to cause non-immune response. Immune response की ज़रूरत ही नहीं है, टिश्यू डैमेज हो जाएगा, डिटर्जेंट की वजह से हो सकता है, डाइपर की वजह से हो सकता है. दिस इज गोइंग टू बी irritant type of contact dermatitis. Second contact dermatitis is because of allergens. Here you will be having type 4 hypersensitivity reaction. याद रखना, atopic dermatitis is type 1 hypersensitivity, contact dermatitis is type 4 hypersensitivity reaction. Diagnosis कैसे करोगे, type 4 है तो पैच टेस्ट करा लो इस पेशेंट का, and you will be avoiding the triggers here, right. You can use what can be the allergens. You can have metals, you can have dye, you can have plants. These are the allergens which are going to cause the disease. Okay, this is about the exogenous type of dermatitis that is going to happen from outside. This is exogenous type of dermatitis. Endogenous type of dermatitis is going to be seborrheic dermatitis. We have got what dermatitis beta, seborrheic dermatitis. This is also known as dandruff, है ना. ये dandruff हो जाता है सिर में. This is the dandruff that you are having. We have got pityriasis alba. मैंने बताया था व्हाइट कलर का एक पैच हो गया स्किन के ऊपर. स्केलिंग विल बी प्रेजेंट, है ना, फाइन स्केलिंग. You can have nummular dermatitis, you can have atopic dermatitis. I'll show you all the images, है ना. अभी एक बार समझ लो फिर images करते हैं, right. So it is going to be type 1 hypersensitivity reaction. Atopic dermatitis जो होता है ये type 1 है. Contact dermatitis जो है ये type 4 hypersensitivity reaction है, right. This is going to be type 1 hypersensitivity reaction. What is the triad for this atopic dermatitis? You can have rhinitis, asthma, dermatitis. This is going to be the triad for this atopic dermatitis. एंड क्राइटेरिया के ऊपर क्वेश्चन है, व्हाट इज द क्राइटेरिया यू आर गोइंग टू फॉलो फॉर अटोपिक डर्मेटाइटिस, दिस इज नोन एज हैनिफन एंड रच का क्राइटेरिया. कौन सा क्राइटेरिया बेटा? हैनिफन एंड रच का क्राइटेरिया. इंपॉर्टेंट क्वेश्चन. You will be having what? You will be having Denny Morgan fold, you will be having white dermatographism on the skin, you will be having Herpes sign positive lateral one third loss of one third of eyebrow will be there. This is Herpes sign positive will be there. Treatment क्या करना है? It is a hypersensitivity reaction. You give what? Steroids to the patient. Patient will be fine, right? So let's try to understand the different types of dermatitis that we are having. Let me just try to recap it for you. Right, so this is the allergic contact dermatitis which is happening because of anklet beta. Anklet जो लोग पहनते हैं, निकल का anklet जो लोग पहनते हैं, anklet is going to cause what? This type of dermatitis, है ना, जो पायल वगैरह पहनते हैं उनमें ये चीज़ें हो सकती है. This is a type of contact dermatitis, and most common agent which is going to cause contact dermatitis is going to be what? Nickel. This is going to be your atopic dermatitis, which is a type 1 hypersensitivity reaction beta. Irritant dermatitis, it can be due to detergent also. Irritant में हम लोग ने contact में पढ़ा था, detergents can be there. And this is osteotic or winter eczema that we were having, right? यहाँ पर आपको patient को lactocalamine दो, है ना, to prevent what? To prevent lichenification. This is your coin like or nummular dermatitis that we are having. Skin, these are your inflammation of the skin, nothing, है ना, inflammation है. ये न्यूरोडर्मेटाइटिस हो गया. दिस इज गोइंग टू बी पेरिओरल डर्मेटाइटिस. एनी टाइप दिस डर्मेटाइटिस कैन हैपन, राइट? दिस इज योर सिबोरिक डर्मेटाइटिस which is going to be having what? Crapping, right? This is your seborrheic dermatitis, this is your seborrheic dermatitis, right? All of them are having what? Same thing. This seborrheic dermatitis that is happening in the baby is due to what? It is due to maternal androgen beta. It can be fungal also, like malassezia is going to be causative agent for this particular one, right? This is your patch test where you are going to take the results within 48 to 96 hours. Then we have got what? Then we have got about the urticaria. What is urticaria beta? Urticaria is dermal edema. You will be having edema. It is characterized by most characteristic lesion is going to be wheals. What are wheals? आपको जैसे मच्छर काटता है, you will be having what? You will be having release of histamine leading to vasodilatation, leading to what? Erythema, leading to what? Edema, leading to what? Itching. Three things will be there: erythema, edema and itching. This is going to be the characteristic feature. Itching will be there, erythematous matlab लाल lesion will be there, edema will be there, है ना. This is going to be a blanchable lesion. You put the diascopy, it will be blanching. This is going to be a blanchable lesion. It can be due to drugs, it can be due to peanuts, it can be due to pollen, it can be viral. Urticaria is very common and it is going to have not very specific treatment we are having. We just give stabilizers like mast cell stabilizers to the patient. We give over the counter medications like antihistaminics, right? That is going to be urticaria beta. Dermographism is going to be positive and you will be having appearance of wheals will be there. We can have cholinergic urticaria. Cholinergic urticaria मतलब जब भी आपकी cholinergic activity बढ़ेगी, जैसे you will be having, you go to outside, you will be going to the sun, you will be eating hot spicy food, you can have this wheal appearance on the body, right? It is a common thing that can happen after eating what? Certain things, you can have this particular thing, है ना. So what is the treatment? Nothing but you give what? Antihistaminics to the patient. What is this urticaria pigmentosa beta? Urticaria pigmentosa is going to be cutaneous mastocytosis. यहाँ पर क्या हो जाएगा? मास्ट सेल बढ़ जाएगा. मास्ट सेल बढ़ गए तो क्या? हिस्टामिन बढ़ जाएगा. Here you will be having child with multiple hyperpigmented lesions due to increase in mast cell proliferation. And what you need to give this patient? Mast cell stabilizers you need to give. नहीं तो क्या होगा? पेशेंट में क्या होगा? मास्ट सेल रप्चर होंगे. यू विल बी हैविंग रिलीज ऑफ हिस्टामिन, यू विल बी हैविंग मल्टीपल itchy lesions will be there. You will be having positivity of this Derriere sign where you will be having erythema plus urticaria. Both the things will be there and you will be giving treatment. So mast cell stabilizers, this is going to be nidocromil. You can also use sodium chromoglycate, right? Sodium chromoglycate, right? This is the treatment that you can use. Then we have got, lastly we have got certain miscellaneous topics, and we are done with the important things. Now we will discuss about the certain miscellaneous topics. So we have got the first thing we have got is this particular cell in front of us. This is known as Sézary cell beta. This is going to have cerebriform nucleus and Sézary cells, and this is going to be very characteristic of what? Mycosis fungoides, which is a cutaneous T cell type of lymphoma, and it is going to cause which abscess? Pottier's microabscess will be there, right? Cutaneous T cell lymphoma, it is going to show you epidermotropism, that means it will travel towards the epidermis. This patch test we have already seen, 48 to 96 hours you will be checking. This is your Harlequin BB, and the gene involved is going to be APCA12 ABCA12 gene, very important, right? This has been asked. Colloidian BB, right? This is going to be your unilateral involvement, multiple grouped vesicle. This is going to be herpes zoster. Treatment I have already explained you, right? This is your dermatomyositis. Dermatomyositis, here you will be having what? Which sign? Heliotrope rash. There will be a rash around the eyes will be there. This is going to be known as what? Heliotrope rash, right? Dermato means skin involvement, myo means muscle involvement, itis means inflammation will be there. So you will be having inflammation of skin, muscles, and all the things will be there. You will be understanding this particular thing. Where we wear the shawl, you will be having some types of erythema. This is known as shawl sign positivity. This is going to be shawl sign positive. And Gottron sign or mechanic hand is going to be something you will be finding over here, right? What is this? Lesions you will be finding this type of lesions. These type of lesions you will be finding. These things are known as Gottron's papules. These things are known as Gottron's papules, and you will be having what? Mechanic hand. Why mechanic hand? Because of hyperkeratosis beta. Hyperkeratosis, you will be having this hand is looking like a mechanic hand, and a hyperkeratosis. These are the Gottron's papules that we are having. You'll be having involvement of shawl sign will be there. You'll be having heliotrope rash. Okay. Then we have got this basal cell carcinoma or squamous cell carcinoma. This is going to be basal cell carcinoma, also known as rodent ulcer. It is normally very easy to treat. You can just excise this particular thing out and easily treat it, right? What about this particular melanoma one? It is going to be very difficult to treat. Squamous cell carcinoma, if you diagnose it early, it will be easy to treat, right? If detected early, it will be easy to treat, right? But if this melanoma is there, it is going to be very difficult, right? It is going to be very problematic, and that is why we will make a differentiation between melanoma versus mole, right? We are going to differentiate melanoma versus mole, and they have asked you question based on this, and how you will differentiate a melanoma from the mole with the help of this ABCD, your previous year exam question, right? So this is how you will differentiate a melanoma versus mole. Remember beta, melanoma is going to be asymmetrical. It is going to have abnormal borders. It is going to have abnormal changes in the color. It will be having increasing the diameter more than 6, right? And it will be evolving and changing the shapes or size. These are the common things, but you need to remember the ABCD. A for asymmetry. They will write you all of the following are the ABCD of differentiation of melanoma versus mole, and they will be writing you something else. A for asymmetry, B for border, C for color, D for diameter, E for evolving beta. Okay, then we have got what? Then we have got this particular one. This is known as xeroderma pigmentosa. Xeroderma pigmentosa, which is a nucleotide excision repair defect beta. Nucleotide excision repair defect, which is characterized by photophobia. Freckles will be there on the cheeks. This patient will be having freckles on the cheeks, right? This patient will be having increased the risk of cancer also. You will be having more risk of cancer in this particular patient, right? Now we will discuss about certain allergens and their sources. What are the allergens and what are the different sources we are having? Like we have discussed about the nickel. Nickel is going to have coming from the artificial jewelries beta. Jeans button, this is going to cause what? Allergic contact dermatitis. Chromium is going to be present in the cement beta. Parthenium is going to be present in the plant. Okay, PPD in the hair dye, neomycin in the topical medicine, latex and rubber in the gloves, and PTBP, you can remember B for bindi. This is going to be a contact dermatitis that we can have because of this particular para-tertiary butyl phenol, right? Then we have got what? Then we have got genodermatosis. Then we have got what? Genodermatosis, right? We have got this adenoma sebaceum. And this ash leaf macule. Remember this ash leaf macule is, they are the suggestive of what? They are suggestive of tuberous sclerosis. What is the chromosome involved in tuberous sclerosis? Very important. TSC1, chromosome number 9 and 16, and genes are going to be TSC1 and TSC2. What is that Vogue stride we are having? This is going to be what? Epiloa. E for epilepsy can be there. L for low IQ, and A for adenoma sebaceum. Adenoma sebaceum is going to be there. Okay. Chagrin patch is going to be positive. This is going to be what? Chagrin patch that you can appreciate. This is going to be what? Xenodermatosis 1. This cafe alute macule you will be finding, right? This is a finding you will be having what? In neurofibromatosis, right? Chromosome number 17 is going to have which neurofibromatosis? This is going to be in NF1. And chromosome number 22 will be having what? NF2, which is going to have bilateral vestibular schwannoma, which is a most common cerebropontine angle tumor, right? In eye you will be finding some nodules. These are known as leash iris nodules. These are known as leash iris nodules, right? Now some one liners that we have got lastly, these are going to be your fixed drug eruption. Fixed drug eruption is a type 4 hypersensitivity beta. It can be due to certain drugs, NSAID, it can be due to cotrimoxazole, tetracycline. Treatment will be what? Just avoid that drug. Whatever drugs we are having, just avoid that drug. Okay. What is the erythema multiforme? It is going to be cytotoxic dermatitis, right? It is associated with HSV type 1, herpes simplex virus type 1. Here you will be having multiple target type lesions on the palms and soles. You will be having this type of lesions on the palm and soles. Target lesions will be there on the palm and soles. Next one is your erythema chronicum migrans. This is generally seen with the Borrelia burgdorferi, which is going to cause which disease? Lyme's disease. And we've also discussed this thing in micro. Xanthalisma is what? You will be having this lesion, this type of hyperlipidemic lesions. These lesions are going to be symmetrical, and this type of papules when you are finding, this is going to be known as xanthalisma. This is suggestive of what? Hyperlipidemia in the body, right? Hyperlipidemia in the body. You can find these lesions very commonly. This is your phrynoderma, which you will be finding with the vitamin A deficiency beta. Phrynoderma, toad-like skin, phrynoderma, toad-like skin will be seen with the vitamin A deficiency. This type of hyperkeratotic papules you will be finding in the around the elbow. Don't confuse this particular with the lichen nitidus. Hai? This one is your erythema nodosum. Red color nodules will be there in the anterior aspect of the leg, right? This is commonly associated with which infection? Streptococcus beta. It is associated with the streptococcus infection. Then we have got necrobiosis diabetic lipodica diabeticorum. This is something you will be finding plaques on anterior aspect of the legs. This type of plaques on anterior aspect of the legs, this is going to be necrobiosis lipodica diabeticorum, right? And then we have got cutis marmorata. Cutis marmorata is going to happen in response to cold. This is your previous year question, last year exam question, right? This type of appearance you will be having. This is happening because of in response to the cold, right? And this thing is known as what? Marbling of the skin beta. This is going to be what? Marbling of the skin that we are having here. This is known as cutis marmorata. This is known as cutis marmorata. This is the marbling of the skin in children. This is known as cutis marmorata. And lastly, we have got what? Acrodermatitis enteropathica beta. Acrodermatitis enteropathica, which is a autosomal recessive condition, and this is due to zinc absorption, right? Here you will be having issues with the zinc absorption, right? You will be having, right? You will be having this type of baby. This type of baby will be having dementia, dermatitis, diarrhea. These things can be positive, right? This is going to be acrodermatitis enteropathica beta, right? So with this thing, we are done with the rapid revision of dermatology. If you have not done anything, this is going to be good enough for you, right? Be stronger than your excuses. This is the last quote that we are having. If you have any difficulties, you can always come back to me on my Instagram, on my Telegram. You can join me on my Instagram and Telegram. I hope this is going to be fruitful for each one of you. Okay, let me summarize what we have discussed in this particular session, what we have discussed. Let me summarize. So we have started off with the basics of dermatology, where we have seen about the different layers of the skin, right? What are the basic investigations we are having, multiple things we have seen about the basics. We learned about the basics. Then we have seen in the skin appendages the disorders of nails, hairs and glands we have seen, right? Then we have discussed about what? Then we have discussed about the Papulosquamous disorder, where we have learned about the papulous disorders and squamous disorder. What are the papulosquamous disorder we have discussed? We have discussed about the psoriasis, we have discussed about the lichen planus, we have discussed about the pityriasis, rosacea, lichen nitidus. These are the disorders we have discussed. We have discussed about certain infections like bacterial infection, viral infection, fungal infection, parasitic infections, right? In STD we have seen 5 types of different ulcers we are having in STD kits. Total 8 types of STD kits we are having, right? Then we have discussed about the vesico-bullous disorder, where we have seen what is a vesicle, what is a bulla, and we have learned about the pemphigus group of disorder, we have learned about the bullous pemphigoid group of disorders, and then we have learned about the disorders like herpetitis, dermatiformis, linear IgA disease, right? Then we have discussed about the hypo and hyperpigmentation disorder. Hypo and hyperpigmentation disorder, we have learned about the urticaria, we have learned about multiple diseases also, right? So this is what we have done in the miscellaneous topics. We have learned about urticaria, atopic dermatitis, contact dermatitis, right? All these things we have covered, right? So with this thing, thank you so much for all the patience, right? For all the patience. See you in the next class. Best wishes. Take care.